Hello, can you hear me?
Good morning there, Stopdown. Yes, I hear you.
Nicholas, good morning. How are you?
Thanks, good. Great to
I
see you.
think same here. So I think we should be starting now. I'm waiting for somebody to tell me we start.
Yeah, I think we can start
Yeah.
already.
Yeah.
Yeah.
Okay. Well, a very good morning and warm welcome to all of you to the day 2 of the 5th International Conference on Integrated Control of Tuberculosis in Central Asia. A brief introduction about myself. My name is Stobdan Kalon. I'm the Regional TB Advisor for the Etika project in Central Asia. I'm going to do a quick recap of yesterday's sessions, and then we give the floor for the presenters to begin the day 2. So to give you an overview of yesterday's presentations, we had a wonderful beginning to the conference yesterday. To begin with, we had a very informative and excellent presentations in the plenary, which gave us the global and the regional context, and reminding us that TB still remains such a big challenge. And then we talked about, while there has been a gradual decline in TB globally, but the overall burden is still massive, and it still remains the #1 killer in the world. However, drug-resistant tuberculosis continues to be alarming, and particularly in the Central Asian region and the Eastern European and the Central Asian region, the most of the high-burden countries come in this region. The other thing that came up in the presentation yesterday was it was highlighted that TB still remains highly underfunded. There's a huge funding gap that remains in TB, and which has been further aggravated because of the COVID pandemic. And also, as the most countries are now expected to step up the level of domestic funding, we see that most of this initiative that has happened is still mainly happen in the BRICS countries. So meaning that other countries, there's a lot for other countries to do in terms of stepping up the domestic funding for TB. And then with regards to the progress on the UN high-level meeting targets, we are far from reaching the targets, and there's still a lot to be done. While there's some work is being done, but it's not enough, and there's a lot of work to be done ahead. And then we had, in the last 1.5 years, been confronted with an unprecedented scale of public health catastrophe in the shape of the COVID pandemic, which has disrupted every aspect of our life. Healthcare services have been disrupted, and TB among them have been one of the most affected aspects of health services around the world. And we've seen that huge losses have the countries had to bear losses over the gains made on TB progress. And it will take a lot of efforts to catch up with those losses. Sorry. And then Sevim highlighted the great support that the USAID provides globally and particularly in the region. And through the Global TB Accelerator to end TB to leverage additional resources, whereby helping UN target treating 400 million people with TB by the year 2022. And then USAID's, we heard about the USAID's recovery support for TB programs in the most acutely affected countries where the TB programs have been acutely affected by COVID globally. And then we heard about a lot of ideas how to capitalize on the opportunities arising due to the COVID challenges. And then we heard about from the host country's program manager, Professor Parpaiva, about the she gave a very nice historical overview of how the country has been developing and rolling out its strategies and roadmap to eliminate tuberculosis. She very nicely highlighted the fact that TB services need to be patient-centered, holistic, and there needs to be a multi-sectoral approach to address TB comprehensively. And the country continues to be at the forefront of combating TB through innovations and pioneering work. And yes, indeed, with her charismatic and capable leadership, the country is moving forward. Then we saw some wonderful presentation about the significance and the role and the significance of the civil society organizations by Paul and Yulia. They spoke about how we should be tapping the potential of engaging the civil society organizations in order to have equitable, people-centered, inclusive, and effective programming for TB services. And then and to strengthen all aspects of TB care comprehensively. It not only adds quality, but also ensures a genuine people-centered care in TB programs. They highlighted the fact that there is a need for serious and genuine engagement of the community in the civil society. There is also the message that they've highlighted. There's a need to create funding for the civil societies to also allocate adequate funding for the civil societies to do meaningful work. With regards to the diagnostics, we saw that the national, while there are a lot of developments happening in the field of TB diagnostics, as we all know, a lot of promising, exciting tests coming up. The national reference labs of the regions have been they have continued to grow in capacity with great support coming from the Gauteng supranational lab for the region. While conventional testing diagnostic methods are being strengthened, new game-changing tests like the sequencing tests, which shows a great promise to transform TB diagnostics in the near future, are being starting to be implemented in the region, and we'll see these coming to its full potential in the near future. We also see in the laboratory, in the field of diagnostics, pioneering work related to the DSTs for the new drugs also happening. So that's very useful, particularly with the context of the rollout of the new drugs and the shorter regimens. And then we heard from the representatives of the TB programs in the region, the progress and they have achieved, and the challenges they're confronted with, and how they are coping up and finding ways forward. As we all know, the countries of the region are highly burdened with TB and drug-resistant TB, and also legacy and the remnants of the obsolete Soviet-era policies and practices. The NTPs of the region continue to make great efforts to adopt modern methods and policies. We see big progress being made in the implementation of the shorter regimens like MSTR with support of WHO and partners like USAID on the ground. We see in Kazakhstan, Tajikistan, Uzbekistan, the MSTR is being implemented. At the same time, other shorter regimens like the BPAL, TB Practical, and NTB in the different countries are also happening. And also initiatives for preventive TB treatment is also starting to happen, although it's early days and much needs to be done in that regard. And then, yeah, there was again. It's noteworthy to see how the region has actually responded to the COVID pandemic. The programs have shown great resilience and adapted to prevent further losses due to COVID. And we saw several innovations coming out in the programs to cope up, which has actually given rise to solutions for the going forwards. Particularly the use of community volunteers, adapting TB services, improved infection control, bidirectional testing of TB and COVID, use of digital technologies not only for patient support, but also for carrying out activities like consiliums conducted online, trainings being conducted to healthcare workers. So that's something really great, and we need to embrace it going forwards. The technology, use of technology. And also, the NTPs are in the process of developing their national strategic plans and developing, strengthening their roadmaps to achieve the WHO, NTB, and the UN high-level meeting targets. And it was also interesting to hear about the technologies like computer-aided diagnosis and artificial intelligence. So this is something really great. We know that some of the countries are already going to be initiating pilot initiatives for these interventions. So all these informations, discussions yesterday, it very nicely sets the stage for the day 2, and I hope you will have a day 2 which is engaging and as informative as yesterday. And without taking more time, I wish you a great day ahead, and over to our session moderators. Thank you.
Thank you, dear Stopdown. Good morning, dear colleagues. Здравствуйте, доброе утро, коллеги.
Good morning, colleagues. Good morning. My name is Nicholas Nasidze, and I have the honor to moderate today's session, today's plenary session. And first off, I would like to express my thanks to the organizers of this very conference, which is really important and very interesting. Just like Stopdan mentioned earlier, the first day was very, very useful, very informative, and I hope hopefully second day and all other remaining days will be as successful as the first day. Now, as for today's plenary session, together with me, there will be my colleague moderating the event, Saigas. You'll see her. Good morning, Rita. I am a counselor to the national TB program in Uzbekistan. This is on the STAR program. I'm sure you know this. You all may have heard about this program. It's a technical analytical resource support. Brita is as a counselor in Kazakhstan of the national TB program. She is a specialist on issues related to managing the quality of anti-TB drug, and she has experience working in GTF program. Rita, maybe you would like to say some welcome remarks. Maybe you would like to welcome. Good morning, all the participants of the 5th conference, and I hope that we'll have a very interesting, very productive day, and we'll hear a lot of good and interesting presentations, and there will be a lot of discussions and questions. Thank you, Rita. So literally in 2 words, I would like to talk about the session itself. So the issue is really interesting. It's a really extensive session. During this plenary session, we'll be speaking about creating favorable conditions for sustainable fight against TB, and this is a very wide-ranging concept. So we'll be talking about the financing issues and about the providing all the services, about involving the communities, local communities. So everything that helps us to bring our knowledge to our drugs to our patients, our population in the way that it's really acceptable, it's really comfortable for our patients, for our population. And I would like to now, in 2 words, say that we'll have 4 presentations this morning during this first session, plenary session, and the time allocated for each presentation that we're allocating to our speakers is 15 minutes. And I ask all presenters to please stick to this 15-minute limit so that we have enough time, so that we'll have time for a Q&A session. Additionally, if during the presentations, if somebody will have questions, you may submit them in Q&A session in writing and or in the chat window in the Zoom platform, and our presenters will be answering your questions. Or if we have some time remaining, you can show raise hand icon and ask your question, and our presenters will answer them. Now I would like to say a couple more words about our technical support team. Thank you very much to them for administering our event, and we want to make sure that all the presenters have their access to their presentations, so that they're able to prepare, open their presentations, and share screens when they are presenting their presentations. So we're starting out today's day with the presentation from Kazakhstan, from Kyrgyzstan, sorry, and it's really pleasing. It's my really great pleasure to present to you Rahat Cholru. Rahat, she's my colleague, whom I've been working with. I have a great history of joint collaboration in Kyrgyzstan. I'm really happy for this opportunity to welcome Rahat. She's also participating in over the past 10 years in all the programs that are helping or promoting improvement and reforming the healthcare systems in the country, in the Republic of Kyrgyzstan. And at present time, she is the deputy director of the USAID project and TB in Kyrgyzstan. And I give floor to Ms. Rahat, and she may start her presentation. Rahat, Ms. Rahat, you have the floor, ma'am. Good morning, Nicholas. Can you hear me? Can you see me? Can you hear me? Yes, we can hear you. Thank you very much. I will now try to bring up my presentation, share my presentation with you. Hopefully, you can see my presentation now. Yes, we can see your presentation. Yes. If you switch to slideshow, yes, we can see it now. Excellent. Thank you, Rahat. Thank you. You have the floor. Good morning, dear colleagues. Good morning, Nicholas, Rita, and everyone. Thank you all very much. First off, I would like to thank participants and organizers of the 5th International Conference on Integrated Control, Integrated TB Control in Central Asia, for the opportunity to share with the Kyrgyz Republic experience. It's a really great honor for me to speak about the results in Kyrgyzstan at such a prestigious conference and get feedback from my colleagues from our region. I will try to stick within the time frame allocated to me. Can you hear me, Nicholas? Rita, can everyone hear me? Yes, Rahat, we can hear you. Yeah, yes, we can hear you very well. Thank you. And we can both see a presentation and we can hear you. Thank you. Excellent. Then I'll continue. So here we have the structure of my presentation for this morning. Let me start with so my presentation is about reforms in the TB system in the Republic of Kyrgyzstan. And so I will try to stick to here we have the structure of my presentation. I will try to stick to the time allocated for me. So I'll start with the fact that I'll give a background and characteristics of our country. As was already mentioned yesterday, Our country, Nicholas also mentioned about this. Uzbekistan is among the countries with a high burden of DRTB on annual basis. In our country, a quarter of patients are with the DR patients. And unconditional this presents a huge challenge and a huge challenge for the system of healthcare in the Republic of Uzbekistan.
Diagnosis and treatment of patients when approaching health facilities. And as you can see, our country still has issues with a low coverage of bacteriological testing, and the country is still trying to reach the WHO recommended targets for treatment success. And as you can see today, these are the results for treatment of DSTB, and we are still below the targets. As for epidemiological characteristics, along with poor coordination of TB care at various levels, low capacity and motivation of primary healthcare personnel to providing TB services, inadequate human resources at different levels of healthcare services, and poor access to laboratory services. So all these factors resulted in low effectiveness of healthcare system in our country. And definitely the issue of drug resistance to be added necessitated further commitments and responsibilities of our health system. And I would like to highlight that before 2018, so before the reforms started in our country, so most of the state financing of TB care had been channeled to hospital treatment, but at the same time, the facilities did not receive the whole range of supplies to provide TB care for the population. So their primary objective was to provide hospital services, and actually unjustified lengthy admissions were practiced, although back then the country adopted the protocols for, say, for expanded outpatient treatment and so on. But at the same time, the infrastructure of TB hospitals remained unsatisfactory in most cases and failed to provide safe hospital stays. And overall, all these factors became the basis and the rationale for the reforms in TB care system in our country. Although the reforms were planned to cover all the key functions of the healthcare system. So starting with changes in the care delivery patterns. So the relevant financing was supposed to be provided for the services, and the resources and systems had to be provided to ensure effective operations as well as effective management. So the overall set of measures was planned to improve the TB care system in our country by our government. So in 2017, and Nicholas is well aware of this document, so the government approved the action plan, so we call it a roadmap to optimize TB care system. In general, the document describes the key areas for reforms in our country. So the reform aims were envisaging establishing the patient-oriented model of TB care in Kyrgyz Republic within 10 years. So the period was before 2026, and I apologize. So we're having some issues. I don't know, someone is writing to me. Either they can see you or can hear you. The technical team, please take measures. If the rest of the participants can check, please, with the rest of the participants if they can see the presentation, because I can hear you and I can see your presentation well. But someone is saying your camera is off, but no. We can see you and hear you well, the people are saying. Maybe you are having some technical issues. Please approach the technical team. I guess that was the message from the host. Well, sorry for interrupting you, because I repeatedly received that message. Please continue. Can you hear me now? Yes, so we can see you, we can hear you. But I received that message about that problem, and so I apologize. Okay. So the goal of the reform was to set up the patient-oriented model of TB care in our country so it could provide relevant services for our population, relevant high-quality services. And excuse me, stop them. Could you please switch off your mic, because I can hear myself, the interpreter speaking.
Oh, yeah. Yeah. I mean, we were not able to hear each other. No, he was not able to hear me, actually. Okay, so I called because my wife is, I'm in a conference right now. I will be here all day. And so instead of me, my wife will come and.
Значит, основными направлениями реформ.
So the main areas of reforms were to expand outpatient treatment, improve quality of TB services at outpatient level, optimization and restructuring of TB hospitals to ensure effective and high quality TB services at these facilities, and also to improve TB laboratory diagnostics to ensure relevant testing techniques at all levels of healthcare. The roadmap timeline was split into 3 stages. And so with regards to the program implemented before and its future stages, but I would like to draw your attention to the fact, as shown on this chart. The goal was, as estimated, as a result of optimization, the country was supposed to get savings to be channeled to the system functions that needed to be enhanced and that needed further financial support. So the roadmap outlines the key strategic areas and objectives and the primary healthcare level to be hospitals and to be laboratories. So as for TB labs, later on, I will give you more detail when I discuss the implementation status of this roadmap. And I would like to draw your attention to the conditions coordinated among all the stakeholders when signing the roadmap. And a key precondition I would like to highlight for you is the consensus, the agreement saying that the savings as a result of optimization could be channeled exclusively to improve the quality of TB care. And so far, in principle, this precondition and others are being implemented, and we do hope it will be implemented till the end of the roadmap implementation period. To ensure effective coordination and management of TB care, the Ministry of Health decided to fundamentally reconsider the role of provincial TB control centers, which before 2017 had operated as TB hospitals. And so they provided hospital care, and they were funded per case treated. And these facilities, provincial TB control centers, they were not functional. They were not financially ready to perform the functions mandated to them to coordinate TB care. And in 2017 to 2021, the range of activities was implemented almost in all provincial TB centers, where they revised the staffing schedule, job descriptions, structure, and they developed the functions for coordination of management. And an important element to change the role of provincial TB centers was the developed financing methods. So they added per capita standards, and provincial TB centers could know how much they could generate as a result of the capitation introduction. And starting 2020, dear colleagues, all TB centers at the provincial level have been receiving this amount of financing to improve their coordination and to ensure a more effective performance. And the chart on the left is showing the hospitalization to TB hospitals. And as you can see, the hospitalization rates are going down, especially the highest level of the downward trend were reported in 2019. And actually on the right, you can see the number of hospital beds. And I guess now you can see that here the reduction is not that intense. And one of the causes is the willingness of healthcare facilities to continue as before, so to preserve their independence. And as you understand, for that they require more beds. And actually in this very period, 2017 to 2020, ineffective hospitals were repurposed for something else, for other needs of the healthcare system. And there were interventions to ensure optimization, restructuring, reorganization, and definitely those activities were in progress. But given the situation last year, of course, some adjustments will have to be made, and the plan will be implemented by the Ministry of Health. So as for primary health care, the main objectives, strategic areas identified in the roadmap so far are implemented quite well. And the breakthrough is that the country reached the consensus in terms of TB case management, and the model was developed. We call it TB case management model. And the focus is switched from receiving TB services from TB doctors to receiving TB services from GPs, general or family doctors. And for that, we had to expand the functions of primary healthcare professionals, family doctors, and tools were developed so the functions and objectives could be implemented by family doctors. And an important point here is that the payment system was developed to provide incentives for primary healthcare personnel so they could cope with their expanded functions and tasks. And this is paid at the same time when the successful TB treatment is completed. And I guess more detail on that will be presented on day 3 at a relevant session on TB financing, and the public will make a presentation on that. So the current approach now is implemented in 3 provinces. And starting September 2021, this approach is extended to 2 new provinces, and this demonstrates a high level of commitment of the government, the ministry, to enhance primary health care. Here you can see the approach to case management, and please pay attention. This approach is broader. So there is a broader approach to patient management at the PHC level. So it's broader than just providing TB drugs and directly observed treatment at the outpatient level. So this approach also includes psychological care, social support of patients during treatment, before the treatment is completed. And much attention is given to treatment adherence. So, as part of case management, a great role is played by the arrangements of the controlled treatment of TB. And the key principle here to organize the controlled treatment is patient-oriented or patient-centered treatment. So various options were suggested, like engaging social assistance, video control treatment, and the approaches should take into account the needs of the patient. Currently, the Ministry of Health is active in developing approaches aimed at active TB case detection at health facilities. And here, I would like to draw your attention to the fact that in our country, some 24% of patients annually notified in our country is detected in general hospitals, so diagnosed in general hospitals. But unfortunately, given their situation, we have very low level of my health professionals, and the active case detection approach is being adapted and introduced in this sector of the healthcare system in our country. So in parallel, we are developing the active case detection approaches among the key groups of the population. So based on the results, like how they will be pilot tested, so relevant decisions will be made for how the country can adopt these approaches and implement them further. As for tracing TB contacts, here our country engages various agencies like SAS, Sanitary Epidemiological Surveillance Agency, Primary Health Care, and TB Service. And now there is reconsideration of functions of each and every agency, and without relevant financing, without providing relevant personnel and resources. This area might remain on paper, just formal, and for that, pilot testing is underway for the expanded model that has not only the broader functions and algorithms for interaction among all those services, but also the issues for how we can ensure adequate financing of this area and how personnel should be provided. So the TB contact tracing could be well established. So as for health financing reform, so I guess I will not take much of your time. On the 20th of September, more details will be provided, but I would like to say that the financing reform is a driver for the whole set of TB care reforms. And the key objective now is to shape appropriate incentives to improve TB care in our country, to improve access and coverage with laboratory testing. Our country has developed and introduced almost in all areas the transportation system.
We accepted the model of transportation when the objective of transportation is given to outsourcing to the transport company, and this approach showed sufficiency. So in pilot format, they were that they used to plan the expenses and payment for the transportation in our country. Rahar, time, please. Yeah, it's about 2 minutes. On this slide, I would like to draw your attention to how this breakthrough has happened for key diagnostic methods. In relation to medical information systems, we will have a separate presentation. And again, big attention is paid to the development and introduction of information systems. And this allows reforms implemented in the tuberculosis aid to be more efficient and ensure efficient coordination. As far as the rest of the plans, as you probably understand, our country is in the middle. 2021 is the medium of the implementation of the roadmap. There are a lot of plans and tasks that need to be implemented, both on optimization, that will be continued, both on introduction of function approaches for treatment and primary medical sanitation help. So all of those activities will be continued, discussed, and piloted. With this, I will finalize my presentation and thank you for your attention. Thank you very much, Rahat. Thank you for presenting all these key aspects, as you have correctly mentioned, and I know about it a lot, about how it happened, and probably it was not easy to do. And now I would like to give the floor to Rigi, who will present the next speaker, please. Hello, everyone. The next presentation will be made by Mr. Lilian Karalan, who is Executive Director of Center of Policy and Research in the area of healthcare. This is an NGO located in the Republic of Moldova, but it's an organization with a big experience of introduction of healthcare programs with different diverse coverage of healthcare systems, infectious and non-infectious diseases. Lilian has a big experience in leading healthcare programs. It's about 17 years of her leadership work. Currently, she is a leader of the grant of TB-RAP, which is a regional grant, which implements programs in improving the measures of controlling TB in that region. The presentation will be focused on the role of the organization of the civil society under the support focused on people. And the special focus of this presentation is a standardized approach of supporting services at the level of communities in order to improve the results of treatment of the TB in the VETSA region. Therefore, I think that we'll have very interesting discussions, and therefore I would like to invite all participants to listen and be active and ask questions. Liliana, please. Thank you, Rita. Could you confirm that you can see my presentation now? Yes, we can hear you and can see your presentation. And please expand your screen. Just 1 second. Is it better now? Definitely. Thank you. Once again, go back to the format you had before that. Somehow technically it does not allow me to do that. When I'm trying to expand it, it disappears. What about now? It is expanded now. Is all good? Go back with. It doesn't let me do that. Could someone launch the presentation for me, please? Technical team. Could you help us? Perhaps you close your presentation and I'll try to share it myself.
Сейчас хорошо видно для всех.
Is it better now? Can everyone see the expanded format now? Yes, we can see it good. Thank you, Rita. Sorry for this technical problems. It's too early in Moldova yet. Dear colleagues, good day, everyone. Let me welcome you on behalf of the team of Center for Policy and Research of Healthcare and TB-RAP program team. Majority of you know TB-RAP programs, TB-RAP 1 and TB-RAP 2. Since you're representatives of the countries who participate in these programs and are partners on their implementation. The first TB-RAP in 2016 and 18 was focused on resolving one common problem of our countries in the region, including Central Asian countries, which is outdated model of providing anti-TB aid, which is focused on full hospitalization and lengthy stay at the hospital that facilitated to development of high-time treatment of TB and an effective use of resources. TB-RAP was focused on ensuring political commitment to transit to the new model of anti-TB aid, which is focused on the needs of people and development of the conceptual model for this aid for DETSA countries and a set of tools
to assess legal framework, forecasting, and planning of the human resources and others. In 2019, TB-REP has expanded the focus of the previous program and focused on improvement of the quality of anti-TB aid, focused on the needs of the people through the high involvement of the TB community and civil society and development of the integrated approaches, which are able to satisfy the needs of all key and vulnerable groups. With the change of paradigm of combating tuberculosis and active transition of our countries from vertical models to new, more coordinated models of aid, we can see the growth of the demand for the services for rather vulnerable and other groups of population, which are focused on the sustainable growth. Unfortunately, the biggest difficulty in providing integrated services focused on people in our countries, there is a lack of clear definition of the services. Package of services, minimum quality standards provided, and the estimation of the costs that would allow our countries to develop those services which are provided under diverse projects and to develop sustainable mechanisms of social order for better quality of involvement of the civil society and communities and handover after the donors by the government. In response to these challenges and to provide the conceptual model of aid that has been developed in 2019, under the second TB-REP, European Bureau of the WHO and the Center for Policy and European Coalition on TB developed standardized package of support services at the level of community to improve the prevention and treatment of tuberculosis package. The document provides the developers and the representatives of these communities tools to identify the costs, those services, in order to implement them and further introduce in the base package at the local or national level. The standard approach describes non-medical services during the entire continuum of the anti-TB aid, starting from increasing awareness and mobilization of community and ending with the social support and rehabilitation after the treatment is over. The services are organized by 4 fields of prevention, detection, treatment, and care and support. And in total, we have included in the package 12 services. In addition to the above mentioned, the package describes also services on consulting persons with confirmed risk to TB, non-clinical case management, accompanying the treatment under supervision, further treatment and surveillance, psychological consultation and support, comprehensive case management, material support, and others. Additionally, the package describes the services with special groups and in special conditions. The special focus is paid to the services for people who are convicted or those who do not have the place of living. And the special focus is given to the family approach of treatment of TB with children and times of emergency in healthcare, like COVID-19 pandemic. For each included in the standardized package service, we provide standardized detailed description, which includes goals and tasks of the target group and services provided with a focus on its planning, continuity, place of provision, and necessary resources, assessment and reporting with specific indicators of quality and quantity, and documentation on case management, and algorithm of services provision. Rita, could you go through the next 4 slides quickly? I will not stop them because the presentations will be provided to all the participants and you will be able to learn it in detail. But these slides provide the description from the first package of service, which is increasing awareness of the community mobilization of the local community. On this slide, I would like to tell you more, since it's a very important component of the document, which is a methodology of cost estimation included in the package of services, which is to serve as a practical instrument to forecast costs, to provide support services to the stakeholders at the national level, such as Ministry of Health, National TB Program, and civil society institutions. The methodology describes the components, calculations, and their volumes, sources of information, and principles of estimation, and has step-by-step instructions to identify the cost. And the most important methodology, we have the tool to estimate the cost, and the next slide provides some abstracts of that. Standardized package of methodology of estimation is the framework document so that countries can easily adapt for specific needs in the country context, and national standards of services according to the normative legal framework and procedures. Additional to the internal expert assessment, the package has and I will use this forum, and I would like to thank all Central Asian countries with Professor Perfiva, who is the chairperson for this conference, for invaluable recommendations to improve this document. And what's important that in parallel with the development of this publication, which takes quite a long time due to requirements, currently 9 countries of VETSA, who are the participants of the TB-RAP program, including 3 countries from Central Asia, Kazakhstan, Tajikistan, Kyrgyzstan, have taken this document for introduction and adaptation. At the end of my presentation, I would like to mention that we all have the general understanding that for improving the results of treatment and prevention of the TB, we need integrated approaches focused on the needs of people, which can satisfy all the needs of key and vulnerable groups. And for this, we need all actors with their specific knowledge and skills. As we all say, nobody wants to play chess with only a queen at hand. Therefore, the role that could be played by civil society in this fight is key. And therefore, our joint task is to make that those services that people expect, that could help us improve the Thank you. Thank you, Madame Kraulan. And I think this presentation and others will be causing a lot of questions in this conference and other periods, because this presentation highlights important thing that, and we all understand it, that we need additional partners like as a civil society, because we quite understand that their involvement is paramount, and we need standardized approach and identify what kind of services they can provide. And therefore, I realize that this document provides for entire list of services on all components of the TV service, as well as the composition of those services, and what's most important, this estimation of budget, so that we can further advocate in the country to be implemented. And definitely this package will help to have the framework base so that the services are of quality and efficient and rational. Therefore, I think that there will be a lot of questions. So your and your colleagues' views who participate in creation of document will be very valuable. But this will be in the session of questions and answers. So thanks again for your presentation.
It was my pleasure. Our next speaker is Mrs. Smith. She represents Partnership Stop TB, and the matters that will be covered by this presentation are covering protection of human rights, introduction of the society, gender equality, full society approach in order to improve the results in controlling TB. Madam Smith is representing a department, and the name of that department is the Society Human Rights under the Stop TB. Before that, she was the part of team of Global Fund and also Partnership for Health in Boston. So unfortunately, she will not participate live, and it's covered also with her voice. And even if she's not with us, we kindly ask everyone to listen to the presentation and then to prepare your questions. Thank you. Technical team, please. We don't hear the voice. We kindly ask a technical group to help us.
Good afternoon. My name is Kiva, and I work on the Country and Community Support for Impact team in the Stop TB partnership, specifically on community rights and gender. Unfortunately, I cannot be with you, but I know that my colleague, Dr. Andrei Masniaga, is with you, and I look forward to meeting you in person soon. I will divide my talk today into 4. I will briefly talk about why community, human rights, and gender matter in TB. I will pinpoint and highlight the strategic importance of CRG as outlined in multiple strategic blueprints and documents and plans to end tuberculosis. Thirdly, I will explain what and how the Stop TB partnership is supporting countries and communities to operationalize the principles and objectives of community rights and gender. And lastly, I will speak to some of the work that I'm aware about in your region, specifically from Tajikistan, Kazakhstan, and Kyrgyzstan, and how the Stop TB partnership will further support CRG advancements in these countries. So, to the first point about why CRG matters and how CRG interventions can contribute to ending tuberculosis. Well, the fact remains, as we all know, that every year the health system is missing millions of people affected by tuberculosis, especially among key and vulnerable populations. And this is because of barriers to health services, human rights violations, stigma, and a lack of access to support services, all of which is now being exacerbated by COVID-19. So in other words, millions of people affected by TB are being missed year in, year out by the health system, and not just because of gaps in the health system, but also due to the environment within which people are trying to access services. So to reach these missing millions, we need to transform the TB response, as you were doing in your region, from a response that is passive to a response that is proactive, one that assesses the environment through which the most vulnerable people are trying to access services, and to address these challenges and barriers in a people-centered manner that meets the holistic needs of people affected by TB. In other words, we need a response that puts communities and their needs at the center of the C, a response that is founded and driven by rights and people's rights to health, right to social support, right to education, and other rights. This is the R. And we also need one that acknowledges and is responsive to the needs of all genders, the G. So a CRG approach to tuberculosis. So at a global and strategic level, the importance of CRG is recognized. In the NTB strategy, it acknowledges the importance of strong coalitions with civil society and community organizations, as well as the protection and promotion of human rights. In the Global Plan to End Tuberculosis, it establishes that CRG is a key requirement to end tuberculosis. In the UN Political Declaration, world leaders have also affirmed their commitment to ending TB using a CRG approach. And the current Global Fund strategy and mechanism reaffirms the importance of CRG, but also, and more importantly maybe, makes resources available to countries to advance human rights and gender equality to meet the needs of key and vulnerable populations. However, today we know that we are not on track to meet the targets to end TB by 2030. And we know this from the UN Secretary General's report and the Community's Deadly Divide report, both of which acknowledge the lag and call for the transformation of the response to be rights-based, equitable, stigma-free, with communities at the center. To support the operationalization of these CRG commitments into action and investments, the Stop TB partnership, in collaboration with partners, developed over time and based on country experiences, a relatively comprehensive package of support for countries. Namely, number one, we developed a CRG framework which consists of different CRG intervention areas to guide a comprehensive CRG approach to TB. Number two, we develop CRG tools and guidance which support CRG implementers. Number three, we develop CRG investment packages, which provides guidance to programs on CRG investments for the NSP and for Global Fund funding requests, for example. We also have a grant mechanism called the Challenge Facility for Civil Society, which is for community and civil society to test and to implement CRG innovations. And we also have a technical assistance program, which is led by CRG experts from across the globe and which links to Global Fund and USAID investments. So in terms of the CRG work in the region and the support that the Stop TB partnership has provided to specific CRG interventions at the country level, we have indirectly supported the rollout of the CRG assessments through the Global Fund TB Rep 2 project implemented by the Center for Health Policies and Studies, so the PASS Center. The CRG assessment really is the starting point from which CRG principles, approaches, and interventions can be operationalized. So it really is good to see the uptake of these assessments in your region. To give you a flavor of the types of information generated by these CRG assessments and how it is used, most importantly, I thought I would highlight what the assessments in Tajikistan, Kazakhstan, and Kyrgyzstan revealed in terms of number one, key populations prioritized, the human rights and the legal concerns, as well as the challenges facing different genders and how stigma and discrimination are all impacting access. And number three, I'll touch upon some of the recommendations that were taken forward. This information that I will present upon is just a summary, and it draws heavily from the publication Breaking the Silence, Human Rights, Gender, Stigma and Discrimination Barriers to TB Services in Georgia, Kazakhstan, Kyrgyzstan and Tajikistan and Ukraine, which was developed again as part of this TB Rep 2 project funded by the Global Fund and implemented by PASS Center. The publication was developed by PASS Center and their consultants with contributions from the Global Fund CRG Department, Stop TB Partnership and the WHO Euro Division. So using the CRG assessment protocols that were developed by the Stop TB Partnership and most importantly adopted by countries, these qualitative assessments provided an important baseline, as is outlined in the report, to establish the situation of TB key populations, the state of human rights, gender and stigma-related issues, and how they impact program performance to reach and treat the most vulnerable. So if we take Tajikistan, the CRG assessment conducted in 2020 and led by the NGO Gender and Development with support from the Global Fund CRGTA program, namely the Canadian Legal Network, they prioritized several key populations, and for the following reasons. People who use drugs have a higher risk of drug resistance in Tajikistan, and while OST is available, its coverage remains low, which is impacting people's ability to complete treatment. People living with HIV, people who inject drugs, and sex workers express not trusting the health system, which again creates barriers to access. Tajik migrants do not have access to adequate and affordable healthcare, while in the Russian Federation and upon return to Tajikistan, they are not prompted to screen for tuberculosis. People with a history of imprisonment reported challenges in terms of accessing a TB diagnosis or care while in prison, and upon release struggle with accessing care because they don't have the appropriate IDs or documentation papers. So therefore, at an individual level, these populations are either not seeking or are not able to access services, which in turn is impacting programmatic performance. In terms of gender, women's decision-making power in Tajikistan, according to the report, in relation to health is very limited, especially when it comes to those who have lower education levels. Married women also fear divorce, while unmarried women fear finding a partner. Gender norms is also impacting access. So, for example, due to masculinity norms, the main function of men in the family is to bring money home. So when Tajik married men are making money abroad, it is usually sent back to the male relatives on the husband's side of the family and not necessarily the wife, which then further contributes to women's disempowerment. As such, one could deduce that in terms of gender responsiveness in Tajikistan, it would be both recommended to have not just a gender sensitive approach, but also one that is transformative, which could balance out these inequalities. So now in terms of human rights and legal concerns, Article 1.56 in the Health Code, according to the assessment, lists the rights of people with TB. However, the Health Code does not prohibit discrimination of people with TB, even though the same prohibition exists for people living with HIV. Furthermore, it is reported that people with TB feel insecure about their labor rights and right to social support. And in terms of stigma, low public awareness about TB and treatment is creating fear, which means that people are not actively seeking care. Now in Kazakhstan, the assessment was conducted in 2020, and it was led by the Kazakh Union of People Living with HIV in collaboration with the NTP. Kazakhstan prioritized two populations, people living with HIV and internal migrants. So internal migrants, according to the report, often face challenges with housing and job security, which leads people to prioritize job seeking over health seeking. And people living with HIV experience delay in getting a TB diagnosis because TB-HIV integrated services are not always available at the health facility. Now, in terms of gender, women experience elevated levels of stigma and discrimination, which impacts their ability to access health services. Women with small children in particular experience delays as well in getting a diagnosis because of the lack of childcare support. And for men, like in Tajikistan, they prioritize job security over seeking care, and they have elevated alcohol and drug issues in comparison to women, which can also interfere with treatment adherence. And in terms of human rights violations, people reported having been fired from their job and even being expelled from university. In Kyrgyzstan, the assessment was conducted in 2016, and it was led by the TB Coalition with support from the Global Fund CRG Department through APMG Health. So in Kyrgyzstan, people who use drugs, prisoners, internal migrants, and people with a history of imprisonment were prioritized. The assessment revealed several barriers faced by these populations. So migrants, for example, and people with a history of imprisonment struggle with access because they don't have the appropriate IDs or documentation. People with drugs struggle with treatment adherence, because in some cases, healthcare providers ask hospital staff to discontinue OST while on TB treatment. In terms of gender, women with TB can be subjected to physical, emotional, and also sexual violence because of TB. And women in Kyrgyzstan have also been advised in some cases to abort their babies while on TB treatment. And for men in Tajikistan, and like in Tajikistan and Kazakhstan, delays in health-seeking behavior occur in Kyrgyzstan because they're often the breadwinner in the family and they prioritize their job over health-seeking. In Kyrgyzstan, there are also several regulations and policies which contribute to legal barriers for people with TB. In the law of the protection of the population against TB, there is a list of professions which prohibit people from TB from accessing. Furthermore, people with TB are largely not aware of their rights, and the contact investigation policy and practice used at the time of the review, in any case, did not respect people's right to privacy. In other words, contacts of people with TB were being reached out to without the consent of people with tuberculosis. And in terms of stigma, it is highly prevalent in primary healthcare settings, according to the report, and myths and misconceptions about TB are really fueling stigma in family and community settings, again, presenting as barriers to access. So as part of the CRG assessment, countries proposed recommendations. So the next step after the assessment was conducted, they proposed recommendations and actions to overcome these barriers through usually a national dialogue that is a consensus-driven process. And in Kyrgyzstan, which is really good news, because the assessment was conducted in 2016, their findings and recommendations were used to inform the funding request of the Global Fund in 2017. So in other words, this was an example of how CRG information was concretely used to integrate CRG into the national TB response. So today as well, across the globe and in several other countries that have conducted these assessments, they are now translating these findings from the assessments into what we call costed CRG action plans, which are then being integrated into national strategic plans. So just by way of an example, in the Democratic Republic of Congo, 8% of their total NSP budget is now allocated to CRG. But coming back to the solutions and to the findings, again pulling from the Past Center publication, countries propose to address the barriers faced by people who use drugs and people with a history of imprisonment through service integration and comprehensiveness, training the police and prison staff and orienting people affected by TB to their rights, just by way of some examples. And in terms of gender equality, to address the consequences for TB for women, countries propose to disaggregate all indicators into men, women, and other genders, which will help to really monitor and to design appropriate gender comprehensive interventions, gender responsive interventions. They also recommended providing family planning support and to address gender-based violence. In terms of stigma in healthcare settings, countries proposed improving working conditions, including prevention and infection control, developing and implementing protocols regarding confidentiality and training healthcare workers on key populations, gender, human rights, and so on. And finally, to address quality and people-centered care, countries proposed to strengthen case management to meet the comprehensive needs of people affected by tuberculosis, ensuring and protecting people's rights to confidentiality, providing differentiated treatment options, and making psychosocial and peer support available to all people with TB. So as is outlined in the Past Center publication, there are several differences, but also similarities in CRG barriers and solutions proposed by countries in your region. But for me, I guess the take-home message, which is also in the report, is that progress is really being made in your region to reform TB care, so that it is responsive to the needs of people affected by TB, so that it is patient-centered or people-centered, it is rights-based and driven, it is gender-centered and transformative to really meet the needs of key and vulnerable populations. And so to further support your efforts, the Stop TB Partnership is here to support, as you know, Dr. Andre Masniaga's work through the Global Fund and USAID, as well as through this grant mechanism that I mentioned called the Challenge Facility for Civil Society. So this year, we're really pleased to be able to announce that we'll be working both at a regional level in the ICA region, as well as at country level to support efforts in Tajikistan, Kazakhstan, and Kyrgyzstan. So in Kyrgyzstan, we'll be able to, through the Challenge Facility, to support community-led monitoring and advocacy efforts. In Kazakhstan, we'll be able to support the development of a national CRG costed action plan, which is great news, and as well as community-led monitoring and reaching key and vulnerable populations through innovative innovations. And in Tajikistan, we'll also, through the challenge facility, be able to support the development of a national CRG costed action plan, as well as community-led monitoring and interventions to reach key and vulnerable populations. The challenge facility really traditionally has only been able to support a small number of countries, but this year, really thanks to the USAID and Global Fund and their considerable contributions to the challenge facility, we're able to support a much larger number of countries. So this year, we're able to support 28 countries and 6 regions. And so myself and my colleagues, we're really, really pleased to be able to support the region more concretely through the challenge facility this year. So with that, I will close and congratulate you on all the CRG work done thus far in your region. And on behalf of Stop TB, express how much we're really looking forward to continuing our work with you on CRG this year.
Esteemed participants, despite the fact that Mrs. Smith was not with us, we had beautiful presentation of hers from the point of view of voiceover and the presentation, but we still have the great opportunity to ask the question, any questions from the representative of Stop TB program, because we have their full participation. So please, if we do have a chance to ask questions from them, should you have any of them, or would you like to ask them, you may do this.
Regarding the issue of the human rights, involving the community, gender equality, they are practical application through analysis of five countries, 3 countries from this Central Asian region. There's already good experience using this, utilizing resources, and then those barriers need to be overcome, and grouping these barriers and summing them up as general for all the countries and also specific for each country in the region. Also, if you paid attention, if you notice, the last message, in the last message, it was pointed out that there are reforms already underway in this regards, and they already launched the reform process. So there's a starting point for that, and I think that these reforms will be successful in the future. That's why this presentation was really very interesting, and it supports us in continuing our endeavors that we started. Thank you all, and I will give floor back to Mr. Nasidze. Thank you very much, Rita. In my turn, I would like to now present our last presenter, Dr. Ron Martin Hughes from the Institute of from Australia. Dr. Martins has education in the area of mathematics and informatics, and he has a PhD. So starting from 2015, he headed and supported several analysis of economic modeling and increasing the efficiency in allocating the resources, fighting TB, HIV, and malaria. And we all understand, everyone present here will all understand how important it is to allocate resources during planning activities and efforts and in the fight against tuberculosis. So he also has the development of models of optimal TB. I know several reports optimal TB for several countries, and these reports are always interesting. And I will now have the opportunity to listen to Dr. Martin Hughes with his presentation on this very topic on optimal TB. So, Dr. Martin Hughes, floor is yours.
Thank you very much for the introduction and the invitation to share today. So yesterday and this morning, we've heard, I've heard many wonderful presentations on improving TB care, on the implementation of TB services, improved diagnostic routines. And what I'd like to talk about is the allocation of resources between each of those. So when we've got new prospective programs and existing programs, how can money be spent most effectively? Because when we think about sustainability of TB services, that really means being able to sustain funding and demonstrate that TB spending is as efficient, cost efficient as possible in order to maintain funding from governments when there are many other health issues to respond to, and from funding partners. And so that means demonstrating that we're achieving the greatest impacts we can with the amount of money we have. And so that's for the right people, as in the presentation just now, looking at key populations, how well are we targeting our spending to reaching those who are most vulnerable to TB, or those where there's can be the highest yield of testing. How well can we target it to the right places geographically? Is it more cost effective to increase spending in one district or in another district? In the capital city where the burden may be high, or in the more rural areas where cases are going undetected? Are we spending money at the right time? Often the answer is that the right time is now, but how many more infections can we, TB infections, TB related deaths, can we avert if we invest more money this year compared to if it takes 10 years to reach that level of investment? And are we investing in the right ways? So with limited resources, is it more cost effective to invest in prevention, TB prevention for preventive therapy, or is it more cost effective to invest in a better but more expensive treatment regimen? And so when we conduct analyses, we're looking at questions like, so after generating a baseline with mathematical modelling of the current epidemic and what the projections are, there are questions that we look at, like, can we spend money more effectively given all of the current programs or prospective programs? How can we spend that more effectively? What if there was decreased funding in the future or increased funding? What programs would we cut if we had to reduce resources? And how many more infections would there be as a result? Or if we could generate increased investment in response to TB, where would we allocate that? And how can we justify that to the people who would be providing that funding? And in particular, when we look at those NTB targets, as we've heard already, mostly we're not on target globally for reaching the NTB targets. So how much more investment would be necessary to reach those targets? So in conducting mathematical modelling, optimization, there's, I guess, several key inputs to this process. So one of those is to generate the projections through of matching all of the reports of incident TB cases, of how many people are being treated, what the treatment outcomes are, and ensure that that matches what's being seen in the country. And the second part, which was really well summarised by Liliana as well, was having really accurate descriptions of the programs and the unit costs, how much, and having that done with consistent methodology so that we can understand what those programs are doing and what the impact will be, and how much they cost relative to each other. And then it's really critical to include realistic constraints on this optimization. So the constraints can be ethical around just maintaining treatment, even where it's more expensive. They can be economical based on available resources, potentially with what increase in spending is realistic, or they can be around what the objectives are. But most importantly, they can be around logistical constraints. As mentioned just in the previous the previous speaker, not all key populations may be accessible for treatment. And so it may not be possible to reach 100% coverage or even 90% or even 50% coverage. And so it's important to input all of those constraints in what can realistically be achieved and hopefully to include programs, additional novel interventions that would increase outreach and increase the potential to reach a higher coverage of key populations. And once we have each of these inputs, we can run scenarios to analyze how, what the impact of changed spending or improved program efficiency would be. And most importantly, we can run optimization of spending. So we have an algorithm that runs, and I won't go into the details, but it's on our website. But the algorithm generates, reallocates all of the spending between different TB programs. And that gives us projected outcomes. So I'll give a couple of examples of how we've applied these models. So one of these was in Belarus in 2016, about five years ago. And the spending at that time was around 25% of spending was being spent on involuntary isolation for relatively few patients, very high cost, while hospital-focused treatment was nearly 40% of all of the spending in the purple color. And of testing, most of that was being done through mass screening. And so through this optimization process, and in line with the recommendations and very much in line with the experience from Kyrgyzstan, the first speaker this morning, reallocating that spending to optimize the outcomes, recommended a reduction in involuntary isolation, a shift from hospital-based to ambulatory care, and moving away from mass screening to better targeting that to the people where there's higher TB prevalence. And as a result, it's possible to achieve much higher rates of TB diagnosis and more people on treatment. And that has implications for sustainability as well. So the projections of what that would achieve, comparing the current conditions or the current conditions as of 2016 to the projected results with the optimized spending, be a 45% reduction in active TB prevalence and nearly a 60% reduction in TB-related deaths. So the results of spending money more efficiently, even when there is, I guess, resistance because of how historically things have been done, the outcomes from spending money more effectively can be really quite significant. Second example I wanted to talk about was from Indonesia. And so this one we conducted recently. And Indonesia has, it's one of the highest burden countries on all measures, including total TB cases, TB-related deaths, drug-resistant TB. But the current spending is really almost as efficient as it can be because they have quite limited resources, like a 45% funding gap to what they would like to have. And most of the money is being spent on treating people who are diagnosed through passive case finding, people who attend clinics because they're sick. And so there's actually quite limited achievements. So this analysis was focused on what can happen with more money, with more resources. And of course, acknowledging within that response, most of the analysis was done before COVID, but the impact of COVID there is that 20 to 50% of health providers have reported disruption due to COVID. And really, it's not on track to have any reduction at present based on our projections. And here, even with if we quadrupled spending, even then the NTB targets wouldn't be within reach. And that's partly because of the implementation of programs. And I think my colleague, Dr. Kai Lin, will speak about the implementation efficiency within settings such as Indonesia later. But reallocating spending is not quite enough. But what we can do is have a more realistic target, looking at an amount of spending that the government could put into programs that are known to be effective and that can achieve really tangible outcomes. So when we look here at a 15% projected reduction in TB incidence by 2035 relative to 2016, that's quite significant in Indonesia and translates to 75,000 fewer TB cases per year, 15,000 reduced TB deaths per year. And that's an amount that perhaps the government can be more receptive to, or funding partners can find resources to fund. And so being able to demonstrate how the most cost-effective programs, in this case, preventive therapy for high-risk contacts, including children and people living with HIV, demonstrating that TB money is being spent as effectively as possible is, I guess, the way forward for sustainability. And it's been great to hear the other, that is a consistent theme. And just to finish, this has really been done as partnerships, and more than the mathematical part of the modelling, it's the process can be, I guess, extremely enlightening to really closely review those costs, closely review what can change, where there are constraints, closely review what new interventions could be introduced in each country. And this has been done, in particular, I acknowledge, I guess, the World Bank for funding much of this development and being our partners and collaborators, along with University College London. And it's not just Optima TB, I guess there's also many other TB modelling groups that are providing similar rhythms, and there's the TB Modelling and Analysis Consortium. So thank you. Hand back.
Thank you very much. Thank you. It was a very interesting presentation, and I hope that the audience can find the details of each report on the websites that you have provided, and I think it will be really interesting for the program managers indeed. Unfortunately, we are running out of time, and we don't have really time for the questions and answers. But anyway, I would have one brief question to you, which I would suggest if you will write in the Q&A answer to this, that if there are any countries who has changed their approach in the financing after your reports. So that will be really useful information if you can write answer to my question in this Q&A. Thank you so much. Огромное спасибо всем.
Thank you very much to all the presenters this morning during this panel. Thank you, Rita, for collaboration in this session. And unfortunately, we don't have time. It's very unfortunate. We already maxed out time allocated for the plenary session. We don't have time for a Q&A session, but I think that in any case, we'll have the opportunity to answer some of the questions at the very end, at the end of the day, when there will be a summary of today. Please, if you have questions, write them down or send them via chat, and our presenters will be happy to answer those questions. Now, I think I need to declare. I need to announce coffee break now, which was announced earlier. We already maxed out our time, but I still think that this is how we're going to do it. So thank you again, everyone. Please, please, other moderators, get ready. Please let me know if it's not a time for coffee break. Please let me know. Thank you. Thank you very much, dear speakers and listeners. I would like to remind all of you that in order to participate in the fourth modeling session, you will need to reconnect to the second link for participating in the third session, stay in this link. Now I have a 10-minute break. Thank you.
Уважаемые коллеги, разрешите продолжить нашу конференцию. Все ли меня слышат, уважаемые участники? Прошу подключаться и прошу уже с перерыва возвращаться. Мы продолжаем нашу работу. Я всех приветствую. Я благодарю Риту Сейкас и Николаса Насидзе. Николас, вам большой привет от нас и от меня лично. Мы, к сожалению, у нас...
Our team, unfortunately, our time has been reduced for our session, but I hope that our speakers will keep up to the time span. And together with Alisher Mahmudov, who will be leading this session, moderating it, although we do it online, with Alisher, we are sitting in one office, so we're both offline to each other. But we talk remotely through the computer. Dear colleagues, now I'd like to give the floor to my co-moderator, Alisher Mahmudov, who is the regional advisor of the USAID EDICA project on policy and advocacy. And he has a big experience in different areas, and during more than 20 years, he worked on improvement of healthcare system, including governance, funding, medical education, and service provision. Currently, he continues this work, and as a co-moderator, I would like to ask Alisher to continue our meeting. Good morning, colleagues. Thanks, Marat, for introductions. And in my turn, I would like to introduce my colleague, moderator, Marat Kaliyev, who is a PhD in medical sciences and big experience in healthcare financing for more than 10 years. And he's one of the people who were at the beginning of the development of the Kyrgyz TB program. Our session is number 3, and in this session we'll be talking about favorable condition, environment, and financial sustainability. We'll have 6 presentations in total, and as Marat mentioned, due to the lack of time, we'll have to expedite, and we'll have diverse presentations, not only in the area of funding of health, but also presentations about social order and a very important theme, which is related to everyone now. These are issues about procurement and quality of procured drugs. So in our session, we will be talking about this. Now I'd like to give the floor back to Marat, who will briefly remind us moderation rules. Thank you, Alisher. Colleagues, first of all, I would like to ask all panelists to open their presentations on their desktops. And before speaking, please turn on your video. Don't forget to share your screen. And please, at the end of your presentation, stop sharing your presentations. Please, not more than 10 to 15 minutes. Please keep up to the time. The floor now goes to first presentation, to the steps on improvement of procurement of anti-TB service and public finance management in Tajikistan. Alisher Mahmudov, please. Can you see my screen well? Okay. Thank you, Marat, for introducing the theme. This brief is related to Tajikistan, and we'll be talking about those aspects that are implemented by EDICA projects in Tajikistan. First of all, we need to understand that to have successful reforms, we need to transit from the strict payment system that we currently have in the Tajik health system. And at the same time, we need to think about using clinical guidelines. And in parallel, we need to work on restructuring and optimizing networks that we have, because this is important to redirect these funds to operational and other costs, for instance, like drugs, consumables, transport, and others. So all which is currently covered by international partners, all of that shortly should be done at the government costs expenses. And therefore, it is important to conduct this work more actively. In general, there are two approaches for the implementation of this work. First approach is so-called top to bottom, is when we have high national level interventions. So, you know, such activities as guaranteed package of services, it's per capita funding, it's funding hospitals for each hospital case, resulting at the... So all these activities are not undertaken in Tajikistan. And for the last 10 to 15 years, we've been attempting, but those funds require, and this approach requires high-level government intervention. So some critical decisions need to be made. And you know, sometimes it's pretty difficult to negotiate with the Ministry of Finance and the government for to get certain decision made. And there is another approach, which in the framework of our project decided to implement, which is bottom-up approach based on the changes at the level of institutions. And for this, we have developed a methodology to conduct mapping to identify those fragmentations, gaps, and barriers which exist at the level of funding of specific services or tasks at the level of the individual institutions. And my current presentation is mainly focused on the second approach, which is bottom-up. So why we need this matrix? The continuity of the services is quite complex, and there are a lot of elements that need to be found. But we understand that currently we have certain gaps to ensure the continuity of services. And I'm talking about state funding. And therefore, we have used and started using in Tajikistan the matrix. And it helps us to identify those problems and gaps that are available at all steps of the continuum. And secondly, we look at this isolated problem and make an assessment based on the sources of funding, whether it is the state or its partner funding sources, perhaps like direct payment from people. We look at the payment system to suppliers and how the public finance management rules work and what is a cash flow. And the fifth element, which is very important, it's the information system. So we need to clearly understand whether we have information system at each stage and whether it can provide that information which we need from the point of view of funding. Well, we have taken as an example, and let me give you this example and remind you about the comprehensiveness and continuity of TB services. On this slide, you can see the list of activities which need to be carried out to ensure the continuity of TB services. It might be quite extensive, but here I depicted the main elements, important elements. It is clear that to identify TB case, we need to conduct active and passive work. It is clear that we have problem with the collection of samples at the primary level, which is quite urgent and complex issue, which is transportation of samples from the level of the institution till the closest lab. It is clear that laboratory network that exists in Tajikistan is becoming more complex. So there are new systems emerging, new equipment, and for all of that, we need money. We understand that we now have the new goal, which is combating latent TB infections. And for that, we need funds as well. And another elements in the list require funds, attention, and implementation of these activities dictate the efficiency of this continuity. If everything works fine, and at each level we have relevant funds, and we clearly identify role and obligations, then we can be sure that the system of identification will work well as treatment and support to patients. Conceptually, on this slide, I'm showing you analysis how it will happen at each level of continuum. And if we go back to the previous slides, there are some steps that require the interventions at the national level. But here, when we use the matrix, some they will not require some political level decisions, but at the same time, we will probably need to update instruction, perhaps internal instruction on funding, and specify the role of the institution and why we need this matrix. Once again, I would like to say that the matrix allows to imagine and visualize and unpack of those aspects in each cash flow. So we have the service suppliers, institutions, and by the way, they might not have direct functions related to the TB services, but at the same time, somehow they participate in the services provision. It could be a lab at the hospital. So on the one hand, it is a part of the continuum, but the patient to get his or her analysis can address to lab and get the services. So matrix is comprehensively showing at each step of the continuum what kind of links exist and what kind of issues exist in relation to 4 areas that we have mentioned earlier. And the principle of matrix is quite easy, simple. So when we started working, we were thinking how to identify those gaps. And in Tajikistan, we started analysis from the basic package. In the basic package, and we have described all types of services, starting from simple ones, ending with complex services. And simple ones could be activities on propaganda of the health lifestyle, or through healthcare centers, or the sanitary epidemiological surveillance system. And the complex ones could be maybe TB patient needs some surgical operation which needs to be done in the specialized institution. And in the same way, we have ranked the institutions. So we put them in the list from the simple to complex. So at the level of community, the healthcare system usually has health house institution, and further these institutions become more complex the way they go up, and additional functions added until we reach the national level, which is the Republican hospital. So this is how we organize the metrics, and we conduct analysis as far as funding, and we'll look at each financial flow, cash flow, how it moves, and to what extent the supplier payment system is responsive. Other instructions on the regional offices about the payments on a daily or weekly basis, or are there any system to collect this information? Here again, I'm repeating the content of my previous slides. I just wanted to show it visually. Unfortunately, it's a very small font, but this slide shows the matrix itself that we have by vertical all those institutions. So we try to take into account all of them as much as possible. By vertical, these are types of services. If you print it in A3 or A2 format, then each cell will open up and show visually the links and demonstrate all these interlinkages between the services, suppliers, and payment systems. We started this work in Tajikistan and already conducted some interventions, and I can give you one example. This is identification of TB cases at the level of the institutions, like a medical house. And mainly we have taken 4 elements, which is, first of all, we need the patient himself or herself who has a suspicion, and we need to see whether he's addressing to the medical institutions and screening is made. Secondly, we need to see whether we have personnel who will be collecting the sputum and conducting work. And third is, do we have the container to collect the sputum? And the fourth is transportation of sputum to the lab. We need to take into account one thing, so that from the point of view of funding, if we resolve these 4 elements and issues, then the system of healthcare will get the biggest advantage from how these elements work at this minimum level of institutions, but at the same time, this is like starting point. So the success of the program depends on whether this identified case, whether it is identified efficiently and followed up. Even identification of the case could be divided into smaller elements where we can see how these small elements are coordinated and funded. And step number 3, which in Tajikistan we have already applied. So we asked key questions. Such question as who and how will identify the cases? So we can already start hearing from the regions that some of the institutions have the facts of lack of containers, and lack of containers means that we can miss it. Another thing is key is how to transport the sputum. The instructions that we have in Tajikistan say that the responsibility for transportation is at the level of the primary level. But primary level is not getting a penny for that. And basically, transportation is done by the medical staff of local offices who might live like 50, 60, sometimes 100 kilometers away from the lab. So they have to transport it at their own cost. So this is something that we have analyzed and tried to locate the funding so that all of that will be covered. The next slide shows visually what is the chain as far as development of recommendations. I'd like to say that the matrix in Tajikistan is being used by the technical working group created by the Ministry of Ministry of Health, which includes the representatives of the international partner organizations, National TB Program, and financial experts. So this is kind of a mixed group. And now they started using this matrix. And at the first stage, we started collecting information, documents, and the decrees. And there are already shortcomings and gaps and simple recommendations how to improve it and how to make it clear. What we have at the moment is an action plan about how we will introduce these improvements. As I said, we already started collecting data. We have the information that, according to matrix, will reflect each cell. And as I have mentioned, we have identification of potential problems and some recommendations that solve certain problems. But this process continues, and I think that soon we'll have some specific goals, solutions, recommendations on each area of work. But again, I would like to mention that the matrix is a tool which seems to be quite difficult at first glance, but if you start applying it in practice, then it helps you to make and find solutions, and you come up with more and more questions that can lead to recommendations, because there are some issues that you never paid attention to before. So matrix helps to, at a maximum, see at a very low level what kind of gaps and obstacles exist, so that you can develop recommendations about how to overcome them. That was my last slide. Thank you very much for your attention. I give the floor back to Murat. Thanks, Alisher, for interesting presentation. Can you stop sharing your screen? Very interesting new approaches on the purchase of TB services, early identification of the TB, and the matrix indeed allows to provide details of steps, identify barriers, and solutions. And dear colleagues, we now move to the next presentation. And now I would like to give the floor to a very well-known doctor who has the economic education, who has big experience of work in the regional clinical document of Karaganda Department of Health, Department of Strategic Development of Health Ministry of Kazakhstan. He also worked as chairman of the Committee of Payment for Medical Services. He was also advisor to the director of the Republican Center for Development of Health and the chairman of the fund of the mandatory medical insurance. So I would like to give the floor to the representative of Etika USAID of Kazakhstan, Kanat Ermekbayev, who will tell us about the mechanisms of funding. And I think this experience will be very interesting for us to see how in Kazakhstan such financial issues are solved. Please. Please, Kanat. Good morning, dear colleagues. I hope that you can hear me. I can see my slides on the screen. Well, this is a great honor for us to present you the work that is done on improvement of funding of anti-TB service under USAID project. We need to emphasize that improvement of funding of anti-TB services in Kazakhstan in general meets the planned development of medical services in Kazakhstan. Thing is that starting from and in the system, we have included the entire stationary assistance and outpatient services and ambulance service and support to socially important diseases, including anti-TB service. Since 2010, we have already developed the principles of the single-payer principles approaches, and medical service has been adapted mostly to the issues related to the principles like money chase the patient. And since 2018, the fund of the mandatory medical insurance became the single payer, and with the establishment, a creation of the mandatory social medical insurance, medical social guarantees have been divided into two packages of services, which were at the government budget cost, and the package of government services at the cost of funds of medical insurance. Whatever is not related to these two packages, which is guaranteed volume of the free of charge medical aid, and which is package which is funded from the funds of the social medical insurance, they are related to the commercial medical services, including voluntary medical insurance. So providing medical insurance to the TB patients is in the package of the guaranteed by the state, free of charge, and funded from the national budget. And all these provisions have been provided, and the code of Kazakhstan on health system, which has been published in July 2020. Next slide. The analysis of the payment of TB services in CIS countries, according to the WHO European Bureau, shows that in general, we have different methods of payment to TB aid at different levels. For instance, payment at the level of the primary medical sanitary aid is carried out in different countries diversely, but mainly per capita principle. And in some countries, it is by article, just like during Soviet Union. The stationary stage of treatment is paid also by different methods, daily payments or by budget. In Kazakhstan, we have made a decision that ambulatory stage, which is per capita provision, will include
на амбулаторном уровне, а на стационарном уровне вот оплата.
In the inpatient treatment, the payment for this. In order to somehow systematize and move forward towards not only on the issue of financing on the whole, but to reorganize the entire system of vertical and horizontal integration, Kazakhstan adopted the plan, TB plan for 2014 to 2020. So the next slide, please. Here's the plan. Here's an integrated plan, which highlights 4 objectives. All the objectives, all the tasks are here on this slide. On the goals are related to improving the financing. They are under the first task to reform TB services in Kazakhstan, civil and penitentiary systems in Kazakhstan, and to help to TB patients and patients with the XDR and DR. So under this first objective, first task, starting from 2018, we started changing in the structure of the TB network, and at the same time, it's a change of financing principle. Please, next slide. Now, as for the financing, from January 1st of 2018, we introduced a new model of financing, which provides for the switch to switching from Soviet time financing. These resources were allocated by local budgets, regional budgets, to consolidation at the country level and paying for a specified patient using the integrated tariff, integrated TB patient. Next slide, please. So this financing model, which is introduced since January 2018, as I already said, the financing of TB services in Kazakhstan is done using the integrated tariff for one patient, for one active TB patient. The patient. So there are rules, what cases and how this is done. So national register, since the diagnosis and how, and once this patient is registered in the national register of TB patients, and starting from that moment, and after they establish the inpatient treatment regimen, the integrated tariff payment starts from that moment. So the integrated tariff itself is calculated using the formula. So the allocated budget from the allocated regional budget, which is historically done, and divided by the number of TB patients in the region. registered in the national register, TB register. And of course, at the beginning stage of introducing a new model, we have 17 regions in Kazakhstan, and considering that the infrastructure, TB infrastructure service was unique for each region, and of course the local budget allocated different amounts of money. So the integrated tariff, it became different, but starting from 2018, 2019, during these 3 years, we are equalizing this tariff between various regions in Kazakhstan. In addition to integrated tariff payment, Kazakhstan also adopted a norm of payment for TB anti-TB drug for the accounting period. So in other words, so TB organizations, TB institution, let's say, submits to the fund of compulsory medical insurance the number of drugs that they are planning to use and the cost for those drugs, TB drugs. And in some regions of Kazakhstan, we do the operational interference, and for the TB patients, there are additional costs for service providers. That's why these rapid interventions were assessed depending on the costs, and additionally, in addition to integrated tariffs, we also have KZG payment depending on the rapid interference measures. So transition to our outpatient model, outpatient treatment regimen. Connection is lost. I can't hear him. And rehabilitation and in the TB sanatorium, for example, the contingent of population in these sanatoriums and practically the complex of rehabilitative measures that they need could be done in any rehabilitation centers, which has necessary methods. That's why the compulsory medical insurance fund. So it's not going to be a state budget. It's going to be through this fund of the compulsory medical insurance. So this rehabilitation assistance will be paid according to the days spent for the rehabilitation from TB. Now, as for the increasing the volume of outpatient treatment with expected effects from outcomes from more effective methods of diagnostics are using now in the inpatient treatment, and the patients with TB, they didn't have there was no motivation to keep the patients in the inpatient treatment because the payment wasn't done by bed/days. That's why there was an increase of outpatient patients, increased number of outpatient patients increased. That's why there was a lot of agreements were signed with the providers, and then later on this is now paid by the fund as part of the integrated financing for the PHC. The next slide, please. So on this slide, you can see that the total amount of funding by years will take the 2020. So its tendency is the same. This was really important for us because I can hear him. The number of patients starting from $17,000 from the budget, but under the integrated plan, TB control plan. which was in accordance with the governmental decree, considering the importance of this issue, of this problem, as well as in relation to the fact that in addition to internal funding through governmental budgets, there's also external financing using donor funding, and all these financing volumes we're still able to maintain at the level required, not to decrease the treatment. Considering the active TB patients, the number has decreased. And on the second slide, you can see that there is a gradual. There's leaders and there were outsiders, but average Republican level from 2061 tenge, 201,661 tenge. So outsiders were brought up to those regions which were lagging behind. So the source for replenishment of integrated were the funding that were within the universal Republican budget. So the released funds through optimizing the structure of TB service structure, and these funds were allocated towards equalizing the tariffs, and this activity will be continued so that this entire integrated tariff should be ideally be equal, except those coefficients that need to be considered for each region. Depending, for example, as you know, Kazakhstan is a rather large country, and in the northern regions, the winter is more than 6 months, and southern parts less than 2 months. So you see, as you can see, the heating season is different, and the expenses for communal utilities is also different. And you can't even compare. There are some regions that have responsibilities to the government on ecological payments. We're talking about near RLC region, Semipalatinsk region. So all these additional payments to the government for ecological aspects that they need to make by that need to be made to the TB personnel. So this increases the integrated tariffs of depending on the peculiarities of each region, as I already mentioned those. So thus, having said this, we can state that that introduction of this new model of financing over the past 3 years has given us the following. So first of all, we reduced more than 5,000 ineffective inpatient beds. So you all understand the background. The funding was a different funding. It stimulated anti-TB service to increase the number of TB beds. This was the path of switching from 2018 to funding to paying to each treated cured patient. So this already. So it's a new motivation. So after that, there was active decrease both administratively and economically, but so we're talking about 5,000 ineffective beds in the entire country. We kept the financing, volume of financing. I already told you that, although there is a tendency for decrease of active TB patient, the outpatient treatment is done at the once we start using new financing method, using the subcontractors, and in the past there will be a per capita financing at the PHC level. Anti-TB drugs, because they are funded according to their usage, they significantly has improved. The accounting has significantly improved. So the sustainable financing has improved, and more or less objective. It became more or less objectively reflects the costs, the expenses of the TB organizations. Now, as for the rapid interventions, this is a fair payment to TB personnel, because only 3 regions of we do that only in 3 regions, and we need to decrease our financing using the external funding through our donors. So we have the schedule. First, we need to decrease the external funding, but in order to carry out all this activity and use new methods of financing, with TB organizations were switched from organizational legal status to economically active enterprise, which provides conditions for introducing instruments for effective management of inside the TB organizations. We need to point out here that we cannot state right now that the management has greatly improved, because there's still a lot to do, training the managers themselves and help them establish a really effective, efficient model of. Next slide, please. Can I ask you to please, we still have 4 more presentations. Thank you. 3 more minutes left. So with all this, so here's the list of deficiencies of the existing financing system. There's external funding, which still remains. There's instability of financing. Also depends on the budget funds. It turns out that some TB events, some TB activities were not included in the calculations during the calculating the integrated tariffs method, including laboratory services in infectious control and others, and so on. And plus, we understand that the integrated tariff is not very. There's different categories, different forms of diseases. There's different levels of this disease. That's why the task is to more or less come up with the more just financing. There's issues related to restrictions and interactions with the outpatient sector of treating TB patients. Next slide, please. So that's why, in order to improve the first integrated plan finished in 2020, now we have a new draft, which this new draft also has the components related to improving, enhancing financing system. You see here 3 bullets on this slide, but each of these bullets they have certain they involve certain actions. Next slide, please. Now, as for the improvement under new integrated plan up until 2025, so we're planning. So it's integrated tariff, which will reflect the peculiarities of forms and categories of disease of TB patients, and it's necessary to calculate those types of costs and expenses that are not related directly with the TB patient. So we're talking organizational matters and methodological work, work related to local executors, and work advocacy activities, and so on, and issues on awareness campaigns. That's why these calculations, they need to be also done. We all understand that. So accordingly, there will be some adjustment coefficients depending on the cost groups. They need to be developed. Needs to be more. They need to be more just. You need to develop assessment criteria for the quality assessment to use, so that the payee could, as a strategical purchaser, could impact the quality, volume and quality of services provided, and in various normative legislative documents, they need to have the rules, mechanism of interaction between all these participants of this very business process. Next slide, please. So with this purpose in mind, under this project, we've conducted a number of activities that you see on the slide, but the most important here is the last one, with the with this fund for compulsory medical insurance. We now have new approaches how to form new tariff, how to establish, and what to start with. In this particular case, through routing, I understand that the previous informative matrix as instrument was it fits to simultaneously do the routing as well as tackle the new emerging issues because they come up unexpectedly that were never considered earlier. But on the whole, the healthcare system changes, and we need to come up with some restrictions and such events as under the project that we started. The next slide. We are planning to develop clinic expense groups, come up with the adjustment coefficients, do the modeling of the budget, considering the internal expenses, and come up with the rules and mechanisms. This is something that we still have to do. Please, next one. I would like to say the following in conclusion. So the TB service in Kazakhstan
the rules of funding of 2018, of course, stimulate the increasing the efficiency of all anti-TB activities. And I'm sure that the USAID project that has taken the mission together with the fund of the mandatory medical insurance will finalize all these objectives. Thank you. Thank you, Kanat, for very informative presentation. I think we will go back to the majority of questions presented in your brief. And I think your presentation is very much synchronized with our third day of conference when we'll be in Kyrgyzstan showing the experience of funding of TB service. And I'm sure that we'll have very interesting discussions on the third day. And now, dear colleagues, I would like to give the floor to Musabek Gulnaz, who is the coordinator of the TB programs in the group of grants implementation. She has a very good experience in accreditation of medical institutions, coordination of the drug programs, and she worked as the head of the monitoring center of pediatry. Her theme is related to the state social order and lessons in Kazakhstan. Gulnaz, please share your screen. And I give the floor to you, Gulnaz. Good morning, dear colleagues, friends, partners. I'm very happy that we have this opportunity to share experience of Kazakhstan in the state social order, and I would like to welcome all the participants from the National TB Program and a Global Fund Group. So, in spite in the strategic document, which is called Comprehensive Plan on Combating TB, dated 2014, we have already had activities on the need to involve the civil society. The real activity started in 2017, so we have 5 years experience, where for the first time NGOs got included in combating TB as strategic partners of the national program. And you can see that the second part, when we talk about strengthening of the civil society role in combating TB, this clause has been included in the new strategic plan to be implemented in 2021-2025. As Kanat mentioned, this comprehensive plan is being approved at the high level. And we hope that by the end of the year, this document will be signed. Here you can see all the activities that will be reflected in this plan. As I mentioned, since 2017, under the implementation of the grant, we have involved NGOs. But in the beginning, they were mainly pilot regions. Out of 17 regions of Kazakhstan, only 8 of them started working, and then we got expanded under the grant to 11 regions and 13 NGO. And with the new grant from 2020 to 22, we have involved all regions of Kazakhstan and 19 NGOs. And we need to say that when for the first time we have received the grant under the Global Fund, unfortunately, we haven't had trained NGOs and TB field. And thanks to the implementation of the grant, we had some NGOs which were experiencing HIV programs. And now the first grant and second grant involved the NGOs which have experienced. And during implementation of the grant, we have created NGOs which specifically work on tuberculosis, those who suffered TB, exposed to TB. It's a public foundation, Egilik, which works on TB, which is led by the senior doctor of this region. And in Almaty, Nur Sultan, Nazarın Kalema. And I would like to say that under this comprehensive plan, for the first time in Kazakhstan, we had the non-governmental institutions which are focused on the reduction of the burden of TB. Here you can see the goal of small grants to NGOs in Kazakhstan. So the focus is to strengthen the role and the participation of the civil sector in controlling TB. We know that we cannot cover everything, and therefore we were focusing on key groups of population. Here you can see that during implementation of the grant, we had homeless people who are alcohol addicted, HIV people, former convicted, migrants, internal and external, and low-income people. Here you can see brief information about the main activities that have been district level with the support of the NGOs. And this year we're expanding the work on other regions which were not covered before. And that happened also due to the help of the Global Fund on combating COVID. And we are working to cover the entire Kazakhstan territory. Secondly, we have also developed a methodology and plan of the remote work of the NGOs for the period of the quarantine. So all NGOs were provided with the personal protection tools, and we are developing the handout materials on COVID. So we have information separately for COVID and separately for TB, but we're now merging these materials. We conduct annual trainings to increase the capacity of NGOs for coordinators, social workers, outreachers, psychologists, which implement the small grant. Another achievement of the national program is that we have developed practical recommendations with this support of Comeda NGO to fund NGOs from the national budget and financial model for cost estimate of NGO costs. We have described all algorithms of obtaining by NGOs of the social orders and grants from the national funds. And I would like to mention that in Kazakhstan, by legislation, the NGOs can get funds on 15 areas, 15 fields, including combating TB. We are also providing permanent support by monitoring visits, technical support by the TB program. We're also developing an introduction of web-oriented information system. Here you can see the list of the tasks implemented under small grants. This is what the NGOs should implement with the support of the Global Fund. I will not talk about all. This is being implemented since 2017. All NGOs have the experience of implementing these goals. Here, I wanted to show you some figures. What was the contribution of NGOs? So you can see that we break down all activities that our NGOs do in two areas. First, as informing of the groups of population with difficult access. And secondly, you can see that in 2020, we have informed 53,361 people. So it was 6 months of full work in spite of pandemic. So referrals to the primary system, and we heard that in the European region, there was a reduction of identification of 40%, and in Kazakhstan it was 21%, and without NGO support, perhaps this figure would be even higher. You can see that we refer to the primary system, 6,787 people. These are people who could not even go to the primary system. They didn't know their rights. So we brought them to the primary system. GeneXpert method has been applied, and we have identified 335 cases of active TB, which was 9% with a target indicator of not less than 5%. And we have also identified 675 contact individuals with TB patients. We also have supported 2,138 TB patients, and efficiency of the work of NGOs is 95%. So 95% of all patients which were taken under the curatorship of the NGOs were not stopping the treatment, and 288 patients were returned back to treatment. Here you can see the picture, the confirmation that in Uzbekistan, in Kazakhstan, we started the advocacy meetings. Decisions are made by the local authorities, health departments, social protection departments. First, we conducted it in Nur-Sultan, the capital, and big thanks to the TB service, head of the TB service, who actively participate in it and interact in this field. And in the country, we have the schedule of advocacy meetings, and we hope to cover all the regions so that next year we will have the shift towards allocation of the state order grants for NGOs. So we can continue. The algorithm of such advocacy activities is that NGO has signed MOUs between Tuberculosis organization, Department of Health, primary institution. So our NGOs know, well known in their region. And 4 to 5 years ago, not even medical institution and not talking about the people knew about existing of such NGOs. We participate in the Coordination Council meetings. Some of the NGO representatives are the permanent members of the Coordination Councils on TB under the local authorities. So we also sent letters to the local authorities, participate in obtaining the state orders. Here you can see information about the grants allocated from the national budget as in 2020. These are 4 regions that the social support allocations were made in Karaganda. So the city administration allocated 1,830,000 tenges to support in Pavlodar, and this region is permanently getting funds from the city administration for hot food at the outpatient stage. The amount of the financial aid has reduced because the number of patients decreased as well, but the support is continuing. And Akmalinskaya region, for the first time, it started. Igilik, the NGO, has received lots for information campaign on prevention of TB. Of course, funds are not big, 2,250,000 tenge. And there was another grant for state order by the Ministry of Health at the national level that Kazakhstan Network on Combating TB NGO has won. As a result of this year, in comparison with 2017, we have shown it with the blue column, the allocation from the Global Fund, and green is national budget funds. And as you can see, the situation is stable, but we need to emphasize that starting from 2020, the themes became more specific on tuberculosis. So if before, the focus was made on information campaigns, in 2020 and this year, lots covered not only information campaigns, but also supported outpatient stage. And it is remarkable to mention that the activities of NGOs became more active. So we have very experienced NGOs in all regions, as I said, so that work on HIV and TB. So we had new NGOs emerging, and they actively participate in all anti-TB activities in the region and at the national levels. We also have development of the partnership. We organize meetings at the high level, coordination meetings, and last year we have registered for the first time the public association of the pulmonologists of Kazakhstan, which united not only doctors, but also people exposed to TB. And I also would like to talk about the quality of the lots development. So NGOs participate in development of the themes for the lots, but and another thing is that the size increased. So at average it was 2 million, but now we have even lots for 15 million tenge on prevention of tuberculosis. And in September, there was a message made by the president, which had two clauses related to this theme. So the second is increasing the efficiency of the healthcare system, so that we need to take care of the diseases which are not related to coronavirus, and that the healthcare system requires large-scale funding. And number 4 is that we need to improve funding for rural NGOs. Thank you very much. If you have any questions, please. Thank you very much, Gulnaz, for information. Indeed, state social order is a new theme, and Kazakhstan is among leaders of those who are introducing this system. And in other countries of the region, we also have some examples, and I think Kazakhstan experience will be also valuable. Now we will move to the presentations, which will be related to the drugs and ensuring the quality of the drugs. And the first presentation will be made by Ganjan Iskulov, who is the head of the Department of Assessment under the Scientific Practical Center of Pulmonology of Kazakhstan. Please. Hello, dear colleagues. Can you hear me?
Поставлен, да? Сделано? Да, все хорошо. Спасибо. Продолжайте.
Thank you.
В целом в Казахстане по внедрению, да,
in general, in Kazakhstan, introduction of the anti-TB drugs, the funding and purchase of these drugs is carried out through the Republican budget. Kanat Kartavich talked about it, about that anti-TB drugs are separated category. So we receive applications through the regional and city centers and coordinated at the national level center. This so we have a single distributor and purchaser in this country, and the purchase under the pilot programs and grants started since 2016. And introduction of a new for drug resistance to be the wide practice for the entire country starting from 2020. So the purchase from the Republican budget of the drugs of first line started since 2007, and it was 100% in 2010. And new drugs, as I mentioned, are being purchased since 2016 under the research program. And the purchase by the country budget started from 2019, and we are having gradual transition.
Начали с 2020 года. Законодательство у нас.
So the legislation of the Republic of Kazakhstan and registration of the drug is according to EU, all the drugs are used according until the 31st of July 2025, until 31st of December 2025. So he's speaking really fast. I'm really sorry. So Republic of Kazakhstan is among the number of countries that joined the WHO procedure for fast access registration of pharmaceutical drugs after the WHO approval. The Republic of Uzbekistan, under the program on improving the quality of drugs plus supported by USAID, is getting technical assistance to improve access to quality drugs through various initiatives, enhancing the capacities in the region in the registration, conducting inspections, including applying the oh my god. As you can see in this table, we have registered anti-TB drugs for DRTB. You see the whole number, total number for Bidaquilin is not registered yet in Kazakhstan. So to obtain access to to bedafiline in 2020. By the order of the ministry, we approved to include this for DRTB. So we have our internal requirements in Kazakhstan and an application for registration, requirements for several TB drugs. We have registered certain DSTB drugs using new TB drugs. We already spoke about this in 2016 and 2018. There was a research conducted for individual regimen. Again, same thing happened in 2018, 2019, shortened treatment regimen, and starting from 20, we started using according to new recommendations by the WHO. You see the treatment regimen on the table here on the slide by the recommendations from the WHO using anti-TB drugs. Modified shortened treatment regimens. Selection of anti-TB drugs. So we use all the treatment schemes. Individual and shortened treatment regimens by the order from the Minister of Health Kazakhstan. After that, the drugs are included in the Kazakhstan national list of drugs. In order for that to happen, all the drugs need to be registered first in the country, or they have to be included. So all the pharmaceutical drugs need to be registered after they register in the national Kazakhstan list. Then there's a list, outpatient drug supply list, and this list includes all the drugs purchased from the distributor. So the forecast and calculation for requirements, we have the order by the Minister of Health. There's a regulation, there's an internal rule, method of utilizing under the Global Fund, and technical assistance from GDF. All the coordinators, they underwent necessary training. We analyze data on quarterly basis. So when working on our requirements list, on the number of drugs, on the heads of the departments, all the coordinators, they all participated, and they gave they contributed to this process. Now, methods of procurement of drugs. I already mentioned this. We have one distributor. They use tender. Everyone buys from the single source. There's also procurement through international organization and the United Nations organizations. According to new governmental decree, they're approving a list of separate list for procured for the drugs procured through the United Nations based on the long-term agreement or contract with the UN. So information system now in Kazakhstan, starting from 2018, all TB. So all the requirements, all the way from requirements to all this using the TB drugs. Each region comes up with their own list, they determine their requirement. After that, they purchase information systems from the single distributor. So this program reflects all the requirements from each region, and then the program And after that, the agreements, the contracts are signed, and then the shipment happens after signing the contract for the provision of the information systems. Distribution is done by a single distributor. After the supply of certain drugs to organizations, shipment comes to our information system, and each patient gets his or her dose of drugs. So all our actions are monitored or tracked. Everything has been digitized. The storage and distribution of drugs, I already talked about this, based on the requests. And we have the governmental decree, governmental order from the Minister of Health about the minimum reserve of the drugs that shouldn't be less than 25%. So all the medical institutions that need to have a stockpile of drugs not less than 25%. So there shouldn't be any interruptions in provision the anti-TB drugs. So this problem has been resolved. So the only problem might happen when there is some interruptions with the shipment of some drugs from some producers from outside Kazakhstan. But then again, we have a ways to procure it internationally, to procure TB drugs internationally. The system of ensuring quality of this. Adequate distribution practice when purchasing drugs and pharmaceutical services, to adequate pharmacy practice when purchasing pharmaceutical services, system of monitoring achievements now. New and repurposed TB drugs and recommendations from the WHO, they've been reflected in the order about approving the rules of conducting events to prevent tuberculosis, high results of treating patients with the drug-resistant tuberculosis. The importation of anti-TB drugs is possible even when they're not registered. So the legislative base allows for the importation of unregistered drugs in accordance with the established norms. Focus accent to good clinical monitoring by training and introducing ABML into clinical practice, using bedaquiline and other anti-drug TBs if they're not registered in the Republic of Kazakhstan. Then Kazakhstan National Drug List, considering determinations for the MDR-TB and XDR-TB. And digitalization information system regarding use of TB drugs. Challenges. What kind of challenges we have? So the size of the market for the anti-TB drugs is insignificant, from 1 to 3 producers, and some drugs they don't have registered names. Bedaquiline, drugs for children, with the exception of drugs from the group of fluoroquinolones. Number of producers pre-qualified by WHO, in particular for treating the RTB, is insignificant. Only 1 producer for certain drugs. Clinicians will use new types and repurposed TB drugs if there are available. Process of registration according to new EAEC rules starting from July 1st, 2021, they don't provide for accelerated and simplified procedure for pre-qualified drugs by WHO. We don't have this opportunity for accelerated procurement yet. Thank you for your attention. John, thank you for your presentation. It's true, all these challenges that you just spoke about in your last slide, I think they are identical for all the countries in the Central Asia. And you know that your information about the accelerated registration, I think that this information is taken is being looked at by many countries to learn from your experience. And I think that you talked about the information system is also very interesting. And again, we have something to learn from our colleagues from Kazakhstan. Thank you, Kalamjan. The next presentation is a presentation from Uzbekistan, Safayev Hassan Abdusabitovich. He is the specialist on international relations of the Republican, specialized scientific Center for Physiology and Pulmonology. Presentation again will be dedicated to issues of drug supply, but in terms of state procurement. Hassan, please, you have the floor. Thank you. Good day, dear colleagues. Allow me to submit to you the presentation on the experience of Uzbekistan in public procurements in buying the TB drugs. Starting from 2001 all the way to 2006, the procurement for the Republic of TB drugs was done from grant kick from KfW fund. In 2007, by 2007, we had grants by Global Drug Facility and GBL on TB component, and all 100% of all drugs that came through global funds. In addition to that, we also had organization FMS, which supplies necessary drugs to the Republic of Kyrgyzstan. Next slide, please. So currently we use all anti-TB drugs, not only for children, but also for children, doses for children, new doses for children. In addition to that, right now we have research on TB practical, where we started using from 2017 retamoline, a drug. Our colleagues in regions, they know all these repurposed new drugs, including pritamanate, and they are included in our new updated recommendations for TB drugs, anti-TB drugs. The mechanism for procuring anti-TB drugs is following. When I talk about the public procurement, so we procure through international platform, GDF platform, which provides drugs with guaranteed quality that have been pre-qualified by the WHO. In addition to that, GDF also on annual basis they provide technical assistance through its own missions in the country and through current distance assistance from the regional management office. We all know that advantages of GDF. This is access to contractual prices for anti-TB drugs, as well as access to guaranteed quality, access to new instruments in effecting payments. All these achievements by GDF. We were able to explain to and show the Minister of Health, and we were able to prove to them that in implementing the state procurement, we need to use the GDF mechanism, and which is not only good as far as the prices, but also as far as the efficiency of treatment. In 2016, we had experience of purchasing anti-TB drugs through other international organizations, and after After that, we came to a conclusion that it's best to continue our collaboration and work with use the same mechanism which we've used using the GDF funds. Our doctors, our physicians, not only physicians, even patients are comfortable with. It was a lot easier for them to because they knew that if we do the state procurement, that we will not be able to always buy the drugs that will come out of the GDF fund, and we are among the countries that there's still a large share of proportion of and it would be there would be some discrepancy in some positions, drug positions. For example, if we purchase for half cohort from one bank from GDF fund through GDF and using budget funds, they will be coming from, let's say, from other manufacturers and producers. In that case, even physicians and physicians, that would be too difficult to explain to them why this is happening, because why we exactly chose to use the international mechanism GDF in doing the public procurement. So you all know that for Uzbekistan, we created a separate web page where we can control and see our shipments to Uzbekistan when we see the payment method status and when we can expect. So all these relevant documents that are necessary to effect or carry out the customs formalities. Using the example, here's the example. Our shipment of second-line drugs, anti-TB drugs, using the state budgets, where there's a full information about the number, about the date of shipment, date of entry into the country, and necessary documents to clear that shipment. On this slide, you can see the dynamic of financing of our anti-TB drugs. As you can see, in 2020, there's 100% procurement is done through using the state budgets for the first-line drugs, and gradually there will be a 10% growth. We'll start buying the second-line drugs now. We have an ongoing state program until 2021 about using the state budgetary funds to buy TB drugs, and currently we are preparing new draft of state for the government, where we're planning to calculate the requirements in anti-TB drugs until 2026. This will be a 5-year program for Phthisiology and service of the Republic of Uzbekistan. Here you can see the financing. If in 2019 was 1,800,000 for the TB drugs, and same thing in 2021 will be increased until $2.2 million only for the anti-TB drugs. If the decree came out in February 2019, and there was a presidential decree 4191, which our director spoke about yesterday, then in November we already had funds. We already signed the contract with the GDF for 2 years, and we are already buying and carrying out shipments into the country under this contract. In February of 2020, we received the first shipment of the drugs, of the first line TB drugs. In August, we received all other remaining drugs. In addition to that, I wanted to point out here that we were able to regulate the process, the customs formalities process for these drugs, considering that the procurement was done using the state budgetary funds. If in the past we used to, it took 2 or 3 months to customs clear. Now that period has shortened to less than a month, so we fully complete the customs formalities, and we can then start using those drugs in treatment. So again, this required certain time, as you can see. This is tied to human factor, of course, because we worked with the pharmaceutical committee, with the customs committee, looking for ways and to help. We looked at the Uzbek laws, Uzbek legislation, to find ways to help with the epidemiologically dangerous diseases. How we can simplify the importation of drugs into the country, or maybe some laboratory equipment. How to simplify and that there's no need to register those things anymore. So by doing that, we can now easily import for one-time usage TB drugs, equipment, without having to register them in Uzbekistan. But in addition to that, we have a problem with the VAT problem. You all know that
вопрос НДС, который составляет в нашей стране 15%. До этого мы...
And before that, we did not include this amount in the state order. And when we face this problem, this required certain time to find a solution, but we were able to correctly explain to the leadership of our country that the drugs are purchased for treatment of the epidemiologically dangerous disease, and that they will be provided free of charge. That the sales of anti-TB drugs in the private market is prohibited. This is how we were able to get the permission so that we do not pay VAT. So now, while importation, anti-TB drugs are not VAT taxed. Besides that, in the resolution of the president dated February 4191, we included the clause on simplification of registration of the anti-TB drugs. And in August 2019, there was a government resolution on amendments and changes in certain government resolutions, where it has been mentioned about the expedited registration of drugs which have pre-qualification by WHO. If the drug registration in the past took about 6 months, now this time has been shortened up to 60 days. And as my colleague from Kazakhstan has mentioned, we are now actively working on expedited registration, and we have already applied for registration of one anti-TB drug, and we're expecting to apply for another 5 medications, and we'll have the first experience of registration of anti-TB drugs through the expedited mechanism. We have also achieved the price reduction for registration, and we reduced the cost for registration up to 40% for the manufacturers, for producers. These drugs have been registered before, and currently we have only 4 drugs registered. This I have already mentioned. With the support of PQM Plus, which works with the regulatory authority and pharmacological committee, we started introducing the WHO CRP mechanism on expedited registration, and we have already published the guidelines on CRP. Since 2015, we are working with the QuantB program, which calculates our need in first and second line drug needs. In each region, we have the responsible coordinator on QuantB that quarterly provides information to us about the and quarterly we make the summary of data and the monitoring of the drugs in the country. Currently, we already have several sources. So we have the
в связи с чем нам необходимо получение именно качественных данных.
Doctors Without Borders, which are supporting with drugs, and therefore we need quality data collection, and GTF is helping us a lot. And during its technical missions and on online conferences, they participate with us very actively, and we conduct. And recently, with the support of the project of USAID EDICA, we conducted a training on new modes for our specialists on QuantB to estimate the needs. Hassan, are you done? Yes, I'm done. Thank you, Hassan, for interesting information. And I think that information is related to Uzbekistan on purchasing through GDF mechanism and information related to regulatory base on expedited registration, and will be very useful to other countries. Thank you again. The next presentation, as Hassan mentioned in his intervention, will be about PQM. I will now give the floor to the next speaker, Katabekov Azamat, who is a coordinator of the PQM program in Uzbekistan. Please. Hello, can you hear me? Yes, we can hear you, and presentation is good too. Hello, colleagues. Thank you for this opportunity to present PQM Plus project, promotion of quality of medicines plus, and I work to ensure access to anti-TB drugs of guaranteed quality while procurement transition. Few words about the project. This is an agreement between USAID and USP. And we need to emphasize that PQM Plus is the main USAID mechanism to work with pharmaceutical sector on quality of pharmaceutical products. A few words about USP. It's a organization that has 10 years of existence, which outlines standards of quality globally. And within 30 days, USP works jointly with USAID. And in Uzbekistan, USP through QPM Plus works since 2016. In the country, during last years, the entire need for TB drugs was covered by the Global Fund.
В 2019 году впервые был осуществлен госзакуп, то есть между министерством.
In 2019, for the first time, we conducted the state procurement by Ministry of Finance and GDF to supply drugs for the budget funds. Before that, all drugs were imported by waiver, which is one-time importation, and we could import them without registration. But now, since it's a state procurement, the
Это требуется,
registration
и через что нужно будет
is
провести все препараты, которые
requested for all the drugs that will be imported.
PQM Plus выбрал
PQM Plus
стратегию
has developed a strategy on how to help the country to conduct this transition. The first clause in our strategy is to strengthen the system of registration by the regulation authorities by introducing the expedited procedures and recognition procedures, as well as the introduction of post-marketing surveillance to control the quality. Secondly, it's recognition and expedited procedures. And third is the support of local manufacturers so that drugs of guaranteed quality of anti-TB could be produced locally in Uzbekistan. If we move to the first, which is the strengthening of the system of regulation of the drugs. Here, our main work was focused on registration, so strengthening of its system, and in this case, the project has conducted a big work, which is the assessment of existing system, revision of the legal framework, like government resolution, which regulates the system of registration in the country, which have been revised and approved. And improvement of existing procedures, and we call it Pharmacological Committee, which is a state agency where they move from manual procedures to automated. This process is also technically supported by our project. Also, it is important for the control of quality of anti-TB drugs that the labs which control the quality conduct duly tests. So now we work with two labs, which is Tashkent and Andijan laboratories. And the main objective is to make sure that the labs get WHO pre-qualification. In the country, there is a big pharmacological park where there will be room for the committee, and the project also provided technical support to develop the design in line with international standards for the labs that will be placed in this pharmacological park. Another important area of our work is working with GMP inspectorates, and the big success was achieved that the Cabinet of Ministers resolution has been approved on organizing a single inspectorate. Before that, in the country, we had several offices that did inspection, and often their activities overlapped. We also want to make sure that inspectorate will reach international standards, which is PICS. And additionally, in the country, there is a system of certification of each series, and we suggest, and this is WHO requirement, to marketing surveillance. So this is a system to allow control quality of drugs which passed registration. Strengthening the use of mechanisms of recognition. As Hassan mentioned before me, Uzbekistan was a member of the procedure of joint registration by CRP. So this is the procedure that allows recognition for the regulator to register drugs which pass WHO pre-qualification. What is pre-qualification? In simple words, this is the WHO recognition of the drugs produced and that it is in line with international standards. Uzbekistan is a member of this procedure, but the procedure didn't work here. What we did was So talking about the advantages, right? So this procedure reduces time for registration. There is no overlapping. It saves resources. And registration happens quickly, and the access to registered drugs for patients increases. What the project did to implement this procedure? First, we conducted the assessment. Why the procedure actually doesn't work. We identified all the gaps that were present. And together with the state center, we have filled those gaps. We have developed regulating documents like SOPs to work with CRP, WHO, and guidelines for producers. After that, PQM Plus helped to coordinate the work. So, we contacted producers of the drugs. So we explained to everyone that the procedure has been introduced, it could be used, and the procedure will simplify their process of registration and work. We have made a list of all reliable producers which already are present in the market. We conducted trainings for them together with the registration unit and state center. And we have approved WHO CRP price list, and the amount has been reduced to 53%. So why the amount reduced? Because by using this procedure, there are no laboratory tests made, and the number of the requested documents is very much reduced. So all the work that will be conducted by State Center by using this procedure is to compare the document that has been provided to WHO for pre-qualification with the documents provided for registration. And WHO provides confidential information about inspection and the reports on inspection to the regulator. And based on those documents, registration is reduced up to 60 days from 120. Another main important mission is work with local producers. PQM Plus works with the Noble Farm Sonnet company. The reason we selected it is that at the time of selection, it was the only company that produced anti-TB drugs. And we're talking about the drugs on second line. So our idea is to reach the status of pre-qualified by WHO. So we want to increase the compliance to GMP standards, develop the product. So we consult each step on development of the product, starting from the selection of the substances and ending with diverse aspects of development. We also help with the preparation of the dossier of the drug. So this is a document that will be submitted to the WHO to pass audit and get the pre-qualification status. And as I explained earlier, while getting the status of pre-qualification, there are a lot of advantages that NTP will have the access to the anti-TB drugs available in the country. So we will increase the compliance to the requirements to GNP throughout the country. We now also learned that Noble Farm Sonnet is interested to produce other anti-TB drugs. And we're talking about second-line drugs. And why it is interesting for the producer. So having the product which is pre-qualified by WHO, they can move to the international procurement systems. Thank you, Zmat. A very interesting presentation. for demonstration of new innovative approaches that seriously increase access to TB drugs. And I think it's very accurate, not only in Uzbekistan, but in all our countries. It's indeed new, interesting, and these steps are very good as education. Dear colleagues, we're coming to the final part of our session. We had very interesting presentations. Of course, they covered many themes. We started with funding, and there was very interesting metrics provided by Alisher on new approaches of public finance management. And we had very interesting model presented by Kazakhstan, where they promote the system of the single payer model and improvement of the comprehensive tariff for purchase of TB drugs. And within our conference, so we will have the third day on Monday, where we'll have the demonstration of the experience of funding of the TB services in Kyrgyzstan. And I think we will have a lot of details during the third day. So I invite everyone. There will be a lot of open discussions, interesting models, where we will learn about it not only as presentation, but also implementers of the system who will be happy to answer questions. And I'm sure that it will be interesting for us to discuss also it as an experience of your countries. Let me now give the floor to Alisher, please. Colleagues, thank you again. I fully support what Marat mentioned. Yes, for more than an hour, we've been talking and exchanging themes. As far as funding, Marat has mentioned about this, but regarding the rest of the component, like quality management of the TB drugs, it was also a very interesting topic. So that information and achievements that have been mentioned in the presentation, I think they are quite applicable, and we will have more discussion exchange between the services that work in the field of managing drugs. So my question is the following. I'm sorry, it's not a question. It's a very urgent issue. And another area that we received very interesting information about is the social order, state social order. I think this theme is not new, but at the same time, it is different than we had in the past for the social state orders. Within Central Asian region in Kazakhstan, this is very much implemented and there is good experience. Other countries like Kyrgyzstan also offered first grants, which is the stage of implementation, but other countries do not have it yet. So I think those lessons learned and experience shown on the slide about how to promote the state social order and how NGO can work under this mechanism, it was very useful. And I think that our colleagues from countries will take it as a good experience and directly exchange and obtain information. Once again, thanks a lot. So thanks a lot to our translators and organizers who helped us to have uninterrupted exchange of ideas. And once again, thanks to organizers of the conference. So basically, we don't have any questions in the chat and no questions in the Q&A. But I think still we have contact details, and perhaps you can send questions in the future, and we will try to cover them. Thank you very much. Now I'd like to give the floor to organizers, the hosts of this session. Thank you.
Уважаемые коллеги, тогда мы переходим к заключительной
части. Dear colleagues, then we move to the final part of the session 3 and 4. So we have the moderators, Dr. Khalif and Mahmudov, will start with the resume of your session, and then with Sharaf, we will move to our session. Thank you. Dilorom, we basically summarized Marat and me on our session. If there is a need, we can repeat that. Well, thank you. Well, those who participated in this session and those who didn't have opportunity, so we can tell them.
So the presentation was made by Anvar Giyasov, and in his presentation, he was discussing digitalization and the elements of the whole chain of TB services cascade by level. So what elements are planned to be added to the existing system of TB register, open MRS, and he also discussed the aspect system previously called TB alert, and it works nationwide on more than 50 GeneXpert devices in Tajikistan, and it makes it possible to establish connection with the planned LMIS, Laboratory Management Information System, and also in the real-time mode. So you can track maintenance of all GeneXpert devices. And there are broad functions offered by this very platform. Also, here discussed Prevent TB platform, and it's a mobile application used to track contacts, to refer TB suspects to testing. And so the clarifying question was asked and explanation was provided how the platform will later on cooperate with the existing TB register. One more platform was presented, I like VST, and the following presenter from NGO Intelish in Uzbekistan. So presented the accumulated experience in the country, and as we understand, Tajikistan only plans to start using that platform, I like VCT, for video-supported treatment. So the next presentation was made by Alexander Trubnikov on, oh no, I apologize. The next presentation, yes, by Alexander Trubnikov. on implementation of VST in provinces of Uzbekistan as part of USAID eliminating TB in Central Asia. So there were 2 pilots, as explained by Alexander, and subsequent rollout in Rizak and Oblast. So this platform is also based on the guideline previously adopted by all partners on video-supported treatment, and it's a part of the country's policy to establish the integrated electronic multimedia system in the country and in the area of TB control. Thanks to such platforms and applications, the connection later on will be provided between the TB register and these platforms for video-supported treatment. So the lessons learned in Uzbekistan by Etika project suggest that actually it was used for people with high level of adherence, and we are pleased to know that many patients enrolled in video-supported treatment were using their own gadgets, and they could use their own internet. And another lesson learned is that the VST use was not really successful in the most remote areas where the connection was not really good. And in fact, there was only one example of that when the patient got back to the directly controlled treatment. So they were not allowed to continue the VST to ensure effective continuation of treatment. And also they noted that health professionals, namely nurses, who were given tablets for VST, they mentioned that there was extra workload associated with that. So the next presentation by NGO Intelish, again from Uzbekistan. So the presentation was made by Dmitry Subotin, and he mentioned that video-supported treatment and the experience in Uzbekistan, on the contrary, have shown that actually the workload goes down because this approach is used as a routine. And the plan is in 2021, as I understand, this is a 1-year project so far. So they plan to enroll 50 patients. So far, they have 10 patients. And the application I Like VSC is what they use. And next, this presentation has some specific additional modules showing patients' treatment regimens, like what drugs they have to use. And in case of adverse events, there is the notification system suggesting how further advice to patients should be provided. And a lesson learned is that use of this application is way more effective compared to just statistical analysis made manually by health professionals. Then we heard the presentation by Panagul Juzebekova from Kazakhstan. She informed us on VST in Kazakhstan, which was initiated in 2016. And it was pilot tested in pilot districts. It was initiated by Partners for Health. And on top of that, the country has long been using TB registers since 2008. And a video-supported treatment. And the patients on VST are analyzed as well from the perspective of TB register. And the applications are not yet linked to the TB register, as I understand, but there are some connections and there are some references because they use the data in their quarterly reports and reports on the portal. And also the presentation on Kazakhstan mentioned that an alternative technique, one of many, for distance operations is the developed system for distant monitoring. This experience is available in the country already, and for the last 6 months, and actually the Global Fund supported it and the center. So some rounds of distant monitoring were conducted in the real-time mode, and actually it is very relevant in the times of the pandemic. And then we had the presentation on use of DHIS to TB tracker in Uzbekistan. So initially, Yuri Rogachev and Mike Frost, they made that presentation. So Mike provided an overview of DHIS. If I'm not mistaken, it's deciphered as the District Health Information System. So it's broadly used in healthcare. So initially, it was developed for health projects. And it's a very convenient, user-friendly, interoperable system. And it also can show you the results on the dashboards and generate various charts for analysis. So the system itself is very flexible, and based on that, TB tracker was initiated in Uzbekistan. So the work has just started this year. As far as I know, maybe my colleague Sharaf can tell you more. And then Yuri informed you on TB tracker and showed even the interface, how it all is done. And we could clearly see that, and the system clearly shows various geographical units, various classifications. So it's very flexible, since different types of information could be entered and adapted as needed. So in the very beginning, when the first presenter, Mike Frost, showed it, he showed like the example of COVID-19 vaccination. And then as for TB, we could see that this is being actively adapted in Uzbekistan. So the last presentation, but not least, was from Kyrgyzstan. It's about prospects of TB MIS in Kyrgyzstan. So Timur from USAID Cure Tuberculosis project made this presentation, and he showed the general charts and electronic government. He mentioned various ministries and agencies, and then the health information system, and then at lower levels, the TB information system. So he showed that it consisted of the electronic register, LMIS, the selected laboratory module, and the electronic medical record. And actually, he focused on each of their stages, and he showed how the interoperability is being ensured now. And it was interesting to see that in addition to LMIS, as for laboratory management information systems and the internal automation systems within the lab, there is a laboratory module which shows all testing techniques, not just bacteriology, but also general clinical tests like biochemistry and so on. So I guess it's very interesting from the standpoint of reviewing Kyrgyz experience. Well, I haven't seen such experience in other countries. We are in a patient's case file on top of bacteriology, when you can include other tests. I guess that was very interesting. And this is the end of our session. So I guess it was very informative, very timely. And Sharaf also has mentioned that now we are living in the times where all processes go digital, and I mean, now you can do a lot online without the need to wait for the offline mode. And video control treatment is recorded, and then time is shown. That's why, as for treatment monitoring process, clinicians can in parallel use such data now, and you can see if the patient use the drugs or not, because so far of critical importance is to make sure the patients really took their drugs. And in fact, such techniques also contribute to ensure high adherence and to treatment. So Sharaf, if you want to add, please. So thank you very much for this opportunity to moderate session 4. I would like to extend my gratitude to all session 4 speakers, which definitely was, so session 4 definitely was very interesting. And I would like to add to that detailed summary by Dilarom. Of course, these interventions by various organizations require coordination. And for example, DHIS2 tracker implementation and DHIS2 introduction in our country. So I guess we had that opportunity to coordinate the whole process, and our country's partners do that coordination as well. But as for VST, so the national protocol was established, and the the big working group was engaged with all stakeholders and to be controlled in Uzbekistan. And after the methodology was developed, the USAID project eliminating TB in Central Asia. So they progressed in their direction. Then NGO Intelligence is finishing their switch to the application, which was previously presented to national partners. And this product was developed by PAS Center in Moldova, and actually it became the most preferable. So this very application is being finalized, so it's being adapted, translated, then it will be tested and so on. As for VST, so the whole activity was supported by experts from WHO Regional Office for Europe, and the whole activity was well described and submitted as an application to the Global Fund, and it was supported by the Global Fund. So financing was provided as part for financing of mobile communications. So mobile devices were funded as well, and as part of round 2 applications for COVID-19, financing was obtained by the PIU and the National TB Center. So the Republican coordinator position was funded, and definitely it's an example of such coordination. And to finish my comment, I would like to say that digitalization of TB services, namely prevention and treatment. So you can highlight it all within one session. I guess jointly with our partners, we can organize a separate forum on digital solutions, because what was mentioned today during our presentations, limited in time, mean extensive experience accumulated so far, as well as lessons learned, the methodology, like how any given solution operates and how it is used by each and every country. So, I mean, it's a lot of knowledge and we can share it. And digitalization implies further expansion of operations and share this experience. I guess we can organize the special event in some format, and the countries have something to share and something to learn from their partners in different countries. And since we have regional projects, I guess they somehow could help us to establish those bridges between various organizations, partner agencies, and national TB programs, so we could stay the current state of affairs, and so we could outline our next steps in line with the Sustainable Development Goals and regional plans of WHO Regional Office for Europe in the area of digitalization. Thank you so very much. I'm grateful for this session. So if you have any questions, well, Alishera, do you have a question? No, it's not a question. So as I understand, our participants from session 4 joined the that's why. Well, actually, our summary was for participants of session 3. So I would like to highlight some of the aspects of session 3 for everyone, with your permissions. And of course, in general, Sharaf, you are right. One session is not enough. And we were discussing 3 major topics, quite sensitive and requiring more detailed and broader discussions. So the first two presentations were on financing. So the first presentation was mine, and it was about the initiatives currently implemented in Tajikistan with regards to the so-called matrix approach. So we are considering how financing is provided to ensure continuum throughout the whole chain. As an example, so the basis for the matrix is the document, and by the way, each country has it. It's like the benefits package, the basic package of services. And I guess if in Tajikistan, this experience is successful, and we can see some positive developments in this area. And I believe that the matrix-based approach could be used, and it's applicable for all countries in Central Asia. The second presentation was made by Kana from Kazakhstan, and we were discussing the complex tariff for TB patients, and we need to know that the complex tariff has long been in use in Kazakhstan, but the time has come when now we need to revise the tariffs and we need to use new approaches. So we could improve this methodology. And again, it was mentioned quite well that the matrix approach mentioned in the first presentation, well, we can use it just to highlight the minor problems, minor issues, or let's say barriers faced in the process of TB service delivery associated with financing,
that
and we tend to disregard them.
But they're very important. And the next steps were also informed about comprehensive tariffs in Kazakhstan and what they're planning to do in the future. And all of that is reflected by the National TB program. With that, our two presentations, two sections were over as far as funding, but I'm sure that we have the third day, which will be quite detailed, and interactively we'll be able to ask questions to our colleagues in Kyrgyzstan. And information will be provided not only by the institutions and organizations, but also people who work in the system of health, centers of family medicine and others, like service suppliers. Other presentation were related to involvement of the private sector, and Kazakhstan informed us about and that was Gulnaz from the Global Fund project. They showed us the state social order, so they demonstrated that they're quite independent and sustainable. And they demonstrated that they are good in case if the public health system cannot handle it. And Kazakhstan, we have generated pretty good experience as far as developing the lots, and they have provided us with some lessons learned. And I think it would be good for Central Asian countries to take them into account when they will be introducing state social orders in their countries. And the remaining three presentations were from Kazakhstan and Uzbekistan. They were related to another important issue, which is the quality of anti-TB drugs, which included the issues of registration, and providing the quality of the system. And it was interesting to learn from Kazakhstan so about the pharmaceutical system that takes into account all these aspects, and the information about the expedited registration of drugs in Kazakhstan. This is a very good experience, and it could be applied in other countries in order to promote these issues. The next presentation was provided by Uzbekistan, by Hassan Safayev, and he, I think, informed us about achievements of Uzbekistan, that Uzbekistan now has the opportunity to make procurements through the international platform, GDF, and how all the aspects related to ensuring quality of drugs is not really urgent anymore. And this experience that has been made as far as changing the legislation and regulations which are related to the registration and expedited registration of drugs. I think it would be good to make an exchange between the countries, because I know that countries are closely working on revising their legislative acts. And I think such exchange of information and documents and views would be very useful to expedite the process of improving legal acts. And the final presentation has been made by Azamat Katambekov, who presented the PQM Plus project by USAID. And it was interesting to learn. And we know PQM Plus works with the regulatory body, and we learned that in Uzbekistan now there are 2 state laboratories which test drugs and ready to be pre-qualified by WHO. So now region which has we have the only laboratory which is located in Karaganda in Kazakhstan, and soon we'll have 3 such laboratories, which is quite remarkable to know. We also learned about the collaboration with the regulatory body as far as expedited registration and change of the legal framework, and the experience of joining by the country to the expedited registration WHO strategy. It's interesting because some countries are only starting to look at it and start this work. In general, all these presentations as far as TB drugs, they had a logical sequencing, and they have shown that between countries, among countries, we have common challenges, but at the same time, certain solutions have been developed which could be applied among them, to eliminate the challenges or mitigate them. As I said, in total, we had 6 presentations for different 3 topics, and we tried to discuss it, but as I said, each theme deserves to have wider discussion in the future, so that we have detailed exchange of views and questions. Thank you. Thank you, Alisher. We're coming to 1300 in Tashkent. Our next session, the 3rd one, on introduction of new modes of treatment of drug-resistant TB, challenges, and plans. So all presenters will be outside of our region. So we will keep it to 1300, dear participants. If you need to get food and water, you can do it in parallel. But I think we will not move this session to the later because our moderator So we will plan it to 1300. So I invite everyone to this session. Thank you.
Yes, hello, it's Kathy Huison speaking here. I'm going to be moderating this session with Shibu. Could you just let me know if you can hear me?
I can hear you. I don't know if you can hear me.
Okay, so Shibu is having trouble to unmute his microphone. So perhaps I can just start by introducing this session for him. Would that be okay?
Yes, Kathy, please go on.
Good
Okay,
morning. I'm just joining in. So,
okay, go ahead, Shibu. Go ahead. Thank you.
good morning. Sorry for that initial hiccup. So I'm privileged to have my co-chair Kathy with me, and also I would like to introduce the panel of speakers. So we are going to have this plenary session on progress on uptake of new drug-resistant tuberculosis regimens, challenges, opportunities, and way forward. We have 3 speakers in this session. I'll just introduce the speakers and how we are formatting this thing. Kathy will summarize after the all the sessions the speakers have spoken about, and then we both will be co-facilitating the Q&A sessions. So the first speaker is Dr. Ford from WHO. He'll be speaking about overview of the short regimens of DS and DRTB. Just give me a moment to introduce Dr. Ford in detail. Dr. Ford is the TB team lead for TB treatment team on Prevention, Diagnosis Center, Treatment, Care and Prevention Unit, Global TB Program, World Health Organization, Geneva. He also leads the treatment team of WHO Global TB Program Unit on prevention, diagnosis, treatment, care, and innovation. He joined WHO in 2004 and his main areas of work were drug-resistant tuberculosis, access to second-line anti-TB medicines, coordination of multi-country projects to expand access to innovative TB diagnosis and new TB medicines, and policy development on TB infection prevention and control, and treatment of drug-resistant tuberculosis. It's quite a lot, in fact. Prior to joining WHO, he has worked for International Committee of the Red Cross. Our second speaker is Salah, Florida. He's the Senior Director, Head of Medical Affairs. He will be talking about the CENIX trials. Salah is the Senior Director, Head of Medical Affairs, TB Alliance, which is a global alliance for TB drug development. Salah is a physician with 20 years of combined experience in clinical practice and leadership roles in medical affairs and clinical development departments at multiple pharmaceutical corporates across several therapeutic areas. Its role in TB Alliance includes defining the medical affairs strategy, collaborating with public health agencies, scientific community, and global partners to bring TB-approved regimens to patients. Dr. Firaida earned his medical degree from Cairo University, a Master of Science in Infectious Disease from Georgetown University in Tashkent. Salak, happy to have you again, like we keep meeting again and again. And our third speaker is for this session is, give me a moment, let me just searching for it. Is Ilera Mota from MSF. She'll be talking about the TB practical study. Dr. Ilera is an infectious disease physician with experience in managing HIV and TB infections in different settings. She works as a medical monitor for TB practical clinical trial, which is done by MSF UK, and clinical advisor for NTB clinical trial from MSF France. She has completed her PhD project focusing on pharmacokinetics of TB drugs and currently undertaking MSc in public health and in London School of Hygiene and Tropical Medicines. Dr. Ilera, eager to listen to your talk. Our fourth speaker is Catherine. She's also co-hosting with us. Hi, Catherine. Catherine is a TB advisor and TB working group leader in Medicine Science Frontiers. She's a medical doctor working as a tuberculosis advisor in the medical department of MSF Paris Operation OCP. Since 2005, this role includes advising MSF projects worldwide. She has a particular interest in introduction of beta-acyl and laminate and repurposed drug to improve outcomes, and which is she's going to talk about the repurposed drugs here. Happy to have all the speakers, and looking forward to for insightful presentations. Over to the speakers. Kathy, you would want to come now, or you'll?
No, I think let's get into this session. It's very exciting. Let's get on with it. Thanks. Go ahead, Fuad.
Perfect. Go ahead, please.
Thank you, Kathy, and Shibu. Just please let me know if you can hear me well.
Yes, perfect.
Yes,
great.
Yes, perfect.
Thank you very much. Good to see everyone. Again, thank you to organizers for inviting me. I will be sharing my screen now, and will be grateful if you can just tell me if it worked and if you can see it full screen.
Yes, we can see it well in full screen.
Great. Thank you very much, Kathy. So I'll just go ahead then, and we'll try to provide you an overview of this of the new shorter regimens, both for drug susceptible and drug resistant TB. Quite exciting progress, and also we'll try to give you an overview of all things that are related to the TB treatment, the challenges and opportunities we have lying ahead. So just to start, perhaps is to tell that for more than 20 years, the WHO Global TB Program has been developing new and updated treatment guidelines and related documents. So for example, definitions and implementation handbooks, these guidelines do address treatment of both drug-susceptible TB and drug-resistant TB. Starting in 2019 towards 2020, the Global TB Program of WHO started the process of consolidating these guidelines into one more updated documents with a specific structure, and that for that probably the drug-resistant TB guidelines is a good example. So the the guidelines that were released in 2020 include chapters and recommendations that are still valid from previous developments, but also they include new recommendations that that come from the new evidence, shifting basically almost all TB treatment and almost exclusively towards all oral regimens, and more specifically towards two shorter 9 and month options for certain groups of patients and under certain conditions. And you see these regimens, these main changes that are being highlighted in red on this slide. In relation to drug-susceptible TB, we have the treatment related recommendations are still in two documents, the 2010 and 2017 guidelines. But following the guideline development group meeting in April this year, that was mostly dedicated to the new 4-month regimen, we are working, and also another guideline development group meeting that happened in June, focusing on childhood related TB topics. We are working on consolidating these guidelines, the recommendations that are still valid, and the new ones into the consolidated document that I think we'll manage to get it released before end of this year. That will include several topics like the treatment of drug-susceptible TB using 6-month regimen, the treatment using 4-month regimens. It will include recommendations related to TB treatment using fixed dose combinations, on dosing frequency, on treatment of TB HIV co-infected patients, and also some topics related to extrapulmonary TB. It is talking about TB treatment, it is almost impossible not to mention several other normative and ancillary documents that I would highlight the following. We have updated the extensively drug-resistant TB definition in this year. The outcome definitions for TB treatment, both drug-susceptible and drug-resistant TB, and they are more standardized, possibly easier to implement now. We are gearing towards getting the two big systematic reviews on dosing of first-line medicines for both adults and children. These reports will be released before end of this year. And also there is some work ongoing on updating the definitions and reporting framework that was last released in 2013. And soon we are going to embark on the update of the so-called target regimen profiles for TB treatment. There are some new developments this and next year that are probably worth to mention. Some of them have already been announced via rapid communication documents that you have probably seen. In the area of drug-susceptible TB, it's the 4-month quinolone-based regimen and 4-month regimen for children with mild TB disease. In the area of drug-resistant TB, we are preparing for the new guideline development early next year that will look at the data from TB Practical trial, focusing on BPAL plus moxifloxacin regimen. We have the data, therefore we'll look at the possible update of the all oral shorter regimens for drug-resistant TB, and with some new data that we are receiving from the technical partners, is we will look at the update on BPAL regimen for pre-XDR TB, focusing on its use of this regimen, duration of its components, and the dosing. Some new developments related to the handbooks and other normative documents, because the emphasis that we want to be made on this kind of documents that can facilitate implementation in countries, can facilitate reporting or provide direction for development of new treatments or treatment regimens. So as you have probably noticed, there was never a specific operational or implementation handbook for drug-susceptible TB. We are developing one that will be paralleled and related, of course, to the new consolidated guidelines on drug-susceptible TB, and it will include implementation aspects, selection of treatment regimen, and dosing of component medicines for drug-susceptible TB treatments. There is a handbook on drug-resistant TB treatment that obviously will have to be updated if we update the guidelines with the new implementation aspects or some new sections possibly. As I mentioned earlier, the target TB regimen profiles document will be updated. That requires fairly complicated process of the review and consultation with experts. The definitions and reporting framework will be updated, and also just important to mention in addition that together with KNCB, our technical partner in the close collaboration, the new DRTB training modules are being developed and will be also appearing on WHO training dedicated website before end of this year. So with all these recent developments included, we are moving towards a new mapping of TB treatment regimens with different possible options depending on drug resistant profile, depending on the age of the patients and disease severity. So probably clinicians are more used to this multiplicity for different situations in drug resistant TB, but now in addition to the standard of care for many years, 6-month regimen, we will have new 4-month regimens that will be options for use. Well, however, I would say that the global pipeline for TB treatment is as you can see, as it was updated in last year, global TB report, it will be updated when the this year report is released. The pipeline is more active than before, with many research studies in their final stages. While the landscape looks very full and promising, we also should remember that research into new medicines or regimens has a rate of attrition, and not all developments might be successful. Nevertheless, it is quite heartening that research into new treatment is such a dynamic place, where we see a fairly small number of new compounds undergoing research, which is doesn't make us happy, I would say. The majority of the studies, especially those in more later stages of the development, focus on new and shorter regimens with different dosing of known medicines or new combinations. Many studies, unfortunately, we have to wait. They have the target end dates of year 23 and after. We have seen very clearly that the COVID-19 pandemic disrupting many parts of our daily life has also delaying, has also been delaying results from the clinical research, and quite significantly. It is a good thing that there is a growing and vibrant area of operational research in TB and newer regimens that may generate data perhaps earlier than the clinical research. So we are very much looking forward to that. From our side, we are increasing efforts to stimulate the research by collecting the individual patient data, as we have done with the recent public call, and we'll be enhancing this platform to facilitate access of all external researchers to it. This global resource will continue to be used for WHO guidelines development, of course. But we want to have more easy access to this resource for external researchers, and there will be some announcements on that in the near future. So, before concluding this fairly brief presentation, I would like to note some challenges and opportunities in the field of TB treatment. We have, it's not a secret that we are not happy with the length of the regimens and the toxicity profiles of especially regimens for drug-resistant TB and all drug-drug interactions that we are currently seeing. But we also see a clear trend toward shortening for all regimens, be it for drug-susceptible or drug-resistant TB. There are new medicines in the pipeline, perhaps, and hopefully they can help to improve the toxicity profile and make it easier for patients and the TB programs in countries. The timelines of clinical research is rather lengthy, and we still, although it is a dynamic space, as I said now, but we also see an increase, something that we haven't been seeing before, of operational research, which is great. The new regimens and some developments require probably put the higher requirements on the drug susceptibility testing. But we also see some new and rapid drug susceptibility testing options that are becoming available. But the most important challenge that stands out in this very dynamic space, I think it's an implementation of the change that we all need to contribute as a TB community and make sure that it happens quickly. So in conclusion, we see several new and shorter regimens that will need to be implemented widely. Now, we'll be working on the target regimen profiles for TB treatment, the document that we hope will help guiding future regimenal developments for technical partners and the industry. We see a pipeline of clinical and operational research eager to develop and generate new evidence. And I think the well-established and regular WHO policy development process will bring these new updates. So we really, just coming back to the first point, we will have to make all the needed additional efforts to implement this innovation widely. So with this, I want to thank you all for your attention, and happy to address any questions that people may have.
Thanks, Dr. Ford. That was actually a very interesting talk, and good to see that the target regimen profile is rich, and then your positioning for more operational research is wonderful. So we'll take the questions by the end of the session. So please hang around till the end of the session. So Kathy will facilitate that session. So I'm happy to hand over this session to the next speaker, Dr. Salah Farida, who will be talking about the experience of Xenix and findings of the Xenix clinical trials and operations research on VPAL in EECA Southeast Asia region and Africa. We're talking about the similarities and differences in experience and learnings. Over to Salah. Happy to have you here.
Yeah, thank you so much and happy to be part of this. Good afternoon, everyone. I will share my screen. So please let me know if you can see it as full screen.
Yes, it's good. Great,
thank you, Fuad. So my name is Salah Farida. I work for TB Alliance, and TB Alliance is a non-for-profit organization dedicated to the discovery, development, and delivery of better, faster-acting, affordable TB drugs. Today, I'll be giving an update on the BPAL regimen, or pretomanid in combination with bedaquiline and linezolid in drug-resistant TB. And as you may know, pretomanid was developed by TB Alliance. So we just presented 2 months ago the XENIX trial at the International AIDS Society in July 21st of this year. And just to give you a background on XENIX, XENIX was a follow-on trial on a previous trial called NIX-TB. And in NIX-TB, which was conducted in highly resistant TB patients, we saw a high efficacy of 90% of participants had favorable outcome. But with this high efficacy, we also observed high rates of 2 adverse events related to the use of linezolid. First one is peripheral neuropathy, occurred in almost 80% of participants in NIX-TB trial, and myelosuppression or anemia, which happened on almost 48% of participants in NIX-TB. However, with this high efficacy, and because peripheral neuropathy and anemia resolved with time, and with modifications to linezolid dose, the BPAL regimen was able to get approved by FDA, the European Medicine Agency, other countries, and it was actually recommended by WHO for operational research. The study design of XENIX, the newer clinical trial, was a phase 3 multi-center, partially blinded, randomized clinical trial with 4 arms. Bedaquiline and pretomanid were not blinded because it's the same dose and duration. However, linezolid was both dose and duration were double-blinded in this trial. So the 4 arms, we wanted to see if the first arm here, which was similar to NIX, which we used 1,200 milligram of XENIX for 6 months, of linezolid for 6 months. That arm is similar to the NIX-TB trial. And then the other 3 arms, we used 1,200 milligram of linezolid for a shorter duration, 2 months instead of the 6 months, or 600 milligram instead of the 1,200 milligram, which means half the dose for the same duration of 6 months, or half the dose and shorter duration, so 600 milligram for 2 months. The bedaquiline and pretomanid will be for 6 months, same dose, same duration. Participants in this trial were XDR or pre-XDR. And when I say XDR, I'm using the old definition by WHO. According to the new definition, all these are considered pre-XDR, and also NDR-TB patients who are not responsive or intolerant to MDR-TB treatment. The duration of treatment is 6 months. The protocol allowed the duration of treatment to be extended beyond 6 months to be 9 months. However, only one patient in this study, one patient out of 181 patients, needed to extend treatment from 6 months to 9 months. So less than 1% of patients usually need to extend beyond the 6 months duration of treatment. The primary endpoint, which I am presenting today, is here, 6 months after end of treatment. And there is a secondary endpoint as well, which will be 18 months after end of treatment. This could be available in a year or two from today. That will be the full evaluation of Zenix study with this secondary endpoint. However, I'm presenting today the primary endpoint. All patients reached 6 months after end of treatment. Predominant dose is 200 milligram daily. Bedaquiline dose is different from label and different from NICS and TB Practical, and it's based on our clinical experience, and this is published. We used 200 milligram once daily for 8 weeks, and then 100 milligram once daily as well for 18 weeks. The idea here is we have clinical evidence that support this. It's the same exposure, and this is once daily throughout the trial. And once daily, we believe it's more convenient for patients if they are taking pretominid and linezolid once daily. Then taking bedaquiline once daily will be more convenient, easier, and it may help in the future to do the fixed dose combinations. So, and there is a reference for this. So bedaquiline dose is slightly different from the label and from NICS and TB Practical as well. The primary endpoint, as I said, is both clinical and microbiologic status 6 months after end of treatment. And the outcome is either favorable outcome, which means cured, or unfavorable outcome, which means everything else. Any clinical failure during the treatment, any bacteriologic failure during the treatment, or any bacterial relapse after the treatment, or any withdrawals, alternative treatment, or death during the trial. As I said, 181 patients, males and females, 14 years or older. In Moldova and Russia, it was 18 years old, 18 years or older. And participants had pulmonary TB, so this was investigated for pulmonary TB, not extrapulmonary TB. Majority are XDR and pre-XDR. Now they can be defined as pre-XDR, all of them, with some MDR patients who are not responsive or intolerant to treatment. The key exclusion criteria can be found here in clinicaltrials.gov. However, the main thing was these T or MICs that suggest resistance to any of the three drugs or delaminid. So to exclude any resistance and any previous exposure to bedaquiline or linezolid for 2 weeks or more. Also to reduce the possibility of having resistance to these drugs. And this 2 weeks exposure, previous exposure, I'd like to say that it was the same in NICS, and the WHO guidelines were based on this criteria. However, with the increased use of bedaquiline and linezolid, we see some countries being more flexible with this bullet. So 181 patients from 4 countries. We see 66 patients from South Africa, 34 patients from Georgia, 71 patients from Russia, and 10 patients from Moldova. Good geographic distribution between South and North. We have the 4 arms here. from 1,200 milligrams of linezolid for 6 months to the lowest dose 600 milligram for 9 weeks or 2 months. 45 patients in each arm in 4 countries. This is the baseline characteristics for Xenex. As you can see, participants who were HIV positive were 20% of participants, almost all of them from South Africa. Also, for pre-XDR and XDR, using the old definition, both can be considered now pre-XDR. It's almost 89% or 90% of patients with pre-XDR, and 10 to 11% with MDR, either non-responsive or intolerant to treatment. 2/3 of males, 1/3 of females, and 2/3 were white, 1/3 were black in this trial. This is the primary efficacy analysis, which is 6 months after end of treatment, using both clinical and bacterial conditions. If you look at the favorable, which means cured 6 months after end of treatment, between the arms, you'll see 93%, 88, 90, 84. The overall is 89%, which is very similar to what we saw in NICS. In NICS, it was 90% as well. So the high efficacy is confirmed in Xenex. Xenex is confirming the high efficacy we observed in NICS here, with almost 90% favorable outcome. The unfavorable outcome is 19 patients, or 10.7% here. And I can describe these 19 patients of unfavorable outcome in the next slide. This is the confidence interval for the favorable outcomes here. And as you can see, all confidence intervals are overlapping, very wide and overlapping. The study was not designed or powered to differentiate between the 4 arms. And the numbers in each arm were small. So what we can say is we see a trend that it's almost around 90%, but we cannot, the study was not designed to differentiate between the arms. In this slide, it's same numbers. Here are the favorable, almost 90%. The main objective of this slide is to describe the 19 patients, or the 10% unfavorable outcome, which is here. As I mentioned before, everything else other than cured will be considered unfavorable. So loss to follow-up, withdrawals due to adverse events, withdrawals due to investigator decision, sponsor decision, or patient decision, all are considered within the unfavorable outcomes. We have 1 treatment failure, 1 patient with treatment failure, which means that the culture was never converted from positive to negative. This is confirmed treatment failure. And we have 4 confirmed relapses within the study, which means that the culture was converted from positive to negative and then reverted from negative to positive. And it was confirmed by genetic analysis that it's the same bacteria. So in total, we have 5 failures and relapses out of the 181, and these 5 are within the 19 patients here of unfavorable outcome. We also have 4 cases of retreatment, and as I said in the protocol, any alternative treatment will be considered unfavorable. However, these 4 cases were the culture was converted to negative, so culture was negative. Clinical symptoms were negative, no clinical symptoms. However, based on CT findings, investigators in Russia decided to surgically remove the scars based on CT findings, and that's why it had to be considered as unfavorable. In Xenix and in Nix, we relied more on the bacterial status and clinical status of patients rather than CT scans. One of the secondary endpoints as well was the median time to culture negative, and these are the 4 arms. The median time was 6 weeks overall. Actually, it was 4 weeks for 3 arms and 6 weeks for the 600 milligram 9 weeks or 2 months arm. The overall is 6 weeks median time, sometimes before 6 weeks, sometimes after 6 weeks. And by end of treatment, which is this red line, almost all cases were negative, except this one patient, which is the treatment failure, never converted to negative. If we move to safety, and the main objective of this trial was, can we maintain the high efficacy of BPAL while improving the safety if we change or modify the linezolid dose? The main 3 adverse events related to linezolid are peripheral neuropathy, optic neuropathy, and anemia or myelosuppression. For peripheral neuropathy, you can see the overall percentage for peripheral neuropathy is 24.9 or 25%. This is way lower than what we saw in Nix. And this 25% is actually mainly driven by this arm, which is the highest dose, longest duration of linezolid. And this peripheral neuropathy decreases when we reduce the exposure to linezolid dose or duration. Actually, in this arm, the South Africa arm is very similar to what we saw in Nix. For optic neuritis, again, we saw 4 cases of optic neuritis. All of them are in this arm, the 1.2 6 months of linezolid, 0 in all other arms. And actually, this is similar to what we saw in Nix. We saw 2 cases of optic neuritis in Nix, which is this arm as well. However, these 4 cases and the 2 cases in Nix completely resolved when we stopped linezolid. And they usually happen at month 4 or 5 after initiation of treatment. So late onset, delayed onset, and they resolve by stopping the linezolid. If we look at anemia, which is also related to linezolid, the overall here is 12% of participants had worsening anemia. And again, it's more in the this arm, which is the highest dose, longest duration. And it decreases when we reduce the exposure. Anemia usually happens early in the treatment, 1st or 2nd month after initiation of treatment. So it's important to monitor the CBC. For optic neuritis, usually happens at month 4 and 5. For peripheral neuropathy, also delayed onset with linezolid. This slide describes the modifications needed during the trial for linezolid. And it makes sense that, and when I say modifications, it means either linezolid reduction, temporary interruption, or complete permanent discontinuation of linezolid. If it makes sense that 50% of patients who started with the highest dose, full duration of linezolid, needed to modify their doses, either reduce, interrupt, or stop linezolid. And this percentage decreases when we go from left to right, or from the highest dose, longest duration, to the lowest dose, shortest duration here. So this is very top-line results. We're still doing additional analyses analyze these data, but in general, we see a high efficacy as we saw in NICS, and this high efficacy is across all 4 arms. And it appears that maybe lower exposure to linezolid may be associated with lower number of adverse events. The highest dose for 26 weeks or 6 months had more adverse events, especially neuropathy, was mainly driven by neuropathy, and all 4 cases of optic neuritis, thankfully all of them resolved, but all of these cases were in this arm. So based on that, we think that we can maintain the high efficacy with somehow improved safety if we use lower exposure to linezolid than 1200 milligram for 6 months. Again, this is very early analysis. This is my last slide. I'm just mentioning TB Practical here because it's again using the BPAL regimen. I know my colleague in Ilara from MSF will be presenting about TB Practical. What I want to say here is in TB Practical, participants had at least rifampicin resistant. So from mono rifampicin resistance to MDR, PXDR, everyone with resistance can be recruited in this trial, which is different from NICS and XENIX because NICS and XENIX were more for highly resistant TB, XDR and pre-XDR. Also, it was two stages.
Sorry, can I interrupt? I think we
Yes.
can leave it to Ilaria because we're running short of time. Let's get on to her too. So just wrap up. Thanks a lot.
Okay, thank you. Last but not least, I would like to thank all patients who participated in our clinical trials, all donors and funders, and happy to answer any questions after all sessions. Thank you.
Great, thanks very much. That was a really great presentation, very nice and clear. So let's go on with no further ado to the next presentation by Ilaria Motta, who will present the Practical trial. Thanks, Ilaria.
Thank you, Katie, and thank you, Sarah. You kindly take some of my slides. So I hopefully I'm going to share my screen. Just 1 second. I want to show this one. Okay. Share. Can you see my screen? Oh, they are sharing in Russian, probably for everybody. I just want to share. Okay, they are presenting in Russian my presentation. I'm not sure if the panelists prefer to have in English. Just let me know what to do. Otherwise, I'm gonna.
I think you can go ahead, Ilaria. Thank you. Yeah, go ahead.
Yeah. I'm just open on my side in English.
Sure.
Okay. Thank you to the organization for this invitation. As a TB Practical group, we are really proud to present this talk here in Tashkent, unfortunately not in person, because as you probably know, our site in Uzbekistan make a major contribution to this project. Please change the slide because I cannot have control on that. Let me check. Sorry, guys. Oh. Can you please? Okay. They also ask you to start your video. Okay. Probably now. Sorry.
Okay, so we now see your English version, so perhaps you've got the hand now toward the slides, Laura?
Okay, so now you can see my
English, yes.
Okay, so I think, okay, so I continue receiving message. Okay. So during the last TB Day in March 2021, WHO released this information regarding early stop of randomization in our trial. And in order to show why we arrived to this decision during my talk in the next 10-12 minutes, I'll share some premises and structure of TB Practica with particular interest to Uzbekistan. So over the last years, substantial progress has been made in rifampicin-resistant tuberculosis, especially in outcome rates through operational research, as Fuad was saying. But rifampicin-resistant TB burden across the world is high, and in many parts of the world, duration of treatment is still 9 to 18 months. With toxicity and significant burden. So treatment success rate from last TB report in Uzbekistan is around 61%. And MSF and a group of TB doctor back in 2014, so yeah, 7 years ago almost, they believe that drug-resistant TB treatment could be as good as it is for drug-sensitive TB with a duration of 6 to 9 months, all oral treatment that might have a treatment efficacy of rate of around 90%. And from this, the idea of TB Practica was born. So from these premises, a randomized control open label phase 2, phase 3 trial was born. And this was evaluating newer drug as bedaquiline and pretomanid for the treatment of patients with pulmonary multi-drug tuberculosis comparing to the standard of care. So the investigation arm consists of a backbone of, as mentioned, bedaquiline and pretomanid, bedaquiline given as Salah was saying, but also a more established treatment for drug-resistant tuberculosis, linezolid. It was given 600 till week 16 and then decreased to 300 for the remaining weeks. And the patient took an investigational regimen for a period of 24 weeks. And the control arm is a locally accepted standard of care, which was consistent with the WHO recommendation of multi-drug pre-XDR tuberculosis, and of course change it over time. So we implement new standard of care during the trial. And from the beginning of the trial, patient had access to the shorter injectable MDR TB regimen, or in South Africa to the all oral regimen, and also to bedaquiline and delamanid, where these drugs were available locally. Of course, to realize this project, multiple collaboration, both with national and international partners have been set up, including academic institutions as London School or UCL in London, and also other research organizations and independent committees for steering and scientific advice. Sites were selected based on operational and or research experience, rifampicin-resistant epidemiology, and existing local collaboration. So we set up sites in a number of different countries, Uzbekistan, Belarus, and South Africa, with diverse epidemiology, both for drug-resistant TB and HIV, and as you all know. So the first site was open in Nukus, Uzbekistan, in January 2017, And the following year, we opened a second site in the country, in Tashkent. And we have a total of 6 sites, 3 sites in South Africa, plus 1 satellite site in South Africa, 2 sites in Uzbekistan, and 1 in Minsk, Belarus. So a tailored approach has been used for each site. Specifically for Nukus in Uzbekistan, we implemented the trial as an MSF project. Investigators are both MSF and MOH staff. And over the year, we extended our catchment area to Nukus Rayon and Free Rayon in the surrounding. At the site also, we conducted a qualitative study on the recruitment experience. And this paper is now has been submitted to trials, so soon to trials journal, and so soon we will able to show results. In Tashkent, the trial has been implemented at the TB Institute, and MSF supports MOH investigator from logistics, supply, and training side. Of course, in both sides, a close collaboration with MSF coordination and NTP with MOH is ongoing. So activities such as infrastructures upgrade, training according to GCP requirement, development of a quality system have been carried out to set up the project at various sites. And the monitoring of site is done both by sponsor and also by external partners with TPH. Unfortunately, due to COVID-19, some activities have been disrupted, and we try to minimize as much as possible consequences both for our participants and for our project, implementing tools such as phone visit, video observe therapy at every site, and remote monitoring visit. So going back to the details of the trial, after the setting up of the sites, the trial began with 4 arms, 3 investigational arms and a control arm. The primary objective of stage 1, that is the phase 2 of the trial, the primary objective was to identify the most promising regimen to take forward to stage 2. And specifically, we were looking at the safety and efficacy outcome after 8 weeks of treatment. And we randomized 60 patients per arm and had a pre-planned analysis at the end of this recruitment. And the analysis was done only on investigational arm at this stage. Stage 2 has the primary outcome measure as a composite of unfavorable outcome that include death, treatment discontinuation, loss to follow-up, treatment failure, recurrence, or withdrawal from the trial. And depending on the results of stage 1, we aim to look at 1 or 2 investigation arms compared to the standard of care. So we plan to include in the second stage 201 patients in the 2 or 3 arms that would have passed from stage 1 to stage 2. And in terms of how the stage 1 to stage 2 decision proceeded, DSMB, that is Data Safety and Monitoring Board, that was completely independent from TB Practical Steering Committee, was provided with unblinded data and asked which of the 3 regimens were eligible to go to stage 2. And all the 3 regimen, investigation regimen, met the pre-specified criteria for stage 1 outcomes. Okay, so from this, the Scientific Advisory Committee were provided with blinded data, and from that, regimen 1 and regimen 2 were found to be the most promising to take forward to stage 2. But due to challenges that we having at the time with recruitment and of course COVID-19 pandemic, was decided only to take forward just 1 investigation arm, and was chosen arm 1, that is BPAL plus moxifloxacin. Going forward, during our quarterly review from our Data Safety Monitoring Board that was done in February 2021, the DSMB looked at data that was up to the 31st of December 2020. So shortly after all the sites transitioned to stage 2. And data from our 242 patients was included, looking at the outcome measure of the study and late exclusion. There was also data available to the DSMB from an additional 229 patients in the experimental arm 2 and 3, and all those patients will continue to be followed through week 108. So based on the review, the Data Safety Monitoring Board unanimously recommended termination of randomization in our trial. And that was based on guidance that was being given at the beginning of the trial from the charter. The stopping should be considered if there was a difference between randomized arms of at least 3 standard deviations in the intermediate analysis of a major endpoint that could have impacted clinical practice. And specifically, this can be considered that that level of evidence was achieved and that it favored the experimental arm over the standard of care. So arm 1 versus control arm. And that was principally driven by the higher rate of treatment discontinuation in the control arm. There were no episodes of recurrence or treatment failure in either arm. So being provided with the extraordinary information, the steering committee followed the DSMB recommendation and terminate the recruitment in the trial in all the sites on the 18th of March 2021. And these are the final numbers of patients recruited across the stage and per arm in all the sites in the first table, and at the Uzbekistan site in the orange table below. I'm almost at the end of my presentation. This is the timeline from when the first patient was enrolled, and end of randomization was not expected to happen until sometime later this year. And in green, the dot green are the planned activities for the next future. Sorry, there were some slides going on. So to conclude my talk, I just want to highlight that only with a great collaboration with national and international partner is possible a study like this one. And it's very unusual for a study to be stopped on the premise of efficacy. We invite all of you to the next Union conference where we will present results from stage 1 and stage 2 of the study that will be taken on the 22nd of October. WHO will receive our data together with data from similar study to update, as Fab was saying, rifampicin-resistant TB treatment guideline later this year. And considering the extraordinary outcome, MSF is currently developing collaboration to scale up the regimen as operational research in other settings, prioritizing our site countries. Here are all the collaboration I mentioned before that made this study possible. And last slide is to acknowledge a particular thanks to our participants without whom TB Practical would not have been possible. Thank you very much for your attention. I'm glad if you have any questions. Thanks.
Thanks, Hilary. That was very exciting. So as all the TB physicians and the TB warriors looking forward to a universal TB drug regimen, this is a way forward to that. And we are also eagerly looking towards the policies will get synthesized in the guidances of WHO. Thank you. Thank you so much. We'll take the questions at the end of the session. So Kathy, the floor is yours. You can talk about the off-label to routine. Thank you.
Great, thanks very much. Just let me know if you can see my screen in full screen. It's okay.
Yes.
Great, thanks very much. Okay, so thank you, very happy to follow on from those three excellent presentations. So I'm going to share some of the results from the NTB observational study. So there's also an NTB clinical trial, which is 2 clinical trials ongoing, NTB and NTBQ, and they do not have results yet. So this is an observational study, and I hope it can highlight some of the additional information that observational research can bring to the care of patients with DRTB. So the NTB study is a collaboration between 3 partners in health, Médecins Sans Frontières, and Interactive Research and Development, and was funded by UNITAID. So I'm going to go over a little bit of the characteristics of the patients in this big prospective observational cohort, and some of the information that allowed us to use bedaquiline and delamanid in what was at the time called off-label, but expanded the use so that we could use them together, we could use them for longer than the initial 24 weeks that was recommended. We'll talk about the outcomes, and we'll just talk about quickly at the subset of children and adolescents. So it was a study conducted in 17 countries, many of them in this region, as you'll see by the map. And it's a prospective observational study, meaning that we had a common protocol, we had a common data collection and database, and you can see by the numbers up at the top there, over 2,700 patients were enrolled, almost 2,000 received bedaquiline, 1,000 delamanid, and many of them, over 60%, had more than the initially recommended 24 weeks at that time, and a big percentage had both of the drugs. A very important part of the NTB observational study was the monitoring of the patients for safety, and we had a specific pharmacovigilance unit in Geneva that collected all serious adverse events from all 17 sites. So this was a really added value of the intensiveness of the pharmacovigilance that was performed. So let's talk a little bit about the cohort. First of all, the characteristics. So as we can see, the patients were, for the most part, had serious disease. So a third of them had a low BMI. About 10 to 15% had other comorbidities. Many of them, 2/3, had been previously treated with second-line drugs and had extensive disease on radiography, and more than half of them had fluoroquinolone resistance. And this really reflects at the time the recommendations for these 2 drugs was at that time restricted to these groups of patients. So I already mentioned that the over 10% of patients got both drugs. And just here you can see that other commonly used drugs were what were called at that time repurposed drugs. Inclusions finished in 2018, but which were now engineered as Group A and clofazimine as Group B, as is cycloserine. And you can see that 2/3 of patients had some of those drugs. And only 40% had injectables, mainly because most patients have been previously treated with those. So let's have a look at some of the outcomes. So overall, we've got a 78% favourable outcomes. And we did an analysis of what patients were likely to have unfavourable outcomes, or less likely to have a favourable outcome. And this is one of the advantages also of observational research that I think is important to talk about, is that in observational studies, we include everybody who needs the drug. So patients who would not likely get into clinical trials end up getting into observational studies, and it's really important. So we had high percentage of those very challenging patients to treat, patients with drug addiction, alcohol addiction. We had high numbers of patients with hepatitis C in the Eastern European region, and patients who are very, very ill. So patients who may not have got into clinical trials, and we found that patients were more likely to have unfavourable outcome if they had hepatitis C, and that was across all the unfavourable poor outcomes, deaths and failures. And obviously things that we're already aware of, prior exposure to second-line drugs and high smear growth and cavity disease. There's nothing new there. But what was really interesting and really great was to know that the baseline resistance that patients had wasn't a predictor of the outcomes at the end, meaning that the extensive resistance was overcome by the drugs. But these other subgroups, it's really important that their inclusion in clinical trials should be increased, given that they are patients we want to know if these regimens are going to work or not. So looking at the safety, so this is a list of what we call adverse events of special interest, and they were particularly followed in this study. And we can see that QT prolongation, which was something that concerned everybody initially when these drugs were first available, was one of the, in fact, the least frequent, along with optic neuritis, or least frequent of the adverse events of clinical interest. But what was very frequent was peripheral neuropathy, and I think results that have just been presented from ZNICS are also very, very consistent with that. Although we had 25% of patients experience at least one episode of peripheral neuropathy, which is a very important number. And we can also see, as probably no surprise to anybody here, that those adverse events that were linked to injectable drugs, so hearing loss, renal failure, and electrolyte depletion, they were very, very common, with 23% of patients experiencing that. And when we look at the incidence of these adverse events whilst on a drug of interest, so here we can see patients who experience at least once peripheral neuropathy, myelosuppression, or optic neuritis. Out of those patients who are on Linzolid, you can see that 26% of them experienced it. And you can see here in the last column, the incidence is very high, with the highest incidence being amongst those patients receiving injectables and experiencing those injectable-related adverse events of interest. So, as I said, we were able to, because these were individualized, longer regimens, we were able to, in some settings, use drugs as at that time was called off-label, and we were able to do some analysis. And we can see, for example, for the QT prolongation, there was a big concern that bedaquiline and delamanid together would cause more QT prolongation. But you can see in this first column here that there was absolutely no excess of QT prolongation in the patients who received both drugs compared to the patients who received only one of them. So that was very reassuring. I think that's reflected also in some recent clinical trials as well. And we also compared this difference after adjusting for some risk factors, and there was no difference. And this just shows again the same thing, that the probability of experiencing QT prolongation according to the baseline regimen didn't change whether you got both the drugs or just one of the drugs. And then there was a big number of patients who really needed a longer duration of bedaquiline or delamanid, because they were really patients with not many effective drugs left available to them. And for the clinicians, it made sense to continue bedaquiline or delamanid, given that the tolerability and the safety was so good. And so we can see in this analysis, for example, we looked at the patients who had just the 24 weeks and those that had the over 24 weeks. And then we looked at the different periods of time. And you can see that for those patients who had more than 24 weeks, in the months that followed, there was absolutely no more QT prolongation than in the group who didn't have 24 weeks. And, you know, of course, this isn't a clinical trial, so probably those who had more than 24 weeks supported better the bedaquiline or delamanid. But that's also very reassuring that patients who have no safety issues with either of those drugs can continue them for the whole duration of the treatment. So just to mention one of the subgroups of patients, so we had 190 children and adolescents less than 19 or less from the countries. So 14 countries out of the 17 had people in that category. And we can see that there are a lot more of them had lower BMI, and they also all had quite extensive TB on X-ray. And again, similar numbers that perhaps a few more got just delamanid, 50% got only bedaquiline, but 10% of them had both bedaquiline and delamanid. And we had very high rates of success with 85% success rates in that group. Again, the most common adverse events were similar to adults, but they were less frequent than in adults, and the QT prolongation was very rare and fully reversible. So I think in conclusion, in that very quick wrap up, I think we can see that this data does support the WHO recommendations now, and that really show that these are effective and safe drugs, and including for children and adolescents, which is reflected now in the new WHO recommendations that recommend bedaquiline and delamanid for all ages, so no restriction at all on age. But I think it also shows very clearly how operational research can really support, one, the programmatic implementation of these new recommendations. It really allows the programs to get to know the drugs and get to use them how they think they should be used in a setting that allows them to evaluate their programs. It also gave early access, and this is very, very much the case. It continues to be the way that to implement new things, operational research can really assist in getting patients earlier access to these new recommendations. And as we saw, it led the way to expand the indications. So younger age groups were able to get access before the official WHO recommendations, using bedaquiline and delamanid for longer than 24 weeks and in combination, which is now the recommendation, was able to be done earlier. And it certainly gives this really valuable information on these subpopulations, as we saw. And so I think this is like a really good supplement and complement clinical trials, where clinical trials are still needed. They really are needed. As we've seen, there are still many questions. You know, what is the best duration of these all oral regimens? And what is the best combination? As we can see, there's still lots of questions about how best to use them and which patients should have which all oral shorter regimen. And we look like we're going to have quite a few different ones that will be shown to be effective and safe in the years to come. And we want to know which patients to give which combination and for how long. So I think it's a really good example of how clinical trials and observational studies are quite complementary. So thank you very much. Of course, there are many, many, many people in these 17 countries that worked very hard over the 4 years of this study to get the data together and to care for the patients. So thanks very much to all the patients and all the collaborators, and thanks very much for your attention.
Thanks, Kathy. That was really, really enchanting. And I like the way that you concluded posing questions. And over to you to conclude, and as well as also to moderate the question and answer sessions. Thank you so much. Over to you, Kathy.
Okay, thanks very much. So thanks again to all the speakers. So if anybody has some questions, that would be great to hear from you. We've had a few questions in the discussion which have been answered directly in the discussion. But if anybody has another question, please feel free to raise your hand or to put it in the chat box, or you can write directly to either of the presenters. So I see there is a question there in Russian, but I'm unable to answer that because I don't know what it says. Fuad or somebody else maybe could read what it says in the chat there. But just while you're doing that, just to sum up, I think Fuad really gave a great overview, and we can see that there is an incredible movement, incredible activity in the development of new guidelines and operational handbooks. And this is grace to all the the research that is ongoing, observational research as well as clinical trials. So I think that we've never really had a moment before in history. There's been actually quite so much going on, not only in drug-resistant TB, but in drug-susceptible TB as well. So thank you very much to all those people who are currently conducting, analysing clinical trials and observational studies, and to WHO for trying to get all of these GDG meetings and guidelines and operational handbooks done at such a rapid pace. I think it does highlight, the challenge before us is that never before have we had so many new recommendations that need implementation in a landscape of the challenges that everybody has with COVID. We know that is such a challenge for everybody around the world, and hopefully this great collaboration that we have seen in the clinical trials in the countries and the programs, this will continue over the next few years to get all these new recommendations. Okay, so if there's no other questions, I think we can wrap up this session and we can move on from there. Shibu, would you like to say something else?
No updates on this session from my side, so that if everyone is ready, so we have a few minutes now to start the next session. I'm not sure. I'm ready to start the next session if the speakers are around.
Okay, thank you, everybody. So we'll hand over to the moderator of the next session.
Thank you.
Do we have all the speakers for the next session as well lined up?
I think the first presentation is pre-recorded. It's Jennifer Furin pre-recorded. So I think that could just go ahead.
So should we proceed for starting?
Yes, would you like to introduce the next session?
Thank you. So colleagues, we are moving on to the next session of this is a continuation of the plenary session 3. We will be reviewing the progress on uptake of new DRTB regimens, challenges, opportunities, and way forward. So the first speaker is Jennifer Furin. It's a pre-recorded presentation. She will be talking about the treatment options for pediatric DRTB, gaps, achievements, and opportunities. And followed by that is introduction of.
Can we turn off extra microphones, please? Because I do not hear the speaker anymore. That's the interpreter speaking. We have several microphones on, so I'm addressing right now to a host.
We lost you, actually. So yes, so you were just saying that will be followed by a presentation from Askar. Okay, go ahead.
Yeah, I mean, can you hear me now?
No, there is a lot of background noise.
So maybe I can just.
Okay, so you may please go ahead. I mean, so Kathy, I would say you may please go ahead and conclude it. There is not much disturbance. You may please go ahead. Thank you so much.
Okay, sure. Okay. So yes. So as we first of all, we're going to have Jennifer Furin. I think everybody knows Jennifer around the world has said working very intensely with the Sentinel project and with the Harvard Medical School and also is often in the field is going to present some of the gaps in pediatric DRTB. So this is going to be very important, as well as some of the opportunities we can to fill those gaps and where we've got over some of the problems. And then we'll have WHO Euro. So I think almost everybody here will know Alex and Askar. So I'm looking forward to hearing about how they have worked on introducing the modified short treatment regimens. So That will be interesting. And then some on-the-ground experience coming from Ukraine, where they have actually introduced some new DRTB regimens from Gunta. So I think we'll just get on with it without any further ado, because we are running a little bit late. So if the organisers could just go ahead and show the video of Dr. Furin's presentation, please.
Hi, good morning, everyone. My name is Dr. Jennifer Furin, and it's my great pleasure to join you all remotely for your incredibly exciting conference. And I have the great pleasure today of talking to you about what I think is one of the most important topics, which is the diagnosis and treatment of drug-resistant TB in children and adolescents. And what I hope to do today is to present you a very exciting state-of-the-art update so that we can really improve the diagnosis and the care we provide to children and their families when they're facing drug-resistant TB. So I'm going to go ahead and share my screen and start the lecture. So again, my name is Jennifer Furin, and I am an infectious diseases physician and a medical anthropologist. And I've been working in the field of drug-resistant TB for 26 years. And I specialize in the care of vulnerable populations with drug-resistant TB, including children and adolescents. So the objectives of this lecture will be to discuss very briefly, because I know you have two more exciting lectures coming up, the current epidemiologic situation of drug-resistant TB in children and adolescents, to very briefly discuss some of the barriers to diagnosis and treatment, and then to really focus the talk on the exciting guidelines that were just updated this year that will really impact the way that we diagnose and treat children with all forms of TB, but particularly with drug-resistant TB. And I want to also focus on important next steps for countries and programs to take. So one of the first things that people always ask is how many children in the world and children and adolescents are affected by drug-resistant TB? And the answer is we're not really sure, which is not a very satisfying answer to give. But unfortunately, we have not done a very good job diagnosing children and adolescents with this disease. And so a lot of countries, a lot of people will say, well, we don't have any children here, or that's not a problem here, but that simply isn't true. If you're not seeing children and adolescents with drug-resistant TB in your country or your program, the problem is that you're not diagnosing them, not that they don't exist. And there's been some interesting work done by some colleagues of mine from Harvard Medical School, where they did some rather straightforward calculations and estimated that each year between 25,000 and 30,000 children become sick with drug-resistant TB. And what we know is that fewer than 20% of these children are ever diagnosed or started on treatment. And the ones that are tend to be older children and adolescents. So we're really not doing a very good job when it comes to any children and adolescents, but particularly to our younger children and adolescents. And the other point that I think is important to raise when we talk about epidemiology is that most countries only treat children who have bacteriologically confirmed disease. But the reality is, if you're only treating children with bacteriologically confirmed disease, you're under-treating them. And what we really need to be doing is taking children who have known contacts with drug-resistant TB, who themselves show signs and symptoms of TB, and treating them for drug-resistant TB, even in the absence of bacteriologic confirmation. So this was an exciting year because the WHO put a lot of effort into updating their guidance on pediatric TB in general. And they had a 3-week meeting that went from the end of May to the middle of June, which was a tremendous amount of work and effort put in by the people who participated in the meeting. And the guidelines that will be coming out will have a major change in how we diagnose and treat all forms of pediatric TB, but particularly drug-resistant TB. The rapid communication about the major changes was released at the end of August, and the full guidance and operational handbook should be out by December of 2021. The areas that were looked at during this assessment were diagnostic algorithms so that we can improve our clinical diagnosis of TB and drug-resistant TB in children, the use of the expert ultra test, particularly on non-sputum samples, treatment composition and duration for drug-susceptible forms of TB, including TB meningitis, treatment composition for drug-resistant forms of TB with a focus on the age restrictions around bedaquiline and delaminid. They looked at models of care, including decentralized family-centered care as opposed to hospital-based centralized care, and then best practices for adolescent TB. In terms of diagnostic algorithms, the question that the WHO review was asking is that in children below the ages of 10 years, where there's presumptive pulmonary TB, can we use diagnostic algorithms to make that diagnosis? And they compared these algorithms with a microbiologic, or what they call a composite reference standard. And they used several different algorithms that exist in the literature. And what they found is that streamlined algorithms may be used for clinical diagnosis, that we have to do more to be making clinical diagnosis of TB in children. But as the sensitivity of these algorithms increases, which means we're finding more children, the specificity decreases. And that is to be expected. The implications for practice are that we need to ensure these algorithms are available and being used. And for those of us working in the space of drug-resistant TB, we need to ensure that children and adolescents who have known contacts, particularly in the household, who have drug-resistant TB, that we're using these algorithms, and then the children who are positive on these algorithms are treated for drug-resistant TB. Okay, and that's something that we all need to do more of, is clinically diagnosing drug-resistant TB based on these algorithms and then a known contact with drug-resistant TB. So the next area that was reviewed by the WHO was the use of the Expert Ultra cartridge and the types of specimens. So the Expert Ultra cartridge is a cartridge-based nucleic acid amplification test that can provide information about the presence or absence of Mycobacterium tuberculosis, and also gives information about rifampicin resistance. And the Ultra version of this cartridge-based amplification test is more sensitive. And so the WHO wanted to look at, can this be used in children, and at the different types of samples that can be used. And I think the recommendation that came out that we're most excited about is that the Expert Ultra can be used, and it can be used on stool specimens. So I think all of us who work with children know that getting them to cough can be challenging, particularly in young children. And we often have to do a nasopharyngeal aspirate or a gastric aspirate. And these procedures are difficult and time consuming. And during COVID, they're hard to do. And they can also be distressing for children. So there's been a tremendous amount of work done recently by colleagues in KNCV and other organizations to look at whether stool specimens can be used on these Expert Ultra tests, and the answer is yes. And the nice thing is that our colleagues in KNCV worked to develop what they call a simple one-step method for preparing the stool to be used in the Expert Ultra cartridges, and they call this SOS. And basically, you just have to take the stool specimen from a child and mix it with the buffer solution that normally goes with the Expert Ultra to agitate it, and then let it sit for 10 minutes. Agitate it again, let it sit for another 10 minutes, and then just take the supernatant and put it in the Expert Ultra cartridge. So this is a huge diagnostic advance. That stool cannot be used for culture, however, because it hasn't been decontaminated. But we think this will be a nice way to get more samples from children. The caveat always being, however, that even in the absence of bacteriologic confirmation, children with clinical signs and symptoms of TB and a known contact with drug-resistant TB should be treated empirically. So a negative test does not rule out TB. So a positive test helps us, but a negative test does not rule out TB. So the WHO committees also looked at whether or not bedaquiline, one of our newer TB drugs, can be used in children under the age of 6 years. Most of you working with drug-resistant TB in children know that the WHO recommendations really are specific to children above the age of 6 for bedaquiline. And so this year, the guideline development group met to review the use of bedaquiline in children under the age of 6 years. And although there were very limited data to review for this topic, the recommendation communicated in the rapid advice is that bedaquiline may be used in children of all ages. So this is very exciting. There's a pediatric formulation of bedaquiline, a 20 milligram dispersible tablet in a quality assured formulation that's available from the Global Drug Facility, and we can now give bedaquiline to children of all ages. The guideline development group also reviewed the use of delaminid in children under the age of 3. Current guidelines really only have data to recommend delaminid in children ages 3 and above. So the WHO guideline group wanted to see, can it be used in children under the age of 3? And again, although there were very limited data to review for this topic, the recommendation was that delaminid may be used in children of all ages. This is very, very exciting. There is a pediatric formulation of delaminid. It's a 25 milligram dispersible tablet. It's been given a positive review from the European Medicines Association, and it's currently available from the company under compassionate use, but hopefully will be available more widely by the end of the year. So it's incredibly exciting. Our newer drugs can be used in children of all ages. I do want to mention the drug pratomanid because people often ask about this. There is no data in adolescents and children really below the ages of 14. And there's a potential for reproductive toxicity based on animal studies. So until the company that makes and sponsors the drug tests it to ensure that there's not reproductive toxicity, pratomanid cannot and should not be used in children. What I want to really emphasize here is that with the new guidance on bedaquiline being available for children of all ages, delaminid for children of all ages, treating children with drug-resistant TB means that all oral regimens should be given to a majority of children. You need to stop giving children injectables. It's really only children with very, very severe drug-resistant strains who are getting salvage regimens who should be getting injectable therapy. All oral regimens should be given to a majority of children, and the duration of their therapy should be based on the extent of their disease. So no more injections for kids, which is very exciting. But we all need to move quickly on this. The injectables are dangerous drugs for all people living with drug-resistant TB, but especially for children. I just want to review, those are the key WHO recommendations, but I just want to mention again some important principles in the treatment and approach to children with drug-resistant TB. And many of these come from the Sentinel Project, their field guide on the management of multi-drug resistant TB in children, which is actually available in Russian. And this will also be updated this year. But when treating children and approaching children and adolescents with drug-resistant TB, there are some key points to remember. And these points are that therapy in the absence of bacteriologic confirmation is the norm, in which case treatment should be based on the drug susceptibility testing of any known contact. If your program, if your clinic is only treating children and adolescents with bacteriologically confirmed drug-resistant TB, you're under-treating, okay? All oral regimens should be given to most children, and these regimens really should not have more than 4 to 5 drugs in them. Priority should be given to the pediatric formulations of the group A and B drugs, as well as delaminid. And there are now pediatric formulations of many second-line drugs, which I'm going to talk about in a little bit. Duration of therapy should be based on the extent of disease. And inpatient management is really only needed when clinically indicated. Hospitalizing children for treatment is no longer necessary. And monitoring and management of adverse events is essential, as is counseling, adherence support, and socioeconomic assistance to the entire family unit, not just to the child. The WHO did discuss and look at whether or not family-centered decentralized outpatient services can be used for children and adolescents with drug-resistant TB. And what they found is that family-centered decentralized care should be used. Okay, we're so used to putting these kids in the hospital and taking them away from their parents and their caregivers, and that really shouldn't be the norm anymore. We need to approach DRTB as a disease of the family and think about the family unit, not just a parent or a child who's sick, but the whole family unit and how we can treat them. However, there may still be some children and adolescents who need to be hospitalized. So we shouldn't completely get rid of our centralized hospital-based services, but we really should only have those available for children with clinical implications. And while there was no evidence to review on best practices for adolescents with TB and drug-resistant TB, there was an expert group that was convened to think about and talk about special issues for adolescents with TB and drug-resistant TB. And the recommendation was that adolescent-friendly packages of care need to be developed, and they need to be specifically outlined in national TB program guidelines and included in training and support materials. Adolescents are a very vulnerable population, and in the TB world, we do them a great disservice because we tend to divide them between 14 and 15 and say under 14 is children, over 14 is adult, and it doesn't really work that way. So when the WHO comes out with the best practices handbook, there will be a whole section on approaches to adolescents, and everybody working in the TB space and the drug-resistant TB space needs to think about creating adolescent-friendly services and specifying how they're going to do this in their guidelines and strategic plans. So I'm nearing the end of my time, and I just want to mention there are now pediatric formulations of most of the second-line drugs. Using adult tablets of second-line drugs to treat children often results in inaccurate dosing. Children may be undertreated or overtreated, and this can actually be very traumatic for them. There are quality assured child-friendly formulations, most of them as dispersible tablets, that are currently available from the Global Drug Facility. And these include for levofloxacin, moxifloxacin, clofazimine, bedaquiline, isoniazid, pyrazinamide, ethambutol, ethionamide, and cycloserine. And we anticipate that linezolid should be available before the end of 2021, and delaminid as well. Although again, delaminid pediatric formulations are available from the company on a compassionate use named patient basis. And these pediatric formulations should preferentially be given to children who weigh less than 25 kg or who can't swallow adult tablets. And they really make a huge difference in the quality of life for the children, in the quality of life for their caregivers, and actually in the quality of life for the nurses and pharmacists who treat and participate in the treatment of children who used to have to spend an inordinate amount of time mixing, crushing, and cutting tablets. So these are really exciting times in the treatment of children with drug-resistant TB and adolescents with drug-resistant TB, and programs need to move rapidly to make sure we implement these guidelines as quickly as possible, particularly around the use of stool experts, shorter all-oral regimens, and expanded use of bedaquiline and delaminid, more procurement and wider use of pediatric formulations of the second-line drugs, and really thinking about how to address the needs of adolescents and families as we move forward in this exciting time. So that's all I had to say. My email address is here. Please feel free to reach out to me. It's jenniferfern@gmail.com. I'm always excited to talk to colleagues working in the space of DRTB and who want to make things better for children and adolescents. And I thank you for all the work that you've done on their behalf and all the work that you're doing during these really difficult times. So keep it up, and just know that these are really great days ahead for kids and adolescents who are impacted by drug-resistant TB. Thank you.
Thanks, Jen. It was actually a wonderful talk. Though it was a pre-recorded session, it went really well. And also the call for all our regimen and pediatric-friendly formulations need to be taken up further for having this regimen to be rolled out at scale. I'm happy to have Andre as my co-host. and Andre will be chairing this session on the subsequent sessions. Andre, over to you.
Thank you very much, Sabib. That's kind of you once again joining the moderators to welcome all of the participants to this conference. And as you said, I will take over and will introduce the next two presenters, which will continue the overall subject of the session itself, the progress on uptaking the new TB drug regimens, describing the challenges, opportunities, and the way forward. So the next presentation is going to be done by Dr. Askar Idilbayev and Alexey Korotic. They are my colleagues here in the regional office for Europe at the WHO, and they will present to all of us in a set of slides and describe the overall introduction of the modified short treatment regimen in Central Asia. Over to you, Oskar and Alex.
Спасибо большое, Андрей. Я буду говорить, мы будем...
Thank you very much, Andrei. We'll present this in Russian. I hope that you can hear us well, and the slide is also up on the screen in Russian. So next slide, please. So in this presentation, Alexander and I, we wanted to talk about the progress of the regional initiative, which started at the end of 2019 and includes 14 countries from the European Union of the WHO. But before we do that, before I get to it, before I start talking about this topic, I would like to say here that, and once again, remind to everyone that from my yesterday's presentation, that in September 2018, during the meeting, a high-level meeting, UN high-level meeting, all countries they committed to, within the next 5 years, to reach certain parameters on prevention of TB, and this is including TB treatment, both drug sensitive so 40 million for the beginning of 1.23 million people, as you can see from the slide. The target, as you can see, the progress, as I was saying, for the first 2 years, during the first 2 years of 2018 is rather good in our region in particular, and this also has to do with both treating the patients with the MDR TB. However, I wanted to point out here that the period of treatment with the MDR TB treatment is and might be one of the things that prevents and might prevent big coverage of patients, and that's why we need new methods, new opportunities, new capacities, new treatment regimens that can shorten the duration of chemotherapy of the MDR and use more number and treat more the number of patients. And by doing that, we'll be able to achieve the parameters which the country is committed to as the responsibility. As you all know, that in June 2020, the World WHO issued the fourth module of the consolidated guidelines on tuberculosis by WHO, and as was already mentioned several times during this meeting, this module of the consolidated guidelines consists of guided guideline itself and a practical operational reference book, which explains in a rather easy to understand language the implementation of all recommendations that are described and recommended by the World Health Organizations on treating the drug-resistant tuberculosis. Next slide, please. And starting with 2019, and after that, as of all the recommendations by the WHO on the RTB, there are different, both significant from what was recommended prior to this significant changes, as was already pointed out. You all know about this. There's a new classification or grouping of the drugs that are recommended for long-term treatment regimens in treating TBs. Also recommended regimens of treatment for short-term treatment regimens as operational research regimen for treating patients with pre-XDR TB, and one of the recommendations is using short peroral treatment, which include bedaquiline that can be used. They can be used in treating this. Regimen consists of first 6 months from 7 drugs, including it includes bedaquiline and some of the drugs from the first line, ethionamide, ethambutol, and ethionamide, and pyrazinamide, and ethion and proteins. However, I wanted to point out here that if this regimen is recommended, then not always, and not in all the countries and not in all the regions, this treatment is acceptable. So next slide. So the WHO, keeping that in mind, in its guide, it says that the treatment regimen which cannot be applied in this region due to some reasons, it can be. There's a possibility to use other treatment regimens as a modification, but they need to be under operational research only. So as of today, the World WHO recommends any modification that is different from the standard, in this case from the short bedaquiline containing treatment regimens, to use under the operational research. And the operational research, I wanted to say here, that is one of the mechanisms, is one of the instruments of the maximally close to programmatic usage. And the operational research, it is that not only in registering of negative effects or serious consequences or serious events, but also it allows to improve the clinical practice and provide access to new anti-TB drugs, which we are talking about right now. Next slide, please. So the guideline, so based on this, the WHO, European Department of the WHO, at the end of 2019, developed a regional package of operational research and started the regional initiative on introducing short-term modified, fully parallel short-term treatment regimens with the MDR, with the susceptibility to as operational research. This regional initiative, it was launched under the auspices of the European Research Initiative on Tuberculosis, and as of today, it includes 14 countries of the European region of the HW. I'm proud to enumerate these countries: Armenia, Azerbaijan, Belarus, Georgia, Kazakhstan, Kyrgyzstan, Latvia, Lithuania, Moldova, Romania, Tajikistan, Turkmenistan, Ukraine, and Uzbekistan. So as you can see, all 5 Central Asian countries are here made to this list. They are participate in this regional initiative under the auspice of the European WHO office. And we're also thankful to all national tuberculosis programs in all the countries, including in the Central Asian countries, for significant support, understanding, and openness in implementing this very regional initiative. What are the goals? What are the objectives? First is facilitate introduction and introduce by introducing modified MSTR regimens. By doing that, promote this process. Also, to foster good clinical care for MDR-TB through in operational research, in order to tackle using the operational research. So what we mean here, if the patient, for example, is added to the operational research or enlisted to clinical research or operational research, then he or she is paid given particular focus under this programmatic use of and routine use of anti-TB drugs. Not always we can achieve the ideal outcome for the patient. So using those requirements, those operational research requirements, and adequate monitoring and being ready for any negative response, we can improve the clinical practice of patient management with the MDR-TB and switch it and cover a bigger cohort of patients. And also, one of the objectives is the initiative to create and strengthen the research capacity in the countries, of course. And the very last objective is through harmonizing approach and using identical approaches to this operational research and data collection. We promote, in addition to improving the treatment results, which we are expecting in all the countries, in all the participating countries of this event, to also promote shape, form, adequate or a package of evidence-based data to formulate the future recommendations from the WHO on treating the DRTB. Next slide, please. So what are the advantages of short-term MSTR for MDR-TB, in particular for the modified regimens? First of all, we will be able to cover more patients with potential safer and effective regimens. Why? Because in these very regimens, I will speak about that later, they include those drugs that are recommended by the WHO as a longer-term treatment regimens for the MDR, and they have a good evidence based for effectiveness and safety. So by that, we'll be helping with the efficiency and reducing the unfavorable outcomes. Also, interruptions in the treatment, which was already approved and recommended in using the short-term treatment regimens in the recommendation by the WHO. Also, I already spoke about this, about the clinical assistance, clinical support, and enhancing this clinical practice through using some new and all methods of research, testing the patients and enlisting them in routine protocols for monitoring of patient management. Also, using short-term treatment regimens in particular MSTR, we can help improve the healthcare through reducing the costs for the healthcare system, and also pay more attention to outpatient clinic, which is rather important during COVID infection, and make the treatment more comfortable, and we're reducing the risks of transmission of infections and risks of contracting COVID-19 infections. Also, this promotes reduce the stigmatization and decrease the household costs due to the disability, and faster impact on the TB epidemic in the region. Next slide, please.
You still have a few minutes, but please speed up your presentation. Over.
Андрей, у нас еще, я прошу прощения, но у нас еще эта презентация продолжается.
We'll finish it soon. So what schemes we use in all 14 countries? These are 39 weeks of regimen. So they use from A and B team, which was recommended for long-term treatment regimens. And the difference from the first scheme from the second is that the replacement of using the bilamanid when there is a low tolerance or there's a health. And the last regimen, number 3, 39-week regimen for the patients, for children, and for the using 4 drugs. Bilamanid is used. Next slide, please. So, using these modified treatment regimens, we can compare to previous recommended treatment therapies, which took longer time, 24 months, using more than 14,000 pills to totally get rid of the injections, and to treat patient within 9 months and lower the number of tablets by 6 times. Now I want to give the floor back to Alexander for more detailed information on this event. Thank you. Thank you, dear Oscar. Hello, dear colleagues. Thank you for the opportunity to participate in this section. As Dr. Yerbayev said, there are objectives initiated, but in addition to that, we also have specific goals, even under this research, among which is determine the efficacy of MSTR only with pre-oral drugs within 39 weeks. And occurrence of unfavorable outcomes, and determine the relapses within 12 months after successful treatment with the novel after the therapy. So this task had Dr. Yerbayev already talked about the task force, which consists of experts who are involved in treating the DRTB in our countries. You can see these experts at the end of the at the bottom of the screen, and the task of this task force is to ensure a regional package of documents for the operational research and data collection instruments, clinical protocols, patient management, and unfavorable outcomes, and also support countries in adapting the protocol and support national research teams in data collection and filling out the forms. Also help the countries obtain certain country ethical approvals. Also, this task force provides methodological support throughout the entire process of implementing the study. Our working group developed protocols. You can see this. You can see them on the screen. So the only schedule for monitoring of the treatment, which allows to provide similar support to all the DR TB patients in all the countries of our region which participate in this initiative, and collect data about unfavorable outcomes. And by doing that, this data are harmonized. They will be collected, harmonized from all 14 countries, and they will be compared, and they will be submitted for consideration by the WHO team to come up with recommendations on treatment for programmatic introduction of the treatment regimens if they prove successful. And also we give quarterly support through monitoring missions in the countries. Second component of technical support, which is given by the WHO, is the virtual medical consilium on short-term regimens. And initially, this consilium was as a body that will be given the advice to countries if they need on the need basis, on involving the patients in this short-term regimen study, on excluding the patients, as well as in the case if there are any necessity to make some changes into the treatment regimens or treat unfavorable outcomes and the strategy for treating these unfavorable treatments. This could be discussed with the consilium. This was the initial plan, but our consilium is also considering the case of the hard to cure cases, or whenever there is issues. MDR, XDR, or DR, everything could be MDR, XDR, or DR, everything could be brought up to the consilium for consideration, and the consilium is ready to provide such a support. So a request is sent by the clinicians from all the countries and would get the response within the 48 hours. Also, the second component of activity of this consilium is monthly webinars, which cover and
Вот этот список вебинаров вы видите в правой колонке. Многие из вас присоединялись к этим вебинарам. Вот есть архив вебинаров, ссылка внизу, вы можете получить и посмотреть все предыдущие записи и презентации. Больше 200 человек присоединяются уже к нашим вебинарам, но мы хотим еще повысить участие. Ну, наша инициатива.
Well, our initiative in each and every country takes 33 months from inclusion of the very first patient till enrollment of the last patient, and plus each patient is treated for 9 months, and then there is 12 months follow-up for any relapse. And that's why each and every country participates in this initiative for 33 months since the recruitment of the first patient. So this is the recommendation for all countries. So in all sites of the country, or maybe in some pilot districts, so all RRTB patients should be screened. So it's a total screening for an opportunity to participate in this study, and there are several criteria. So patients give their consent and then they get enrolled in this study. So for 12 months, the recruitment process will be conducted in each country, and also we can see that if the regimens work okay, if the country has good experience, there is no need to limit this recruitment only for 12 months to regional cohorts. So we recommend that countries currently introduce the country-level cohorts. So what's needed for that? When the recruitment to regional cohorts ends, then the study protocol similar to the original study should be submitted to the ethical committee, and then the recruitment should continue, and then there will be an opportunity to get treatment for 9 months with equally effective regimens. So this is the slide showing our initiatives. So there were original preparations to February 2020 since 2019. So we presented the regional package, and then the countries adapted that package, some sooner, some later. And actually, Lithuania started recruitment in April. Other countries started doing that in 2020, and thus the recruitment will continue till March 2022. In other countries, the recruitment process will finish earlier. For example, Armenia started in August 2022, and then in August 2021, the regional cohort recruitment started, and then the patients will be followed up. Treated, then followed up. And so thus we will get the last data in 2024 representing the final results of the study, and then we will do preliminary analysis of the treatment successes. And the plan is that by 2024 we will be able to provide the final data set to WHO group, so recommendations could be compiled. And on top of that, we will continue our support to countries. So we will conduct monthly webinars, concilium, and then we will conduct country-specific meetings. So we could assess challenges in terms of introduction of shorter regimens, and thus it will be a platform to share experience and share data. And so the most interesting slide for the audience here is the country timelines to implement shorter regimens in countries. And as you can see, the initiative includes some 2,000 patients, namely 1,866 in various countries. And for countries participating in this conference, we can see Kazakhstan 139, in Uzbekistan 106, in Tajikistan 64, in Turkmenistan 42, and in Kyrgyzstan 26. But as you know, the numbers are lower than planned because of the last year's COVID-19 pandemic, and the number of patients decreased, and partially that provided an effect on our initiative. Yes, Andrei, I know that. I know about the time limit, and as you can see, the patient enrollment finished. So in Armenia and the Republic of Moldova, so these countries will start implementation of their country cohorts, and we also request that other countries consider this option and continue to enroll patients for shorter regimens as part of their country's cohorts. And the last slide is the slide that highlights the WHO continues its initiative, and we will keep on working with our countries to continue these studies, and we will work to expand the country cohorts so these regimens could be provided to as many patients as possible, eligible patients. Thank you very much. Thank you, everyone, conference participants, the colleagues, the patients who agreed to participate in this study.
Appreciation to our countries and of course to ASCAR, and much appreciation to our principal investigators in all of those countries which are leading and catalyzing the implementation of the new short treatment regimens, all oral, and brings the hope for those patients which did not have that in the past. So next presentation is going to be done by Gunta Dragnice. She is coming from originally from she is coming from the PAST, the organization that is based in Seattle, and she will present to us a presentation related to the introduction of the new treatment regimens for drug-resistant TB patients and its experience that has been received and achieved in Ukraine. Back to you, Gunta.
Thank you very much, Andrei. Can you see my slides? Everything is fine?
Yes, please. Go ahead.
Хорошо. Я буду тоже добрый день, коллеги. Очень рада вас.
Good afternoon, colleagues. I'm pleased to see you, but I can't see you all, but I feel you. So now I work at PATH. So it's the project to support TB control in Ukraine. It's USAID funded project. And before we start discussing Ukraine, I would like to start with this slide. And I guess you can recall it quite well. You've seen it repeatedly, like what it all started with. So it all started with patient sorting. So as part of the project implemented by KNCV, jointly with the partners Challenge TB, so you see that simple triage of patients. And so the shorter regimen was used available in 2016, and the regimen that contained new drugs, bedaquiline and delamanid, for those who were not eligible for shorter regimens. And so in late 2016 and early 2017, I guess you remember that the results were quite good. I'm not going to elaborate on that, but to add to what Askar has mentioned in his presentation, so the shorter treatment regimen available back then was not bad, but at least it included 3 regimens when most patients in our region were resistant to them, and plus they were injectable. And it's perfect that there is WHO initiative, and now we have much better regimens. And what Ukraine started its introduction with, so they started introducing bedaquiline in July 2017. They started enrolling patients at the National Institute in Kiev. So there was a small cohort, and then they rolled it out nationwide, and then bedaquiline was used only as part of individual patient-specific treatment regimens. But now the treatment regimens changed considerably, and there are a lot of options, as you can see. So the BPAL, which lasts for 6 months, and it's possible only as part of operational studies, and also individualized treatment regimens, which are still valid. And all the regimens are available, and they are used in Ukraine. Implementation of new regimens in Ukraine, so the modified and shorter treatment regimens, as Askar has mentioned. Ukraine is part of the multi-center operational study, and this is it's also supported by USAID and partners, including PATS, and the implementation started in December 2020, so 1 year ago, and BPAL regimen is implemented again as part of the multi-center study supported by TB Reach, and OAS, the local NGO, is implementing that jointly with the National TB Institute, so ANTP and other partners support them. And patient enrollment began in November 2020, so 1 month after the modified shorter treatment regimen. And as for shorter regimen, so it's being introduced almost throughout the country, and gradually all regions stepped in except for one province which didn't want to participate in that. BPAL, the same, it's being introduced in all in most of the provinces, but the difference is that the patients from the provinces have to come to the institute for prescription, and then they can continue their treatment as outpatients. That's how the updated algorithm for triage looks like. So for 2 simple regimens, well, then as part of the cascade, other treatment regimens could be prescribed, but there is nothing challenging. So each patient is assessed against the eligibility criteria, if eligible or if not eligible. If not eligible, then BPAL. If not BPAL, then only individual treatment. I'm not going to focus on that because I promised Andrei I would save time. And what DST techniques are used in Ukraine, that's essential for introduction of new treatment regimen. So we have expert MTB REEF. Expert XDR was piloted in 3 provinces until the year end. The country will get additional cartridges, and the plan is to expand it nationwide. And also for the country, HINE to first and second line drugs is available, but HINE was not enough because they only had 4 machines, and that's why partners organized transportation of specimens from provinces without HINE to those 4 labs. And now definitely there are challenges with supplies of reagents for HINE. MGIT is definitely available, and what's new here is that target sequencing is supported by the project, and now it's not possible to use it as a clinical solution, so we can't rely on that for our clinical decisions, but hopefully there will be updated WHO recommendations, and then the country will be ready. It will learn how to use this methodology. So challenges, what challenges they face during the introduction? I would like to apologize because I can't show you the data for outcomes because there are not really outcomes available for shorter regimens. And I guess Natalia Litvinenko, the primary investigator, will show you the outcomes and the adverse events. I guess I lost, no. So the most important part is retraining of clinicians, convincing clinicians, and limited access to rapid diagnosis. So they have a lot of patients and so much caseload, and also COVID-19 affected the study. And there are two ongoing reforms in the country: health reform and administrative reform, which also had an effect on patients' enrollment. As for opportunities, I will not repeat myself and repeat Alex and Oscar, because they mentioned that it's an opportunity to train further the specialists in the region. It's a fresh outlook, and actually we can see the challenges in the programs when we do that. As of September 2021, 923 patients are included in short-term modified treatment regimens, and as you can see on Alex's slide, so that's the biggest number of all countries, and more than 90 patients are enrolled for BPAL. It's a lot because Ukraine was one of the first countries to introduce BPAL regimen at such a scale. The key to success, I would like to commend the NCP because actually they are leaders, they are proactive, they try to introduce the available innovations, and they coordinate the donors, and our support is based on the NCP needs. I would like to commend also our colleagues from WHO because they provide ongoing technical support. Colleagues from WHO Regional Office for Europe, that's real practical help. And as for coordination and support from partners, and also replication of best practices by other partners. Just one example. So when COVID-19 happened, so our project supported the multifunctional transportation system, also the system for diagnosis of hepatitis and HIV, and we supported that for 12 provinces, and immediately the Global Fund supported us and expanded that system to other provinces. So what's next? We will continue the operational study for shorter regimens, but as part of the national cohort, we will continue introduction of BPAL as part of new projects, and then the treatment regimens for children will be upgraded based on updated WHO recommendations, what you've already seen, and the colleagues before me showed that. So, and we expect new WHO recommendations for DR to be issued in 2022. Thank you so very much for attention. I tried to save time. Thank you, Gunta. In fact, you didn't promise it to me only, but to the whole audience, and you tried to stick to your time limit. Thank you so very much. So let me continue. The point is we are a little bit behind of our agenda, and let me anyway try to draw the audience's attention. So now you can ask some questions, either in the chat or you can put them as comments, so don't be shy. And you can also share your experience about the content of the conference, and please follow online version of the conference on YouTube, organized by the conference secretariat. But anyway, I will let myself ask one question to presenters. Which lesson learned during these interventions to expand the use of shorter regimen? So just mention two lessons which you would present for the audience so they could take them into account later on. Anyone? If I may? Yes, just quickly. The most important lesson is timely information, both for clinicians and administrative agencies in the country when we expect some new recommendations, like here, the rapid communication. So when something comes, so provide information in advance so the country could get ready for updated recommendations. Then you will avoid delays in implementation. The second is organization of supportive supervision, clinical mentoring, so we could ensure quality at each and every level. Thank you. Thank you very much. Oscar, maybe you have something to share. Thank you, Andrei. Very much. Just a brief reflection. So the first point is, once again, operational studies are not really different from programmatic visualization. It's complementary. And as for clinical monitoring requirements, as part of our operational study of shorter regimens, well, they include just the minimum of this study, which has to be applied to all patients as part of programmatic use, because not all countries even have the opportunity to always ensure that minimum. That's why my big request is, it would be good if we could use the opportunities offered by the Global Fund project that supports implementation at the country level, and we need to consider providing for all study-related requirements needed for monitoring. And it's not a request for the Global Fund, but special attention should be given to national TB programs. Thank you. Alex, maybe you want to mention something? Well, Andrei, I want to mention that when the goal is well understood by all stakeholders and partners and MCP, when they all are on the same page, then the implementation is smooth. When the study is not done for the sake of the study, but just to provide benefits for our patients, then there will be success, and it will be equally successful for all. And the next point is we need support and understanding from all partners, national, international. That's also the key to success, when you enjoy support from donors and when you have reliable interaction among all partners, and then we can succeed. Thank you. Yes, thank you so very much. And now we are at the end of our session 3. It was really very interesting, and thank you so very much, presenters and the audience. Thank you for being with us. We will have a short break. The point is that we went a little bit beyond the time limit for our session, but again, let's get back to that. And let's continue our parallel sessions, session 5 and session 6. And I would like to invite Gunta and Catherine. Please become moderators of sessions 5 and 6. So we will continue in several minutes. So session 3 is finished.
А мы остаемся здесь, да?
Да, секунду, уважаемые спикеры и слушатели, напоминаем вам, что для участия в сессии номер 6 вам необходимо переключиться по второму линку, а участники 5-й сессии остаются на этой
Those who are in session 6, please follow link 2. Now we are having a short break while we are following our links to our sessions to get prepared for our further agenda. So wish you a fruitful day.
Добрый день, уважаемые участники конференции. Мы сейчас плавно переходим.
Good afternoon. We're now moving to session number 5. It is called Way to Self-Reliance, Enabling Environment and Financial Sustainability. I'm the technical advisor on TB. So before that, my work also was related to Central Asian region and TB Care 1. And I'm happy to introduce you to the second moderator, who is Gunta Badangmas, whom I think we do not need to introduce separately. Gunta just told us a very interesting overview of Ukraine Path project, where she is a leader. It's a big USAID project, which is called Supporting Efforts on TB Control. And before that, Gunta worked a number of years on supporting the TB programs. It's TB Care 1, Challenge TB, And she has a number of other achievements. She is a member of the Committee of Green Light, and she worked in Riga as well. First of all, I would like to thank organizers of the conference that they have included in the program the session on the prophylactic preventive treatment, because it was historically in the global agenda, and it has been mentioned several times on the conference in 2018 and the high-level meeting at UN. The political declaration has been adopted, under which the countries were supposed to achieve ambitious goals to include in the prophylactic treatment 30 million patients. And that made us to rethink about our approaches, to think how we can use new methods of diagnostics and new modes of treatment. But at the same time, as we have seen in the presentation of WHO Europe Bureau presentation, such achievements are quite moderate, and we need to pass a long way to shorten this gap. Now we have a brief overview of our session, which will consist of 4 presentations. The first presentation is called Strategies for Implementing Tuberculosis Preventive Treatment in High Prevalence Settings. The speaker is Hai Lin Huang from Burnet Institute, Melbourne, Australia. Second very interesting presentation is called Zero TB City Initiative, a global overview and implementation progress in the EECA region. We will have Michael Wilson as a replacement. The third presentation will be Kyrgyz experience on introduction of testing on latent tuberculosis by using quantiferon TB method. And the last presentation is called a Changing Paradigm, Way of Active Identification Method to Testing, Test of IGRA in Decentralized Conditions. The reporter is Vladislav Nikolaevsky, the company Kaya-Jida, who is a manufacturer of the test. I'd like to ask and request the presenters to keep up to timing. It's up to 15 minutes for each presentation. I think we have achieved we catch up with the agenda, caught up with the agenda. Is first speaker ready? Mr. Hai Lin Huang. Unfortunately, we have the technical pause. We have enough time to wait for our first presenter. I will introduce him, Dr. Hai Lin Huang, who is an infectionist doctor and executive co-director on elimination of the TB and introduction of the scientific approaches at Burnet Institute, Melbourne, Australia. And his latest work was focused on how the public healthcare response to the antimicrobial sustainability in COVID-19, in particular, its effect on Papua New Guinea. Very interesting presentation. And jumping ahead, I can give you a teaser that he'll be talking about the treatment of the contact of MLTB. So the presenter is here, right? Good. The floor is yours. Yes. Dr. Hai Lin Huang.
Is that okay? Can you see my screen?
Yes, we can. Thank you.
Perfect. I'll make a start then. Thanks. So I'm an infectious disease physician working for the Burnet Institute based in Melbourne, Australia. And today I'll be speaking on the implementation of TB preventative treatment in high transmission settings, but with a particular focus on drug resistance. For those who aren't aware, the Burnett is an independent, unaligned and not-for-profit Australian-based organisation. And within Australia, we're accredited as a research institute and an NGO. Hence, we are often sort of working at that intersect of public health implementation and translational research. And our main countries of focus for our TB work are in the immediate region where we are, which so including Papua New Guinea and Indonesia. The work I'll be talking about today is primarily funded through the Australian government through a number of different grants via the Department of Foreign Affairs and Trade and the Department of Health. And all the work has been conducted in collaboration and close partnership with local governments and agencies. So to start off, I would firstly invite you to think about where we are globally with TB control. We're in the era of the WHO End TB strategy, which really outlines these sort of three pillars or principles by which we are trying to work and sets very ambitious targets for TB control for quite, a steep bend in the curve to decline the TB incidence globally. But perhaps where it falls down a bit is the actual strategy part. So how do countries practically achieve this bending of the curve and to see a decline in TB incidence? And if you look at settings where this has been successfully done, including many historical examples, what do they have in common? And it's often putting together these pieces of this paradigm of detection, treatment, and prevention. And I understand that the subsequent speakers may be talking about this, a bit further, but this search, treat, prevent, it all needs to be done and it needs to be done together. And when you look at what programs are currently doing globally, there's obviously a lot of attention on treatment with a lot of developments in terms of new regimens, a lot more activities in terms of case finding and finding those missing patients. But prevention is often that missing piece where there is that, very large implementation gap from policy to what's actually happening. The impact of this has been modeled in a variety of settings, and that's sort of indicated in that middle figure of this slide. And it's been thought to, it's thought to potentially have a very significant impact. And of course, it is also part of Pillar 1 of the NTB strategy. In terms of the current guidance, the WHO updated their guidelines in 2020. And the current advice is that at-risk groups should be targeted that are listed here. So historically, household contacts under the age of 5, people living with HIV, but then expanding that now to household contacts over the age of 5 as a conditional recommendation, contacts of those with multi-drug resistant TB, and consideration to other high-risk groups. The next step is latent TB testing, and there is a role for this in some, but not all populations, via either a skin test or an interferon gamma release assay, and we'll be hearing more about that during this session, I understand, of course. And then on to the treatment options. So 6 months of isoniazid has been the standard of care for drug-susceptible TB contacts for a long time in many, many settings, but there are now, of course, a number of shorter options for drug-susceptible TB contacts, including 4 months of isoniazid or rifapentine-based combinations, or also now this new rifampicin isoniazid fixed-dose child-friendly formulation. For drug-resistant TB, this remains a challenge. There is a conditional recommendation here, and there is, a building body of observational data. And currently, there are 3 randomized controlled trials running to, sort of definitively answer what the appropriate regimen will be. These are TB Champ, VQuin, and the Phoenix trial, and 2 of those are looking at a regimen comprised of 6 months of levofloxacin. To perhaps further complicate this picture a bit more, and particularly where there are high prevalence of drug-resistant TB, latent TB testing, of course, does not differentiate between drug-susceptible and drug-resistant TB, which can leave you in a challenging situation, and I'll speak about that in the coming slides. So again, this is just to emphasize that scale-up of latent TB treatment has proven to be key in many settings. This is old data going back to the 1950s and 60s in Alaska, where there were very high rates of TB in the Inuit population. And as well as the overall public health response, it was the implementation of preventative therapy that was thought to be one of the key factors that led to a significant and rapid decline in TB incidence that has been sustained for quite some time since. In many of the sites where we've been working in PNG and Indonesia, there has been to date very limited to essentially no implementation of preventative therapy for latent TB infection. This is from one of the grants we've been working on to try and really establish these fast-track sites where we can pilot models of care and scale up initiatives such as the scale up of preventative therapy, and then take and translate these lessons to other parts of the country. In the initial pilot work that's been happening at these sites, we've come across a variety of implementation challenges. And of course, these would vary from setting to setting. And particularly, some of them relate to drug-resistant TB specifically. But just to list through some of these points, I've mentioned earlier, there are limitations to the test for TB infection. They're indirect tests. They don't test for drug resistance. And then you've really got to think about where exposure is occurring in the household and community and what is the background rates of drug resistance. In terms of the screening and management algorithm, you've got to think about what target population. Is it just sticking to that initially, the household contact or other risk groups, or even at the other end of the spectrum? There are some settings, which again, I'll talk about shortly, where we may think about a community-wide initiative. Need to think about the model of care in terms of household follow-ups and engaging with communities and households, what tests we are using. And of course, it is critical in those algorithms to be, have a reasonable degree of confidence that we are able to exclude active, TB. And in terms of the regimen, again, those particular issues around, drug-resistant TB and where you may or may not be able to differentiate. Of course, in terms of uptake, you need to be conscious of the adverse effects, and they need to be sort of counseled and managed appropriately. And health promotion and community engagement are really central. So regarding drug-resistant TB, and I've alluded to this earlier, the optimal regimen is not well known, and latent TB testing doesn't differentiate. We usually hence assume there is some concordance with the index case and the household contacts. And in this review, they looked at contact investigations of households with drug-resistant TB. And the take-home message really is that there was about a 75% concordance in this systematic review and meta-analysis based on drug susceptibility testing. And of course, if you had data to go to the level of genome sequencing, you could get some more resolution with that. But of course, this does vary from setting to setting and may depend on where you think transmission is happening, whether it's happening in the household level, as we've traditionally focused on, or maybe it's more in other settings and more broadly in the community. I would also just like to mention this recent paper briefly, which we found quite interesting and have actually been thinking about prior to this. And this was a prospective cohort study of household contacts of adults diagnosed with pulmonary TB in Lima, Peru. And these people all received 6 months of isoniazid for the child and household contacts, despite many of these having MDR TB. So they then looked at the MDR contacts and found that even those who did receive isoniazid preventative therapy, they still, despite the natural assumption that the strain would have been resistant, they did have a lower incidence of TB. And so this raises sort of, an interesting question. We've always sort of assumed that if the index strain is resistant to isoniazid, then isoniazid preventative therapy won't be effective. But actually, we don't know this for sure. In latent infection, potentially, TB is existing in a different state. There may not be high-level resistance. And is there potentially a role for isoniazid still in the management of MDR TB? We don't know, and we need more data. But it's quite a thought-provoking paper, we thought. So just coming to one of the key sites in the final 5 minutes, I'll talk about and some of our experiences in Papua New Guinea. So this is in the western province of PNG, in a region that borders Australia and Indonesia and Papua, where there are very high rates of TB. And there is a particular high level of MDR TB centered around provincial island capital of Daru, which is a small island capital just near the mouth of the river. There is very intense transmission on this island. There are very high case notification rates as per the population. And we know from genome sequencing data that it is a clonal outbreak that has probably been going on for some time in this setting. The case notification rates, despite significant investment, have remained high over a number of years. We have seen progressive increases in the treatment success rate, now sort of 85 to 90% for both drug susceptible and drug resistant TB. But despite that being sustained for a number of years, we're still seeing high notification rates, which of course, remains a major concern. In terms of what else has been done apart from treatment of TB cases, we've also been scaling up TB preventative therapy in this setting. Initially, taking existing guidelines within P&G, which is roughly in line with the WHO guidelines at the time, and going a little bit further. So focusing at the level of household contacts and household child contacts under the age of 5. Initially with isoniazid-based regimens, then the new sort of fixed-dose formulation of rifampicin isoniazid, and then also 6 months of levofloxacin more recently for the drug-resistant TB contacts. What we found so far is that with strong community engagement and support, we've had very high uptake and high completion rates, but clearly this is just the sort of the pilot and the start of the model of care. The other interesting bit of information that's come out of this work is that as we were doing that, we looked at rates of latent TB infection in household contacts, drug-susceptible TB contacts on the left and drug-resistant on the right, and that's stratified by age group and ascertained by tuberculin skin testing. And what we found actually was a surprisingly low rate in child contacts under 5, but a rapid increase throughout adolescence and young adulthood. One possible hypothesis for this is that there is transmission occurring outside the household level. And so far, we've just been focusing at the household contact model. But perhaps it's as people become more mobile in adolescence, they're having this significant exposure. And it's also matched by the fact that we often didn't see that, concordance, or there was often very mixed, contact histories. And it wasn't very reliable to sort of ascertain what strain people are necessarily infected in. So this sort of leads us to our next sort of stage, which has been pushed back significantly due to impacts from the COVID pandemic. But we are looking to implement a house-to-house, but population-wide intervention, really looking at this detection, treatment, and prevention, focusing on residents. There is a lot of movement around with surrounding islands and regions, but we know that this is the center of the very intense transmission. There are a number of objectives in this intervention. Of course, initially is the detection and treatment, and there's nothing so surprising here, but mobile digital chest X-ray using CAD for TB or another artificial intelligence platform for chest X-ray interpretation, sputum testing by expert ultra, and treatment as per guidelines. In terms of the the preventative therapy. And this is probably one of the the sort of key and parts where we're still putting ongoing thought into, is that we're going to target this at an age group of under 34 years. So under 5 years, we're not going to be looking at skin testing for tests for infection. That's not required within current P&G and global guidelines, but skin testing for 5 to 34 years. And in terms of preventative therapy, we still think in the under 5 age group, we can rely on contact history to provide us with a more reliable index case, and so to treat for drug susceptible latent infection with 3 months of rifampicin isoniazid fixed dose combination, or 6 months of levofloxacin for drug resistant contacts. But for 5 to 34 years, we feel that we can't reliably ascertain that.
Мы можем утверждать, что связь пропадает.
Sorry.
Извините за то, что такое происходит с моими слайдами. Тем не менее, продолжим.
Should I continue, sorry, or no? I'll just go in the last sort of 30 seconds. So 5 to 34 years, skin testing and a regimen of 6 months of isoniazid and levofloxacin to cover both drug susceptible and drug resistant strains, catch up BCG vaccination, and less than 34.
You have about 2 to 3 minutes if possible.
Okay, I'll just finishing up now. So isoniazid levofloxacin and targeting less than 34 years, because we think that's really where there's a higher risk of more movement and transmission, and also the balance of side effects to avoid an older population. Follow-up of household model of care, family-based, with treatment supporters, peer counselors, and enablers. That's just a summary of the algorithm, and that's the end. Thank you.
Большое спасибо.
Thank you very much. I think was really rather interesting and informative presentation. We spoke about the contacts. We talked about the preventive therapy, various treatments. Once again, as you all know, if there's any comments, please you can send them via chat. Send them via chat box or Zoom chat window. We'll have hopeful time at the end to discuss all the presentations and clarify if something wasn't clear enough. Now we're switching to the next presentation. It's called TB-free tuberculosis. Our presenter is Mr. Michael Wilson. He's the director of the Advanced Access and Delivery in South Africa. He's also assistant professor at Gillen's Institute of Northern Carolina. He also heads the initiative, the Partner Zero, the best Zero TB. Now he has a team of 30 people involved in screening, support patients with TB, HIV, and hypertension in South Africa. He's also consultant of the UNOPS on supporting national TB programs. I give floor to Mr. Michael Wilson for the next presentation. Unfortunately, we have experienced some technical glitch until our presenter is getting connected. Maybe we could comment the first presentation by Mr. Kylian Kwan, because this was rather informative, rather interesting in presentation, although it's really far away from Uzbekistan, that experience that we just heard, but still all these findings, all this experience provided by the previous presenter, I think they're really, really good food for thought for all of us. And considering the fact that we're talking about the situation in the context of high prevalence of TB and MDR TB also, which was also rather important. Maybe this wasn't the focus of the presentation, but nevertheless, there were high levels of good outcome from the prevention treatment, as we all know from our experience. Also, how as a rule. And so this is the component. Are we good? Yes. Apologies. So, not to waste time, let's go back to our presentation. I'll give floor to our second presenter, Mr. Michael Wilson. You have the floor, sir.
Michael, can you hear us? Can you join with your presentation?
Yes, I can.
Okay,
yes,
great.
Can you hear me? Can you hear me okay? Is the signal all right?
Yes, we can hear you well. Thanks.
Okay, great. So could I go ahead and share my screen?
I don't think we're seeing the screen yet. I think it's uploading, so we should be seeing it in a second. Great, it's on. Thank you.
Okay, just again, let me just make sure it's. Okay, can you see it okay now?
Yes, please.
Okay, great. Okay, wonderful. All right. Thank you, everyone. My name is Michael Wilson, and I am the director of an organization called Advanced Access and Delivery. I'm based at the moment in Durban, South Africa, and thanks so much for including me in this presentation. Today, I'm going to talk a little bit about the global burden of tuberculosis and the Zero TB initiative that was started by a coalition of organizations, and then just share a little bit about a couple of the examples of TB city projects. So as many of you all know, TB has been responsible for over in deaths in the last 200 years. That's a lot of zeros. It outnumbers the plague, smallpox, influenza, AIDS, cholera, malaria combined. In the last 20 years, the TB incidence has declined at a rate of 1.5% per year, and is now the biggest infectious killer of adults worldwide, and is the largest killer of people living with HIV. The global incident rate of 120 per 100,000. At this rate, if we continue the decline at 1.5% per year, we'll take 200 years for the United States, for the global average to reach that of the United States and some other countries, as graph. So what do we know about how to stop the TB epidemic? I'd just like to go back in history a little bit. As many of you may know, here in this picture is Robert Koch from Germany, who discovered the TB bacillus in 1882 using smear microscopy. And at the time, people really thought that if you could isolate TB, that you could develop vaccines and antibiotics to control and to eradicate it. TB at the time was the scourge of mankind, killing up to 25% of the European population. And it wasn't actually until 60 years after Koch won the Nobel Prize for his discovery that the first antibiotics were actually developed. This here is Wilhelm Conrad, who invented the X-ray in Germany in 1895. And this is actually a photo on the right of his wife's hand. And what the X-ray really brought was a more sensitive test to identifying tuberculosis, even more so than Koch's smear microscopy. This is a gentleman by the name of Robert Phillip, who in 1897 started the very first community-based TB screening program using X-ray in Edinburgh, Scotland. And from very early on, we knew that you could not wait for patients to present with tuberculosis, that at the time that they had already presented, it was too late, and that once symptoms were present, that they have been sick and spreading for some time. So I just want to go through quickly a couple of the early observations. So one of the first observations for TB control was if you do a sensitive test and targeted active case finding, you will find people with TB. And that we knew very early on that active case finding is a critical component of stopping the spread of the epidemic. In 1934, there was a study conducted in New York City that showed a very high pickup rate of TB amongst close contacts of TB patients, just further suggesting the role of targeted active case finding amongst close contacts as a strategy for stopping transmission. We also knew that if we could identify cases early and get people proper nutrition, rest, and sunshine, that we could decrease mortality even before there were effective antibiotics discovered. The second major observation was that as each new drug emerged, so the streptomycin was discovered in 1943 by Selman Waxman, and again, this was 60 years after the discovery of the TB bacillus. And as more and more drugs were developed, it was very clear that if we didn't treat the bacillus properly, that there would be more resistance coming. And so this led to the fact that every time a new drug was introduced, resistance was observed, and that when they were used in combination, that there was less resistance. The third observation was that resistant strains maintain the ability to be transmitted to other people. The first drug-resistant survey that was done in Britain in 1955 found primary resistance to streptomycin, to pass, INH already circulating in the community. So we knew that resistant strains could be passed and transmitted to other people. The fourth major observation was that we knew that when people are initiated early onto treatment, or the correct therapy, that that transmission is halted very quickly. And this was proven by an experiment that was done and has been repeated since with guinea pigs, showing that when air from a tuberculosis patient's room was chambered into an area with guinea pigs, that once once the patient was treated and the air was circulated, a very small number of guinea pigs actually got infected. So we knew that very early on that patients on the correct therapy combination, that was very key to stopping transmission. The last observation, just from history, is that treating TB infection is an essential part of stopping transmission. This is just an example from Alaska. The CDC found very high rates in certain parts of Alaska in the 1950s, as high as 2,000 per 100,000 in some areas. They started an ambulatory treatment program using active case finding and X-ray, and they initially got this decline that you can see here. But new cases began to emerge. And in 1957, they started to treat TB infection, as you can see here, and they really got that drop that you can see right around 1957 here in this example. So rates went from around 2,000 per 100,000 in some areas to as low as 240 per 100,000 in less than a decade. And so, what is the recipe for these epi control principles? First is searching actively using a sensitive test amongst high-risk groups. Second is initiating therapy promptly using multi-drug therapy to avoid resistance. Third would be to treat contacts that don't yet have active disease with post-exposure prophylaxis. And number four would be to support patients, providing patient supports, particularly to those who may need additional support, adherent support. So what is achievable now that we know what is needed? What is the recipe? As I mentioned, Alaska in the 1950s had some very high rates. And the areas in Alaska obviously are very cold. There was a lot of people living in crowded units. Alcoholism was very high at the time. People were living in isolated communities, and the prevalence in some areas was as high as 2,000 per 100,000. And Alaska started a community screening program using X-ray, treating active TB. They built hospitals, and they saw, again, that initial drop. But it really wasn't until 1957 when they started treating TB infection in the community in large groups that the rates went down drastically. In New York City, there was a huge TB outbreak in the late 80s, early 90s. The number of cases tripled within 15 years. It coincided with an HIV outbreak. Parts of central Harlem in New York City had rates as high as 200 per 100,000. And so what did they do? They started a community-based program to screen and link patients to care. A lot of the individuals were homeless, people who used drugs, and they started actively looking for cases, treating all forms of the disease and supporting patients, through adherent support. And the rates dropped very quickly in 6 to 7 years. They had 3,755 cases in the early 90s and now have approximately 600 cases annually. In Russia, my group started working in Russia in the late 90s, early 2000s, around the time of the collapse of the Soviet Union. And we know that at the time there was very high rates of unemployment, incarceration, alcoholism. There was a fast-growing HIV epidemic. And there was an emerging multi-drug resistant TB epidemic at the same time. And so my colleagues from Partners in Health started working in the Russian in Russian prisons in Tomsk alongside the Russian authorities, who are already running a very good program treating regular TB and drug-resistant TB. And they were actually able in this area to bring the mortality down to 0. And then, as you can see here in 2004, the group received a Global Fund grant to treat all patients in the community and to provide patient support. And like I said, the Russian program was already very strong and was doing latent treatment and active case finding. And so they saw that with this addition of patient support, that they were actually able to have a massive drop as compared to other areas in the surrounding areas. The mortality actually dropped by 80%, and the TB rates dropped in half in a decade. And again, what did they do? They searched actively, they provided patient support, they treated all forms of TB. I just wanted to quickly give a couple of other examples. In Singapore, which is not a closed system, meaning that many people come in and come out for work, often from some high burden settings. Before 1997, they were only treating active TB, and there wasn't treatment of TB infection, except for in young children who are household contacts. And the rates, as you can see here in the 90s, between 1990 and 1995, the rates really began to plateau. But as they added infection and treating infection of all contacts, as well as high-risk groups, including prisoners, those in nursing homes, mental institutions, as well as providing adherence support, including directly observed therapy for patients that needed it, you can see the rates really began to come down around 1997. In Taiwan, they also wanted to bring down their rates of TB. They're not a part of the UN, so they don't have WHO advisors, and so they looked at examples from the US CDC, from New York City and other places, and they implemented a comprehensive approach, and they now have rates of around 30 per 100,000. There are more examples, but I just want to quickly explain what do these programs have in common. They search actively with the right test, with a sensitive test. They test properly in high-risk groups, so they know the local epidemiology. They know where to be looking. They also treat promptly and effectively, doing drug sensitivity tests to ensure that the right drugs are, the right combination of drugs are provided, and they promptly start treatment. They also prevent exposure by infection control and treating exposure by priority. And because the program in Tomsk, for instance, was not a perfect program. It had many gaps, but they did all of the pieces simultaneously. And that's why we have represented this by a chakra, the search, treat, and prevent. So in 2012, a group came together in Cambridge and said, can we take these examples that have been done and do them on a global scale? And the group brought together academics, practitioners, individuals from the USAID, the WHO, and said that if it worked in Tomsk, can we achieve 0 deaths worldwide? The data was presented from Alaska, from Russia, from New York City. And we said, how can we accelerate the rate of decline in other areas? And it became very clear that we needed the right strategy using sound epidemic control strategies like what was presented earlier, and that we also needed to unit of intervention. And we needed to focus on a model of delivery that goes into the community and into the households to screen and to link patients. So we started something that's called the Zero TB Initiative. And that was started in 2015 by three different groups. Excuse me. So the Zero TB Cities project was started as a platform for cities to work together and to share innovations around finding patients, using index cases, screening households, getting people treatment, and those who are exposed on prophylaxis and providing support. And the Zero TB initiative was started by the Stop TB Partnership, Interactive Research and Development, Advanced Access and Delivery, which is the organization that I'm with, Partners in Health, and Harvard Medical School. And we really wanted to create a network of cities and sites that are using a comprehensive approach to eliminate TB that can share strategies with one another. And one strength of this has really been the collaboration of sites that have been able to exchange operational lessons and to really create a global coalitions as they move towards zero. So I just wanted to share this in closing, that the Zero TB initiative has over 50 partner cities around the world that are working together, and they're really working to support local governments by bringing together partners to think about these parts of a comprehensive program and how might we come together to fill different gaps. The idea is really to think about how do we create islands of tuberculosis elimination, whether it's in a small area of a city or on an island, that can then be used to be a model for expanding that to larger areas of a city or even the entire country. And so what we've really been able to do is create a network of cities now that have demonstrated what is possible and now can share strategies and approaches to optimizing the delivery of care, supporting patients. And so we have been able to bring together cities for conferences all around the world to share their lessons and to learn from one another. So thank you so much for this opportunity to share with you all today.
Огромное спасибо, Майкл, за такую...
Thank you very much, Michael, for such an informative presentation. I'm sure we'll have time at the end of the session to ask questions and discuss very interesting experience and active detection and preventive treatment. Now we move to our next presentation. And with great satisfaction, I would like to introduce you to my colleague from National Reference Laboratory, Kyrgyzstan, Altyn Iskakova, one of the leading laboratory physicians who is responsible for a number of key components on diagnostics, including sequencing. And she will talk about the experience of introduction of the testing of latent TB by introducing quantiferon TB Gold method. Altyn?
Добрый день. Меня слышно, да?
Good afternoon. Can you hear me? Yes, we can.
Добрый день. Меня зовут Altyn
Good afternoon.
Iskakova.
My name is Altyn Iskakova.
Я работаю врачом-лаборантом Республиканской референс-лаборатории Национального центра педиатрии Кыргызстан. Сегодня я хочу поделиться опытом внедрения тестирования латентной туберкулезной инфекции тестом quantiferon TB Gold.
By quantiferon TB Gold test.
Внедрение теста проходило в рамках
Introduction of the
проекта
test conducted under the project OTPH. Somehow my slides are not changing.
Сейчас повторюсь. Получается, внедрение теста проходило в рамках проекта STOP-TB совместно с USAID и нашей национальной референс-лабораторией Counting. В рамках проекта было выбрано две большие группы. Одна из групп — это тесные контакты семейные среди пациентов, которые находились на лечении в Иссык-Кульской ОЦБТ. Это один из областных центров борьбы с туберкулезом. Вторая большая группа была это, получается, сотрудники противотуберкулезных учреждений. Из сотрудников противотуберкулезных учреждений было взято 404 человека. Большая часть это было НСФ национальный центр
Majority was
психиатрии.
National
Также было
Center
взято
of
4 группы.
Psychiatry
Это
and 4 groups
республиканская
from the
противотуберкулезная больница
Republican
Карабалта,
anti-TB
98 человек, и
hospital.
Минская
98
противотуберкулезная
people came
больница
in.
37 человек,
Tuberculosis Hospital,
и
37
Иссык-Кульский
people.
областной центр борьбы с
Cool
туберкулезом.
Regional Center.
Средний возраст
And
где-то
the
было
average age
47,
was about
53.
47, 53.
По должностям это были взяты, в принципе, все сотрудники, которые работали в этих учреждениях, главные врачи, медсестры, сотрудники администрации, технические сотрудники, санитарки, лабораторные сотрудники.
Lab staff.
Из группы семейных контактов были взяты, как я уже говорила, контактные лица пациентов, находящихся на лечении Иссык-Кульского ЦПЦ. Было взято 252, было обследовано 252 контактных лица в возрасте от 10 до 100 лет. И, как мы видим, у нас латентная туберкулезная инфекция была выявлена у 41% контактных. Если смотреть первичные результаты, то вот у контактных где-то 41% был взят, а у сотрудников ТБ-учреждений чуть больше 30%, это не доходя до 40%. Если взять с пограничными еще значениями, то более 50% где-то среди сотрудников.
Dimension, so it's about 37% among staff.
Также смотрели распределение по возрастам, и получилось, что у лиц старше 60 лет было самое больше обнаружено позитивных тестов. Если брать по должностям, я не думаю, что это показательно, потому что взята была какая-то группа сотрудников, не вся страна. Вот получилось так, что больше всего позитивных результатов было у сотрудников лабораторий. Второе место занимали это сотрудники администрации, главные врачи, ну и врачи. Самое меньше было позитивных результатов среди административных сотрудников учреждений. Если брать по... Ну, также рассматривалось по отделениям, тут, в принципе, более-менее равномерно было. Немножко странно, что было очень большой процент позитивности в республиканской референс-лаборатории, самый такой большой процент. Следующий большой процент позитивных был в отделении МЛУ, Национального центра педиатрии, а так уже, в принципе, по всем остальным отделениям было более-менее равномерно. 56 человек среди сотрудников ТБ-учреждений. Для 56 человек было взято более одного теста. 2, 3, 4 раза их тестировали. Ну и здесь показаны графики, как у них этот тест был положительный, отрицательный. На слайде видно, что среди этих 56 человек стабильно отрицательными были 16 человек, стабильно положительными оставались 19 человек. Реверсия была у 5 человек. И конверсия была у 16 человек. То есть из 56 человек, которые были отрицательны в начале исследования, потом у 16 человек были обнаружены положительные результаты. И на основе вот всех проведенных этих тестов были сделаны выводы по проекту, что предположительно базовый показатель позитивности в популяции это 15-30%, показатель позитивности среди семейных контактов 41%, показатель позитивности среди сотрудников ТБ-учреждений 62%, в регионах было меньше позитивных результатов, где-то 38-39%, и самое большее это в Национальном центре в
and the biggest was in the national pediatric
По
center,
группам рисков, если
54%.
распределять
By risk groups,
сотрудников противотуберкулезных учреждений, у нас получилось так, что
in
самый
the
большой
TB
риск
institutions,
у
the
лабораторных
highest risk was
сотрудников,
among the lab
затем
workers,
у главных врачей,
senior
потом врачи
doctors,
идут, санитарки,
doctors,
самое последнее место, медсестры.
technical
Самая
personnel, and
низкая
nurses.
вероятность инфицирования сотрудников оказалась у
The
сотрудников
lowest
детского
probability
отделения
of infection
Национального
among
центра
staff was
педиатрии, а также в других детских
the
отделениях.
members of
Высокая
the
вероятность инфицирования была в ПЛУ
children's
отделении,
section.
и самый большой
The
риск
highest
инфицирования, почти
probability
в 2
was
раза
in
больше, чем
the
в других, это МЛУ отделение Национального центра фтизиатрии.
National Center of Physiatry.
И все это говорило, что у
All
нас
of that
имеется
showed
сильное
that
доказательство
we have
наличия
a big
передачи
evidence of
инфекции в
the
ТБ-учреждениях.
transition of infection in the TB institutions.
Ну и дальнейшие планы по
The further
внедрению
plans
квантифицированного
on
теста TB-Code,
the
и
introduction
для
of
кого мы
the
собираемся
quantified
использовать
TB
этот
gold
тест,
test and
то
towards whom we want to
для лиц,
use it.
контактировавших с
These are
TB-пациентом.
persons who
Первая
were in
группа,
contact
вторая
with
группа –
the
это
TB
ежегодное
patient. Second
тестирование
group, it's
сотрудников
annual testing of the TB
TB-учреждений
institution staff
при поступлении на работу в TB-учреждении,
while employment
при
with
увольнении
the
с
TB institutions,
TB-учреждения. Для лиц,
dismissal,
контактировавших с TB-пациентом в лечебных учреждениях общего профиля,
persons who
возможно.
contacted with the TB patients
Также
in general
возможно проведение
profile
квантифицированного теста у лиц
hospitals,
среди стационаров общего
test
профиля, которые планируются на взятие на
among persons
иммуносупрессорную терапию.
for
А также использовать
immunosuppressive therapy,
этот тест
and
как один
use
из
this
методов
test
диагностики
as one of the
ТБ
methods
у
to
детей.
diagnose TB among children.
Ну, спасибо большое за
Thank you very
внимание.
much for your attention.
И про сам тест, я так поняла, будет следующая
And
лекция уже.
there is a next presentation about the test itself. Thank you very much, Altin. Indeed, a very interesting presentation. Thank you for keeping up to time. Yes, when we talk about preventive treatment, the first question is what kind of diagnostic methods we're going to use. And this is one of the key questions. And we will continue this theme in the next presentation, which is called changing paradigm from active identification and the role of the target test of testing among adults and children in decentralized conditions. Thank you. My name is Vladislav. I'm very happy to start my presentation. I'm sharing my screen now. You can see it, right? Yes. Thank you. First of all, I would like to introduce myself. My name is Vladislav Nikolaevsky. Currently, I work at the company Hygiene. I'm the director on medical issues and specialize on immune diagnostic of the tuberculosis and other infections, in particular COVID-19. And I'm very happy to see many of my colleagues whom I know through work in different institutions in this meeting. Kaizen, I worked in the UK and I conducted scientific research work. I know many colleagues and pleased to see you all again. During next 15 minutes, I will try to cover issues related to the role of tests and assays in diagnostic of TB infection and talk to you about and focus on strategic issues rather than practical and technical. First of all, continuing the presentation of my colleague from Australia, my few slides will be about global epidemic of TB. We know that the number of the cases are not drastically reduced. There is a big number of not diagnosed cases, and there is a big number of the known cases with multi-resistancy and what we call the shock resistance. And unfortunately, COVID-19 pandemic is not helping us at all, and the situation is becoming worse. As far as existing cascade of the AIDS against tuberculosis. Even people with active tuberculosis that we can see on the surface, there are certain problems. First of all, with diagnostics, treatment, success in treatment, and due to many reasons. First of it is related to different delays in diagnostics, we'll know about it, delays in treatment, and no commitment to the treatment, and the results are not that good yet. But entire problem, was the biggest part of it, is because when we talk about the existing cascade tuberculosis 8, we often forget about this bottom part of the iceberg, which is the main reservoir of tuberculosis, active tuberculosis, which is always filling up this active tuberculosis. This is so-called latent TB, that includes latent infection and so-called incipient TB. I'm not sure that the translation is correct into Russian, but also subclinical TB patients. Although so far we haven't reached full consensus about what is the difference between latent, incipient, and subclinical tuberculosis, it is clear that without involving the close attention of diagnostics and anti-TB therapy and preventive therapy, we most probably within the region and the world won't be able to handle. Few words about COVID-19 problem. In my previous life, when I worked in the National Reference Laboratory and coordinated a number of the European projects, we conducted research in 2020 related to how pandemic affected lab activity in the first months of the pandemic. Unfortunately, it was 1 year ago. The situation was quite dramatic, and we will be feeling the impact for quite a long time. So on the slide, you can see how this affected the National Reference Laboratory work in the European Union, and mainly it was training, enrollment of new personnel, and supporting competence and research work. And this is dangerous because these two types of activities, which are currently or then were not that important, or less attention has been paid, they are important to support the quality and improve the quality of diagnostics. Diagram on the right shows how many labs out of 27 participants suffered reduction of the number of the cultures and other materials for diagnostics. And on the peak of the first wave in April-May 2020, more than 3/4 of the labs suffered from reduction, and in half of them it was more than 50%, and that means not detected cases of active tuberculosis. Going back to the eradication of tuberculosis, still in spite of the COVID-19 situation, TB eradication is possible, which most probably could be achieved by changing strategy and paradigm and start diagnosing latent tuberculosis and offer prophylactic preventive therapy. And here you can see that if we introduce new methods of diagnostics, in particular latent TB, by 2035 we'll be able to reach target indicators, but only if we do good prevention and treatment.
На слайдах из рекомендаций Всемирной организации здравоохранения. Они нам известны. В настоящее время рекомендуется ВОЗом применение как туберкулиновых кожных тестов, так и игротестов для диагностики латентной туберкулезной инфекции в определенных группах. В частности, вот эти группы, они здесь показаны в центре слайда, группы риска, в которых показано применение тестов на латентную туберкулезную инфекцию. Однако много существует исследований относительно того исследования.
However, there's a lot of research compared with the IGRA test or skin tests, and in particular IGRA. And this diagram shows significant logistical or organizational issues related to this, with the skin test in particular related to the fact that skin tests, as we know, they require 2 visits, and administration of skin tests. So the injection of the tuberculin and many. Plus, in addition to that, we also know there's a global shortage of for this test, tuberculin for this test. But at the same time, IGRA assay, we can talk about quantiferon, about other tests. They only require 1 visit, and the results, the reading of the results is more objective. On this slide, I'm sure, again, I'm not going to stop here because we're pressed for time, but nevertheless, there's hundreds of publications that says that the 4th generation of quantiferon, which was introduced in 2018, it shows the better outcomes compared to previous generations of tests, and also in the special and certain groups of the population of among the older people living with the HIV, people living with the HIV, as well as among. So there is that show high efficacy and efficiency of using the quantiferon. Here, I wanted to speak about quality of indeterminate rate, because as far as I understand, in many countries around the world and many categories of patients, they are not patients, I'm told, but the physicians, the doctors, when using this test, they have certain fear that the level of indeterminate rate might be high because of, in particular among children, and younger than 5 years, and HIV people, as well also with the immunocompromised patients. We have publications here about this that show that the percentage or the level of the share of indeterminate results is not very high, and when conducting the research, it could be slightly higher than people that have some other issues, health issues, but then the rate of indeterminate rate among children in HIV is rather low. Recent publications from the 6th of September in the Lancet journal. This research was conducted within several years in the United States of America. This publication from CDC, it's a CDC publication, and it shows that the results of the IGRA assays in the high-risk groups in comparison with the tuberculin test skins. However, what are the problem? What are issues? Of course, again, there was a very good publication in 2020 again by a Canadian group. So they looked at many countries around the world and the problems, and everybody knows about those issues, those problems, and the producers also are aware that the main problems are, first of all, the high cost of tests. So it's a problem is the same, lack of budget or maybe high price, but also in 17% it has to do with the lack of laboratory infrastructure and inadequate access by the laboratory personnel. So infrastructural problems, training, and the availability of tests. This is apparent, and that's why the company is proposing a new solution, new methodology, so-called high-rich quantiferon TB. This is a methodology. The main purpose of this methodology is to bring this testing to the patient, closer to the patient. The main difference is that for diagnosis you only list one compared to 4 milliliters that quantiferon plus used. And there's also we provide so-called set also includes e-hubs, it's electronic devices and tests. So they use exposable cartridges where there is a reaction happens, and within 20 minutes you have either negative or positive results. This slide shows you how the testing has changed, how the testing will change compared to other technology, quantiferon technology, and there's a new technology is proposed. So we won't need a centrifuge. We won't need. So this essay or this test from 15th of September is available commercially available. CMOC, and there's been several research conducted that shows the efficacy of this test, in particular in Zambia. This was a usability study which shows that it doesn't require big training, and recent publication in Pulmonology, the first research on susceptibility and sensitivity shows 100% sensitivity for determining active tuberculosis. Very overview of conclusions. The main conclusions are it's necessary to focus on not only finding new tuberculosis, but also diagnosis of latent tuberculosis and prophylactic treatment. IGRA tests, IGRA assays, I think they're more preferable than tuberculin tests. And lastly, innovative decisions are necessary to bring this test closer to the consumer. So, and among patients, among regions with high burden of TB. Thank you very much for your attention. Thank you very much, Vladislav. You were within your time frame allocated for you. Despite that, you had a very good presentation. Thank you for that. And we still have some time for Q&A if there's any questions, because the topic was rather interesting. And I don't know, Gunt, is there some questions in Zoom? Is everyone, or can someone maybe ask a question now here? Thank you, Timur. Thank you very much. Thank you to all the presenters. Indeed, it was a very interesting presentation, not only because we are conducting this session, but they were really interesting topics. There a lot of thanks, especially to Altin. Altin, there was questions for Altin. Were there measures taken in connections to improve the infectious control based on the results of piloting? And Altin writes that she thinks, yes, not so very cardinal, but not fundamental. There's a lot of discussion. I would like to now ask Kylene.
LTBI testing method did you use in your study?
Was the question about what LTBI method? Yeah, so we were using tuberculin skin testing. We had considered some of the other IGRA platforms, including the KaiReach one, which we just heard about. But in the context, there's a lot of sort of issues with sort of supply chain and cold chain, and the requirement for venisection, particularly in looking at young children initially, was probably a limiting thing. So at the moment, still tuberculin.
Yeah, okay, thanks. I see. Я вижу, что в чате написали коллеги, что они закрылись.
I think colleague, they closed their session. So I think, Timur, I think we need to go back to the plenary session, unfortunately. If I may, one question to Vladislav. So right now we can see many countries use different tests. Somebody uses TBT, somebody switching to AGRA assay. Some countries, they use both of them. Do you have any data where countries were switching from tuberculin to AGRA and how it impacted detecting latent TB, because it's also very interesting for us for the future, something to thank you very much, Timur. Yes, there are data, but not from the high level to the high incidence level countries, but from countries with lower incidence rates. But the main advantage is that especially among children, when we conduct testing among children, the number of so-called false positive, not false positive results, but results that are positive in testing and negative in AGRA, and so these results do not require preventive treatment. Very often they don't even require follow-up. That's why the costs are reduced. So this is the main thing that I can say about the cost effectiveness. Cost effectiveness is a rather difficult issue, but at the same time, we do in our company, we conduct research. Maybe we can offer some instruments for cost efficiency. So the tuberculin tests are much cheaper. We all know that. AGRA assays, I don't think they can compete cost-wise, but however, in terms of reducing need, although AGRA assays are not ideal, they will allow save money. This is the maybe it's not a very specific question, but this is the answer that I have right now for you. Thank you very much. Then we'll wait. Then we'll wait for the session number 6, and we'll have some time to discuss our presentations, maybe more detailed and with a certain focus. Can we start, or what are we going to do now? Then okay, then we'll start. And so number 5, right?
Я не буду, наверное, сейчас
I'm not going to describe the presentations that we heard today, and you heard them as well. I will only stop in some moments which I think they were rather interesting, and which I think maybe we need to focus our attention to. The first presentation by Hai-Ling Huan. He talked about experience in Papua New Guinea, and what was interesting for us is that a country with high prevalence of TB and MDR TB. So they showed us that this comprehensive approach, cascade approach, inclusion of on active and latent TBs and active TB. It shows rather good results. And we heard about preventive treatment, and outcome was really good. This was a good parameter for us because we very rarely we follow what other countries are doing. We know how many people have started treatment, and sometimes this type of information is not available for us. How many people started, how many finished treatment. And second presentation was also rather informative, and I think again the thought from the second presentation, the search, treat, and prevent, it corresponds with the current strategy by the USAID, which uses this is very identical approach. As we follow this, again brings us to think that we don't need to invent a wheel. There's a very effective, efficient, practical models. We saw the examples of some. This was Alaska, New York City, how combination of active finding and rapid treatment and preventive treatment, combination of all three, they radically change the situation and they reduce the prevalence of TB. So we talk a lot about the preventive treatment, about coverage, how it can reduce the incidence by 10% per year. But looking at these tactical results shown, examples that were given earlier, we'll see that this reduction was rather dramatic. This is a very encouraging news for all of us. for future planning, so to say. Now, this is it. What I wanted to add on my behalf. I give floor to Ms. Gunta. Thank you, Timur. Yes, we had 4 presentations, and third presentation by Michael Wilson, NVH Advanced and Accessible Delivery, about rather comprehensive, I don't know how to say it in Russian, but approach to eliminate tuberculosis. It was really interesting to see the history, go back, travel back the history and see how the TB was fought in many cities like New York City, Singapore, many places, and it showed us the approaches and experience of the zero TB cities project, and recommendations were. It was really important to involve local administration, local authorities, all the partners, and create like islands with good models, which could be then upscale for the entire country. And after that, come up with a network of cities that can share strategies and best practices. Very interesting presentation, the last one by Vlad Nikolaevsky from Gaijin, about the role of IGRA assays in testing in case management for TB for children and adults. And very important thing that Vlad mentioned in conclusion, that to be able to achieve ambitious NTB goals, we cannot but work on finding and treating TB infections. This is just impossible to achieve. And of course, IGRA testing needs to be looked at in the context of testing and treating. Without treating, it doesn't make sense to test. Very interesting presentations. Thank you, Timur. Thank you to all presenters. I think we'll now give floor back to the 6th session, right? Thank you very much, Gunta.
I will try to summarize our presentations. But before and it was dedicated to operational research completely. But before I go to the details, I think I feel like I need to touch a little bit the context. Because it describes the relevance of very well the relevance of operational research. In general, to achieve the ambitious goals to end TB, the countries need to eliminate the existing gaps in their respective TB programs, starting from case detection to successful treatment. But we all know that this situation has been severely affected by COVID-19 pandemic, and we discussed a lot about this. So I will not stop, but I just want to mention 2 things. In Tajikistan, a while ago, NTP, together with PAS Moldova, conducted a patient pathway analysis, and that indicated that during COVID-19 pandemic, the majority of TB patients delayed healthcare. They ended up quite late with more advanced diseases, which means they were spreading the disease in their communities for a longer period than they would have done so before the COVID pandemic. Besides, the NTP Tajikistan, together with the USAID, they conducted a modeling study to measure the possible impact of COVID-19 on TB incidence in the coming years. And as Dr. Asledin Ajabzoda mentioned yesterday, this study demonstrated that depending on the level of disruption, it could take anything from 18 months to 5 years to recover TB program to the pre-pandemic level. It depends on the number of waves and the measures taken to control COVID-19. Now, all this happening when the countries had committed to very ambitious national targets, which were based on UNGA targets. The problem is also that now we are all lagging behind our targets, and we are even behind that where we were before the pandemic, which means we are desperate for better diagnosis and rapid, more patient-friendly and short treatment regimens. Approval of this new regimens that are coming in pipeline and are in development all depends very much on operational research. So I just really wanted to link this to the presentations today, because not all countries have the same capacity to conduct the operational research. Here's a good example, the presentation, the first presentation about, which was presented by Dr. Jamshed from Uzbekistan about the SORT-TB training, SORT-TB structured operational research training, which started in 2019, and it's entirely dedicated to build the country's capacity on operational research. They had these sessions face-to-face in 2019, but because of the pandemic, they had to delay the third session and do it online. But it still didn't prevent them to actually publish 12 manuscripts out of 13 that were submitted to the International Journal of Environmental and Research and Public Health. And I think this is a very impressive achievement, but also it's a very good demonstration to other countries that there are resources to build the capacity to conduct more operational research. Also, in terms of support that countries need in tackling TB problems, but also conducting more operational research requires some external assistance. And I think the last presentation by Dr. Togdan Kalon was a very good example how much support, tailored support, can organizations, partners provide to NTPs. He described the ETICA support, and it's a very good example in to provide support in a sustainable way, because it's all technical and it's based on needs, and it leaves behind the technical knowledge. I will not go into details of the aspects of the support ETICA provides, but I just wanted to highlight that coordination efforts are very important to conduct the to support the NTPs. And then one of the important presentation by Dr. Erke Bulan was about ADSM. And I'm glad to hear that this is very well set up in Kazakhstan, and it's set up from like primary healthcare level up. And also, I'm sorry, I think I've
that was Bates.
Dr. Bates.
Bates was excellent. She is indeed coming from another side of our community farm committee, and having such a very well concerted interoperable cooperation between TB and farm regulatory agencies at the country level was an excellent example. Thank you indeed.
Exactly. And also it's important to know that this ADSM is completely backed up with the country's legislative framework. So it gets entire support from the country, from the government. And also is included in their national plan for 2021-2025. I think this is amazing. And then the two presentations actually were demonstrating the interim outcomes in the process of implementing MSTR treatment regimens in Kazakhstan and in Tajikistan. Both speakers described the process, and there are many similarities between these two presentations and two operational researches, but there are also some differences. Maybe differences based on the presentations, maybe that they're not just differences, but it didn't really come up through the presentation. One thing is that in Tajikistan, they include children below 6 on Delamanid-based regimen. So they have included small children in their operational research. I'm not sure if this is happening in Kazakhstan, actually. And the regiments, so there's the third regimen in Kazakhstan that includes pyrazinamide, which is not presented in Tajikistan. I think it'll be very interesting to wait for the outcomes of these two operational research. They have this main objective to assess the effectiveness and safety of the regimens, but there are lots of sub-objectives about the predictors of side effects and other issues, as well as follow-up 12 months post-treatment and defining the rates of the relapse. And I know this is what we discussed today, and there are lots of other operational research out there. So I just wanted to thank the presenters and also encourage the NTPs to take up and use all the resources existing to strengthen the operational agenda in their respective countries. I think I'll hand over to Kathy and Andre now.
Yeah, thanks very much. A lovely summary. I don't have much to add, except I think it was a really excellent session, and I would encourage everybody to try to watch the recorded versions, because it really highlighted the added value of the operational research to help programs, for example, developing their diagnostic capacity, which was obvious was posing a problem during the operational research. So for the program, strengthening that was an advantage. And also even from Kazakhstan, the PV, the strengthening of that, they have now an electronic system. As I said previously today, it's incredible how far we've gone in the last few years, and it's excellent to see this region really powering ahead and using operational research as a tool to not only contribute to the evidence base on DRTB regimens, but also strengthen their own programs and capacity. So just well done to all the presenters. So I'll just hand over to Andre, who would like to just share something more about the European Research Initiative. Over to you, Andre.
Yes, indeed. Thank you very much. Please confirm you see my slides.
Yes, thank you.
Affirmative. And so I will not take a lot of your time. There will be only a 3 minutes interventions. And thank you once again for the host for letting me up doing this. And to thank also the USAID who supported us in the initiative for the regional platform, setting up the European Research Initiative, which is basically a catalyzer for introducing the new applications of an innovative one for the prevention and the treatment of tuberculosis. So back in 2017, the ERI has been set up here by the regional director of the WHO and being hosted by us here in the role of the secretariat itself. So currently the overall network contains about 350 members across the 50 countries of our region. The overall network defines the priority to operate in the framework of the operational research by a core group, which is an advisory body, independent one, that tells to the secretariat, to us, to the ERI secretariat, which activities needs to be prioritized. And of course, since the ERI has 3 objectives, which is identifying the priorities for the research in the region, which are basically a gap in the research knowledge, and those needs to be eliminated. The second one is build up the capacity, and you saw basically a presentation of applying the SORT-TB course, which has been initiated here at Euro at the country level. Jamshid did that presentation excellently. We do believe that so-called alumni, the European alumni, European SORT-TB alumni, are the future of our frontliners fighting against tuberculosis. They will take over the management at the national level and enlarge the capacity of applying the new innovation through the operational research mechanisms. And of course, under the third objective is the inter-country big studies, and it was several times mentioned in the framework of the conference, the MSTR and other studies. We did have also a study related to the identification of the barriers in TB and HIV collaborative activities. Soon we will launch a new inter-country study related to the preventive treatment of the MDR contacts, and so on and so on. And so here is basically the ERATB, European Research Agenda. You can find there 76 research priority questions. Take it, and implement the research. If you need a mentorship, please don't hesitate to approach the ERI Secretariat, and we'll try to identify to you someone that will guide you through the process of the research implementation. And the last slide is basically the website. I would also like to advertise the cyber space, which we've established since the COVID put us down in our countries and restricted our face-to-face operations. So we've established a virtual workspace. I will soon put the link in there. There are already 120 participants there. Many of them are the moderators. You could raise your question there, and we will affiliate you to a respective moderator and a mentor that would help you to implement your research study. Thank you once again for the organizers and the host of the conference. Much appreciations to Nana and to Katie for being with me and co-moderating the research session. Thank you very much indeed. It was Andrei Dadu streaming from Copenhagen. Over.
Дорогие участники, да, на этом мы завершаем обсуждение сессии 5 и 6.
Dear participants, this is the end of discussions for sessions 5 and 6, and now we are switching to the final stage of the conference. Summary and resolution.
Спасибо большое, Тимур, Андрей, за...
Thank you very much, Timur, Andrei, for excellent moderation of our last session. Yeah. Now, dear colleagues, we are coming to the final stage of our conference. So I would like to give the floor for a presentation on the draft resolution of our conference to Dr. Trubnikov. Alexander, after you hear it, then we will send it to all the participants. So you could comment on this resolution. So if possible, please submit your comments by the 15th of October. And after that, the final version will be made available for everyone. Thank you for this opportunity. So resolution of the 5th International Conference on Integrated TB Control in Central Asia. We, the conference participants, referring to the resolution of previous international conference on integrated TB control in Almaty in 2016, in Bishkek in 2017 in Dushanbe, and in 2018 in so referring to the political declaration of the UN high-level meeting against TB and the strategy till 2025, and recognizing the WHO strategy for TB elimination, which was approved at the 6th session of the World Health Assembly as a guiding document, shape the goals and objectives of the national TB control services in Central Asia countries. As part of reaching the objectives of the global TB strategy by 2030, and relying on the goals identified at the UN high-level meeting on TB, for 2021-2022, and the political declaration coordinated by all UN member countries, and having the new global USAID initiative, will to be accelerator and give us sustainable health systems in the region, which currently are the key tool for countries to provide high quality TB services for the population, but they are in need of further strengthening and improvement, and recognizing that along with visible progress towards decreased mortality and morbidity to be in the region, there are still multiple factors that prevent us from scaling up TB diagnosis and treatment, especially for the RTB and TB HIV. Given the impact of COVID-19, the deterioration of health system operations, namely TB programs, and negative effects on TB detection and uninterrupted access to treatment and greater stigma and discrimination, we would like to adopt the following resolution. We would like to confirm our determination to combat TB as envisaged by the TB control strategy and the key objectives of the high-level UN political declaration to combat TB till 2022. We would like to invest every effort to address the following objectives. First of all, to enhance political commitment in Central Asia countries to ensure TB control, and we will use a multilateral approach to detect at least 90% of cases and to ensure treatment success for at least 90% of detected cases in the context of pandemic of COVID-19 and its effects on TB services. We will ensure access to services. Second, we will need to use the available financial resources as effective as possible and ensure a transition of countries towards self-sufficient, and we will advocate for increasing the amount of programmatic and financial services for better quality of TB services, and after that, to ensure further development of TB services in the context of COVID-19 pandemic. We will ensure that TB programs respond to COVID-19 given the COVID-19 response plans. Ensure universal access to competent services to ensure early detection and treatment and dispensary observation for everyone, regardless of social, economic, and any other status if a person is affected by TB, including in the penitentiary system. And also, we will improve early detection and rapid diagnosis mechanisms at the level of primary health care. We will contribute to better quality for monitoring and treatment at the outpatient stage. We will ensure reliable cross-border control of TB among migrants, and we will finish the activity towards signing multilateral country-level memorandum to ensure interaction in this area. We will also consider additional opportunities to introduce new TB rapid diagnosis technology and consider additional opportunities to introduce innovative techniques to ensure patient care and the strengthening of TB services. We will improve access to rapid TB diagnosis, including TB with multiple drug resistance using new techniques. And we will enhance use of new drugs and shorter treatment regimens for all patients with drug-resistant TB, ensuring adequate pharmacovigilance. And also we will ensure availability of TB drugs of relevant quality, and we will promote implementation of the accelerated registration strategy, and we will ensure adequate and timely diagnosis and treatment of pediatric TB, and special attention will be paid to measures against the spread of TB, both in health facilities and at the community level. We will recognize that the problem of TB HIV prevents us from reaching our original goals, and we will need to take urgent measures to provide TB HIV patients the services, patient-centered services. And we will contribute also to international research, engaging international agencies as partners, and we will disseminate adequate and reliable epidemiological data on TB, drug-resistant forms of TB, TB HIV in Central Asia countries. We will contribute to strengthening civil society and communities of TB patients, and we will implement and assess national TB programs in terms of reducing stigma and discrimination and ensuring early detection and treatment of TB. We will also engage a mechanism of social contracting as part of public funds, and other opportunities will be used so adequate financing could be provided to organize civil society efforts when providing psychosocial support, we could ensure active case detection. Then we will expand use of best practices with regards to engagement of civil society in anti-TB activities, focusing on vulnerable groups, including migrants and people in the penitentiary, given the human rights and gender aspects. So, and the last is to conduct the 6th International Conference on Integrated TB Control in Central Asia in 2022 in Nur-Sultan in Kazakhstan. Now, finally, we commit to implement this resolution immediately in coordination with all the partners and in cooperation with all stakeholder ministries, agencies, and the civil society. Thank you.
Спасибо большое, Александр.
Thank you very much, Alexander, for reading this resolution.
Reading of the resolution, and as I mentioned, it will be distributed to all the
And
participants.
reminder, we will send this resolution to all the participants,
and
and by
comments till October 15.
we will be waiting for your comments.
Now,
finally, I would like to
give the
floor to
final
representative
remarks
of
to Leon Kupins, who is
WHO in
WHO
Uzbekistan,
representative in Uzbekistan.
Leon
Video
Kupins.
message. Уважаемые гости, коллеги, друзья.
Really like to thank you on behalf of the WHO for your attendance and your participation in the 5th International Conference on Integrated Tuberculosis Control in Central Asia. Thank you all for the speakers, for their contribution to a very successful program. And obviously an ongoing vote of thanks for the partners, for the Ministry of Health, for the national TB programs in the Central Asian countries, but also to the KfW, the USAID, and other partners. Only through partnership we can make the progress happen and we can make the changes we need to make. I've been told that the conference topics were very interesting. I myself could only attend a few online sessions, but those which I attended were extremely interesting. So again, a big thank you for all of that and all the comments and the questions which were raised by the audience. So, colleagues, I hope you really enjoyed it, because I mean, when you are taken away from your day-to-day job, you are able to, in this conference, hopefully to learn a lot, to get the bigger picture, an overview of the bigger picture, what is happening in Central Asia, to learn from each other, to share ideas, and to come with innovative thoughts and ideas, of course, sharing results of research, sharing ongoing progress, sharing challenges, which we also need to hear and listen from, and then bring that all back to your daily job in your respective countries. And hopefully you learned a lot, you shared a lot, and you really enjoyed this international conference. So a big thank you again to everybody who contributed, but also those who were behind the scene, who made it happen. My own WHO team here, the speakers, the translators, all those people behind the scenes who we don't see, but contributed to the success of this conference. So, and we hope we are even getting a better and more interesting conference in 2022. Not saying that this one was not good enough, but we always hope for better and more technologies, more advanced technologies, ideas, research results, etc., etc. Wishing you all good luck in the future, and bring all this beautiful knowledge back to your respective countries in your daily work. Thank you and goodbye. See you next year.
Спасибо большое, госпоже.
Thank you, Madam Leon Kupins, for kind words. and for your wishes for the future. Dear colleagues, on behalf of the National TB Program, and in particular, Director of the Institute of Pulmonology, Uzbekistan, Madame Perpiva Nargiza, who is currently couldn't participate personally, but kindly requested me to express great thanks to all the participants of this conference. On my behalf and my project and people who are involved in the preparation of this project, I would like to thank the Ministry of Health of Uzbekistan for this wonderful reception. And despite the conference was remote, we felt very good support from the Ministry of Health. And we felt that the dialogue happened in spite the majority of moderators and speakers were outside of the region and in different parts of the world, including Australia, US, and all the continents of our planet. We also express thanks to the US Embassy, USAID, its mission in Uzbekistan, of course, German Development Bank, Stop TB Partnership, and many, many others, thanks to whom this event has been organized. Thanks a lot to all the speakers and presenters, and thanks a lot to translators, as we had to catch up with the agenda and timing, and we have completed all the work in time. Dear colleagues, I also would like to remind you that although we're now closing our conference on Monday, we have the third day as a continuation of this conference, where we will be looking at Kyrgyzstan experience in reforming healthcare system, and especially public finance of healthcare sector, along with the TB services. This will be a virtual tour. So we have disseminated all the links, and we hope that you will be active, and this day will be interesting to you as well. All the presentations will be distributed, and you will also be able to continue to observe the live stream in YouTube. With this, dear colleagues, I would like to finalize our day, our 2 days conference. We still have the third day ahead of us. Wish you all success, health, well-being, and I truly hope that next year we will continue this meeting in physical exchange. Thanks a lot to everyone, and have a good day.